So good morning everyone. Hopefully all of you are doing well. Please let me know in the chat box if the audio visuals are clear ones. Thank you so much. Chalo. So shall we begin? Let's begin now. So today's first topic is going to be esophageal cancer, beta. So today our target would be to complete GIT at least, okay? Till appendix most likely, or till pancreas, whatever is possible. Let's see. Okay. Now if I talk about beta esophageal cancer, now we know beta the normally esophagus is lined by the stratified squamous epithelium. That's the reason, but obviously the more common type of esophageal cancer has to be the squamous cell carcinoma. But yes, yesterday I've told you at the last that even a adenocarcinoma is possible in the esophagus. Why? Because we know if a patient is having a long-standing GERD beta, due to that the patient will have Barrett's esophagus, where the stratified squamous epithelium changes into the columnar epithelium, and from there if the cancer arises, that will be an adenocarcinoma of the esophagus, right? So if I talk about beta squamous cell carcinoma and adenocarcinoma, do remember squamous cell carcinoma is the most common esophageal cancer worldwide, as well as it is the most common esophageal cancer in India beta. Okay, so worldwide पूछे India पूछे, the answer has to be same. But बच्चे, if they ask you the most common esophageal cancer in the Western world means usually the countries like USA, UK, okay, usually in these countries definitely beta the chances of adenocarcinoma are slightly higher. Reason beta the cases of GERD are more, and it's because of the lifestyle habits, okay, or the food habits. Okay. Now if I talk about beta, what is going to be the most common site? Yeah, Ratna, squamous cell carcinoma is going to be beta more commonly seen in the middle one third of the esophagus. Okay, squamous cell carcinoma is more common in the middle one third of the esophagus. On the other hand, adenocarcinoma is more common in the lower one third. That has to be remembered. Now, if they ask you, beta, why adenocarcinoma is more common in the lower one third, we discussed yesterday, because if there is GERD, beta, the reflux of acid will happen in the lower part of the esophagus. That is the reason the metaplasia will be seen in lower part itself. Okay? That's the reason. If they ask you about risk factors, beta, the first thing that you have to remember, those sarkari risk factors, beta, as I always say for all the cancers, and those are going to be common for even a squamous or an adenocarcinoma, beta, and those are going to be smoking and alcohol. So smoking and alcohol beta will be a common risk factor for both the cancers. Now, individual risk factors for each cancer beta. Now let's see. First of all, for squamous cell carcinoma, bache, squamous cell carcinoma के लिए the first risk factor is achalasia cardia. Yesterday I've told you what is achalasia cardia. When the lower esophageal sphincter of a patient is not able to relax at all, beta, that condition is what is known as achalasia cardia. Now in this condition, what will happen, beta? The lower part of the esophagus is contracted. That's the reason all the food collects in the middle and the upper part of the esophagus, bache, and that's the reason the patient will develop cancer in the middle or upper part of the esophagus. That is nothing else but squamous cell carcinoma. Next important beta, Zenker's diverticulum. Zenker's can also be a site beta for the squamous cell carcinoma to arise because of that outpouching and collection of food for a longer duration of time. Next important beta is preservative rich or smoked food, basically, right? So preservative rich food definitely. Why? Or smoked food, why? Because beta the preservatives which are there, most of them contain a carcinogen, and that carcinogen is known as nitrosamine. Okay, and that's the reason beta the patient can develop a cancer if the patient is taking too much amount of food which contains preservatives. Okay. Next important is beta next important, if I talk about tylosis palmaris and tylosis plantaris beta, these are the conditions where there is thickening of palm and thickening of soles beta, but along with that the patient will also have an increased risk of cancer. And last is Plummer-Vinson syndrome. You might have discussed this in patho medicine somewhere. So Plummer-Vinson syndrome is also known as Patterson-Kelly-Brown syndrome beta. This Plummer-Vinson syndrome is seen in middle-aged females beta, and there is a classical triad over here, remembered by the mnemonic age. Okay, A for iron deficiency anemia beta. Okay, so which causes koilonychia. Second, G for atrophic glossitis बच्चे, and E for esophageal webs, basically. Okay, esophageal or the post-cricoid webs. As there are esophageal webs beta, from there itself the cancer is going to arise. Okay. Next important, if I talk about in a patient of adenocarcinoma, what are the common risk factors? Obviously, beta, long-standing GERD, as I've told you, and from that long-standing GERD itself, the patient may develop Barrett's esophagus, beta, or even obesity for that matter, or even scleroderma. Now, please remember, beta, scleroderma which is there, okay, that is fibrosis it causes in the muscles and in the skin, beta. So scleroderma mein there can be fibrosis of the lower esophageal sphincter. So now initially when there is fibrosis, when the fibrosis just starts in the lower esophageal sphincter, beta, the lower esophageal sphincter is not able to contract properly, and that's the reason, as the lower esophageal sphincter is not able to contract, the patient will develop GERD, beta. Clear about? Whereas in the later stages of scleroderma, beta, there can be complete fibrosis in the lower part of the esophagus. And when there is complete fibrosis in the lower part of the esophagus, you can see the lower esophageal sphincter gets completely closed. And if the LES gets completely closed now, that will lead to achalasia cardia. Yes. So early stages of scleroderma, beta, can lead to GERD in a patient. Later stages of scleroderma, beta, can lead to achalasia cardia in a patient. Okay, so yaad rakhna. No issues with this, anybody? Now if they ask you, beta, that what will be the clinical features? Obviously, what is going to be the earliest clinical feature, which is the earliest clinical feature, beta, has to be dysphagia, because if there is a mass inside the esophagus, beta, obviously the patient will not be able to swallow properly. Okay, so there will be more dysphagia to solids or liquids, beta. There will be more dysphagia to solids, because liquids at least can pass, beta, even from a narrow lumen, but the solids which are there, they will not be able to pass, right? So that is the reason, yaad rakhna hai. If they ask you dysphagia is more for, answer has to be solids. First thing. Second important, the dysphagia will be continuous or intermittent. Here it will be continuous, beta. In Zenkus it was intermittent, right? Here it will be continuous because the mass will always be there, right? So clinical features, if they ask you, beta, answer has to be a progressive dysphagia, beta. Progressive, why? Because it will keep on increasing, na. Size of mass will keep on increasing, and that's the reason the dysphagia will keep on getting more and more severe. So the patient has a progressive dysphagia, beta. Okay, and as I've told you, the progressive dysphagia which is seen, it is mainly seen for the solids as compared to liquids. Now, here two important things, beta. As they say, progressive dysphagia and continuous dysphagia, this differentiates esophageal cancer from Zenker's diverticulum, beta. First thing. Second, as it says, the esophageal, as the dysphagia is going to be more for solids, this one actually differentiates from achalasia cardia, because in achalasia cardia the dysphagia is going to be more for liquids. That has to be remembered. Okay. Now, when the cancer spreads outside the esophagus, beta, then what will be the problem? So when the cancer spreads outside the esophagus, it is always called as an advanced cancer. And in advanced cancer, beta, we know definitely the patient may have hoarseness of voice. Now, what is the logic behind hoarseness of voice, beta? So when the cancer spreads outside the esophagus, there can be involvement of the RLN. What is RLN? The recurrent laryngeal nerve. And due to involvement of the recurrent laryngeal nerve, the patient may have hoarseness of voice, beta. Next, the patient may also develop a chronic cough, beta. Now, why there is a chronic cough basically? So please remember, as the cancer spreads outside the esophagus, beta, as the cancer spreads outside the esophagus, there can actually be seen. This is the esophagus. Here we have the cancer. Now the cancer is spreading outside the esophagus, and it can spread, beta, anteriorly to the trachea also, right? It can spread anteriorly to the trachea. So there can actually be formation of a fistula, beta, between the trachea and the esophagus. And if there is a malignant tracheoesophageal fistula which forms, obviously the secretions from the esophagus will enter inside the trachea, and as these secretions will keep on entering inside the trachea, beta, patient will keep on getting a lot of cough reflex. Okay, so that is important. So chronic cough ho sakta hai in a patient of esophageal cancer, which is, and that chronic cough which is there in a patient of esophageal cancer, what is the reason for that? It is due to development of a malignant tracheoesophageal fistula, beta. It was the development of the malignant tracheoesophageal fistula. Great, all of you. Apart from that, definitely, beta, the other symptoms, like if there is involvement of trachea, obviously, beta, the patient is going to have difficulty in breathing, that is dyspnea. There can be noisy breathing known as stridor, and the patient may have weight loss also. Please remember the two cancers of the body which actually shows maximum weight loss or a severe cachexia. One is definitely going to be esophageal cancer, beta. The other one is going to be stomach cancer. Reason here, the weight loss does not only happen because of the cancer, beta, but the second reason being, as there is a mass over here, the patient is not able to swallow also properly, beta. There is dysphagia, and that's the reason the patient's appetite is going to be lesser, and that's another reason why the patient will have a weight loss. Okay. Now, if I talk about, beta, the TNM staging, you have to remember one thing. that T and M staging we know, that tumor, nodal, and the distant metastasis staging we have to do. But I have told you, beta, the T staging or the tumor staging is based on various parameters, like either the size of the tumor or based on the number of structures involved or the depth of invasion. याद रखना है henceforth that in all the GIT cancers, beta, whether it is the esophageal cancer or up to the anal cancer, beta, in all the GIT cancers, bache, do remember that the T staging or the tumor staging is best based on depth of invasion. How deep the cancer is inside the wall. That is, there is involvement of mucosa, submucosa, muscular serosa, right? So likewise, तो याद रखना है बेटा, this was a July 2023 question, याद रखो. So tumor staging, they have asked that tumor staging in GIT cancers is basically based on which parameter. So you have to remember it is based on the depth of invasion, beta. No issues with this. Next important, if I talk about now, based on this itself, beta, you can classify the tumor like, see over here, T1 matlab till submucosa, that is mucosal and submucosal involvement will be T1. Okay, T2 matlab involvement of the muscularis there, beta. T3 matlab involvement of the adventitia. Now yes, we do not have serosa in the esophagus, that's the reason. T3 matlab till adventitia. And T4, when the cancer spreads outside the esophagus, that means involvement of the adjacent organs, bache. Now if they ask you definitely that what is going to be the most common site of distant metastasis, yaad rakhna, again in all the GIT cancers, beta, okay, in all GIT cancers, the most common site of distant metastasis will always be the bechara liver. So wherever I ask you the most common site of distant metastasis in GIT, the answer is usually liver. Okay, no issues with this. That is important. Next important beta, if I talk about is this classification, beta, this is basically called as the Sievert's classification of the esophageal cancer. And if I talk about the Sievert's classification of the esophageal cancer, bache, according to the Sievert's classification of the esophageal cancer, in the lower part of the esophagus, beta, it is actually classified into three zones. Yes, the lower esophageal cancers could be classified into three zones, beta. Kya ye three zones? Understand. The type 1, which is there, beta, the type 1 esophageal cancer is going to be 1 centimeter proximal to 5 centimeter proximal to the gastroesophageal junction. या anatomical cardia जो लिखा है ना, this is what is your gastroesophageal junction. ठीक है? So here you are able to see type 1 means the cancer is 1 centimeter to 5 centimeters proximal to the gastroesophageal junction. Next important is बच्चे type 2. Type 2 में you can see definitely it is 1 centimeter proximal, okay, 1 centimeter proximal and 2 centimeters distal, beta. So when the cancer is going to be 1 centimeter proximal and 2 centimeters distal from the gastroesophageal junction, that is called as type 2. Type 3, which is there, बच्चे, it is 2 to 5 centimeters distal from the gastroesophageal junction. अगर 2 से 5 सेंटीमीटर आगे है, okay, so if it is 2 to 5 centimeters distal from the gastroesophageal junction, beta, that is what is called as type 3 esophageal cancer. Now you will be like, sir, why this is important? Reason, beta, this type 3, which is there, the green zone that you are able to see, okay, the type 3 esophageal cancer which is there, beta, it should be treated as a gastric cancer itself. Okay, this is a type 3 esophageal cancer which that should be treated basically as a gastric cancer. No issues with this, anybody? That has to be remembered. No issues. Clear hai? Now when we have to do a diagnosis of the patient, beta, so for that definitely we can go for a barium swallow, right? Here you are able to see, beta, this one investigation which is given over here. Okay, the barium is basically, the barium sulfate solution is traveling via the esophagus and we have taken an X-ray so that the esophagus appears to be highlighted. And then we are able to see, beta, that what is the problem? Here you are able to see, beta, there is a filling defect, right? There is a filling defect over here. Yes. So yaad rakhna, barium will not be taken up at two sides, beta. First, wherever there is a mass, and second, wherever there is an ulcer, beta. So obviously here you are able to see there is a mass, and that's the reason, beta, the barium is not taken up over here, and this is classically called as the filling defects, beta. Now apart from the filling defects, if I talk about, beta, what is another important feature, and that is going to be, okay, that is going to be this one, beta. What is seen over here? Now for example, this is how the cancer is, okay, on from all over the wall, beta. So definitely the lumen of the esophagus over here in the lower part is going to become very, very narrow, and as the lumen in the lower part becomes very narrow, beta, that's the reason we are able to get a very classical appearance. What is that appearance called as? What is that appearance called as in esophageal cancer? So do remember, beta, this narrowed appearance which is there, it is classically referred to as the rat tail appearance. Okay, You'll classically call it as the rat tail appearance. Now a lot of faculties do tend to call it as no. A lot of faculties do tend to call it as bird beak also as an alternative term. वैसे bird beak is more commonly seen in Achalasia cardia, ठीक है? But I strictly don't use the term rat tail and bird beak as an alternative terms. The logic being, understand, rat tail जो होता है बेटा appearance, it is something like this, right? You can see there are irregular or shaggy borders बेटा, ठीक है? And the narrowing which is there बेटा, it is going to be gradual over here, ठीक है? धीरे धीरे करके narrowing होती है. And secondly, shaggy borders are seen. This is what is a rat tail ना. Which bird beak you have seen like this ऐसे टेढ़ी मेढ़ी बेटा? No bird beak will be like टेढ़ी मेढ़ी ना. So definitely बेटा bird beak appearance जब बोलते हैं, it is basically a sharp margins बेटा, sharp regular margins which are there, those are called, that is called as a bird beak appearance. Second important beta, over there is a sudden narrowing. That sudden narrowing which is seen beta, it looks like the shoulder, that is called as the shouldering effect beta. Okay, so sharp margins with definitely a sudden narrowing is what is called the shouldering effect. That is what is a Achalasia cardiaca bird beak appearance. Here you will only call it as rat tail beta. Okay, so that's the reason rat tail will have irregular shaggy margins. Okay, अभी clear है, कोई दिक्कत? It is Sievert's classification beta. It is a Sievert's classification. चलो, no issues with this. Now let's talk about what is the investigation of choice. If I talk about investigation of choice beta, याद रखना है कि we know that the best investigation for all the cancers is always a biopsy. So here also it is a biopsy, but just to take the biopsy we have to do an upper GI endoscopy beta. ठीक है, so investigation of choice which is there बच्चे, it is nothing else but an upper GI endoscopy plus biopsy. We can go for an upper GI endoscopy plus biopsy. Next important, if they ask you what is the investigation of choice for distant metastasis, you already know beta that the investigation of choice for distant metastasis we have discussed in breast cancer also, right? The investigation of choice for distant metastasis is a whole body scan beta known as the PET scan. I hope all of you are quite aware about the contrast, that is 18 FDG fluorodeoxyglucose, half-life being 110 minutes, right? Now if they ask you definitely beta what is the investigation of choice for TNN staging, this is somewhat different beta, and ये याद रखना अच्छे से. Okay, now when we have to do only a tumor and a nodal staging beta, we have to see how deep the cancer is and how many lymph nodes are involved in the surrounding. What we do beta in esophageal cancer or even in a gastric cancer for that matter, we pass an ultrasound probe beta, okay, with along with an endoscopy we pass an ultrasound probe, and that ultrasound probe goes inside the esophagus beta, and then it will actually tell us. We know na ultrasound is very good for superficial structures. So what we have done, we have sent the ultrasound inside itself, so that now it is able to tell us beta that how many layers of the esophageal wall have been involved, right? How many lymph nodes in the surrounding will be involved. That is important beta, and that is called as an endoscopic ultrasound. So याद रखना है बच्चे that if they ask you what is the investigation of choice for tumor and nodal staging in esophageal or gastric cancer, answer has to be an endoscopic ultrasound, as this is somewhat different, therefore this has been a question. याद रखना. Next important beta, if they ask you what is the investigation of choice for TNM staging, overall TNM अगर करना है, so when they say TNM, that is overall staging beta, for M, that is distant metastasis, we have to do a PET scan, and for the local tumor we can go for a CT scan beta. So PET CT will be the overall investigation of choice beta for the TNM staging. Now if they ask you what is the treatment बच्चे, we know the treatment has to be what? Treatment has to be beta esophagectomy, that is removal of the esophagus, right, with some normal margins. So treatment which is there beta, it has to be esophagectomy itself. Now if they ask you sir how much should be the margins for esophagectomy beta, ठीक है, कितने margins होने चाहिए esophagectomy करते वक्त, तो please remember beta the esophageal cancer which is there beta, it spreads too much in the wall in upward or a downward fashion, ठीक है. That's the reason beta when I say esophagectomy in a patient of a esophageal cancer, so याद रखना the margins that we take beta, the margins that we take are going to be proximal 10 centimeters and distal 5 centimeters. The usual margin that we take for any cancer is around 1 to 2 centimeter, right? But esophageal cancer के लिए it is proximal 10 and distal 5 centimeters beta, that has to be remembered. No issues with this. Here beta, please remember along with esophagectomy I am writing plus minus, we have to do a lymph node dissection beta, right? Obviously if the lymph nodes are involved beta, we have to go for the lymph node dissection also. Now the question could be that how many are the minimum lymph nodes to be removed during a lymph node dissection in a esophageal cancer. So if they ask you beta the minimum number of lymph nodes to be removed beta, okay, minimum number of lymph nodes to be removed in a esophageal cancer, they have to be how much? minimum they should be 15 beta. We have discussed in breast cancer now, there are minimum 10 lymph nodes to be removed during an axillary lymph node dissection. But in a esophageal cancer, the minimum number of lymph nodes to be removed will be 15 in number beta. याद रखना ये बात, ठीक है? Gastric cancer has the maximum one, that is 16. Colorectal cancer has 12. ठीक है? Now let's talk about the various types of esophagectomy beta. तो जो esophagectomy है depends on the involvement, that which part of the esophagus is involved. The main aim of the surgery is same. You have to remove the esophagus with some normal margins, with or without lymph node dissection. Okay, but the name of the esophagectomies are different, and the incisions that we make and the anastomosis that we make will be different. Okay, you just have to remember the name. That's more than enough. So yaad rakhna, if they say if there is any cancer in the upper 1/3 of the esophagus, beta, any cancer in the upper 1/3 of the esophagus, then the surgery that we usually do, beta, is known as the McKeown surgery or the McKeown's esophagectomy, beta. Now, important is yaad rakhna, this McKeown's esophagectomy which is there, the McKeown surgery which is there, beta, it is not only done for the upper 1/3, it is also done for the upper 2/3, beta. Yes, मतलब upper 1/3 and middle 1/3 दोनों में अगर कैंसर होगा बेटा, then we can go for a McKeown's esophagectomy or a McKeown surgery, no issues with that. ठीक है, it is rather a preferred surgery. Next important, if they ask you only in the middle 1/3 if there is a cancer, beta, only in the middle 1/3 if there is going to be a cancer, then what is the surgery of choice? Then please remember बच्चे, the surgery of choice is known as the Ivor-Lewis operation. ठीक है, so Ivor-Lewis esophagectomy or the Ivor-Lewis operation which is there, it is the surgery of choice basically for the middle 1/3 esophageal cancer. ठीक है, and last one if I talk about beta is the lower 1/3 of esophagus. If lower 1/3 of esophagus में there is a cancer, then we can go for a Oringer surgery beta or Oringer esophagectomy, and in this Oringer surgery it is also known as a transhiatal esophagectomy. Oringer is also known as a transhiatal esophagectomy. Clear है? Remember the names of the surgery. Now once you have removed the esophagus beta, obviously now we have to reconstruct the esophagus. Now there's a lot of gap. Now how do we reconstruct the esophagus? So please remember बच्चे, reconstruction of the esophagus which is there beta, reconstruction of the esophagus is usually done by using the gastric tube beta. Okay, याद रखना, reconstruction of the esophagus is usually done by using the gastric tube. You'll be like, sir, why, and how? So please remember beta, see, you cannot pull the entire stomach upwards now. So what we do, we actually cut out this part of the stomach beta. Okay, once you are going to cut out this part of the stomach, what is going to happen, we'll get a tissue and then we are going to make beta a tube out of it, right? When definitely we have cut out this part of the stomach, basically what we have done, we have made a tube out of it beta, and now that tube which is there beta, it will be used for the reconstruction. That tube will be placed over here, clear about, and this will be closed, right? So what we do, definitely, can you see, we have taken some part of the stomach beta and we have made a gastric tube out of it, and now this gastric tube will be placed instead of the esophagus beta. That is what is made, clear about. Chalo. Now if they ask you beta that what is the complications of surgery, so yaad rakhna beta, if they ask you that the complication of the surgery would be, the most common complication of the surgery beta is nothing else but atelectasis. Now what is atelectasis beta? Atelectasis is nothing else but lung collapse bache. Okay, atelectasis or lung collapse which is there beta, it is not only a common complication seen after this surgery, it could be a common complication seen after most of the surgeries which could be done under GA, that is general anesthesia. Reason beta, what happens is, if you do a surgery under GA beta, the patient's cough reflex which is there, it gets suppressed, and that's the reason beta, the mucus which is there, it is not able to clear up from the airway, and that's the reason beta, there is definitely a lot of mucus which keeps on collecting in the patient's airway bache. And if the airways of the patient would get completely blocked, almost beta, if the airway of the patient gets completely blocked, that is going to cause collapse of the lung beta, known as atelectasis. That's the reason you might have seen that whenever a patient undergoes a major surgery beta under general anesthesia, what we do basically, we usually go to them every round beta. On every round we pat their back beta. ये क्या करते हैं हम, definitely this is called as a chest physiotherapy. Why do we give chest physiotherapy? Because we do not want that mucus to stay collected over there and block the airways beta. Okay, to clear that mucus, definitely we do it. So that is what is done beta. So अगर prevention करना है, if you do not want atelectasis to happen after a major surgery, then always give chest physiotherapy to your patient beta. First thing is that. Second thing beta, apart from giving chest physiotherapy, is You might have seen beta that respirometer. Usually, what is that respirometer? It has basically three balloons inside it, sorry, three balls inside it beta. Okay, and there is a tube to it. So what the patient is asked to do, the patient is asked to blow air inside that tube beta, and he is asked to lift up the balls. Okay, उसको उसमें हवा फूकनी होती है और वो बॉल उठाने होते हैं. Please remember beta that initially the patient may not be able to lift up any ball, but slowly as we keep on practicing beta, obviously the balls will get lifted up. Actually that prevents the lung collapse or the atelectasis in the patient. Clear है बात? Now if they ask you beta, sorry, what is the most common long term complication? तो याद रखना है बेटा, most common long term complication is nothing else but strictures. I've told you beta, wherever you make an anastomosis, there can be a possibility that over there beta there can be fibrosis and it can lead to formation of strictures at that particular site. ठीक है. Next important beta, if they ask you what is going to be the most common cause of death, तो याद रखना है बेटा, most common cause of death after esophagectomy or after esophageal surgery is going to be beta an anastomotic leak. Reason is, if there is an anastomotic leak beta, what is going to happen? As I've told you, all the secretions beta, everything is going to leak out into the mediastinum. Just like peritoneum beta, the mediastinum is also a sterile cavity, and that's the reason beta the patient may develop mediastinitis, which can land up the patient into sepsis beta. Okay, which can land up the patient into sepsis, and that can be the reason for the patient's death. ठीक है, so anastomotic leak is the most common cause of death after esophagectomy surgery. No issues with this. That is important. Now, if I talk about beta, the Sievert's classification type 3, we have discussed that type 3 Sievert's which is there, that is the cancer which is 2 to 5 centimeter, or you can say cancer which is more than 2 centimeter distal to the gastroesophageal junction beta. Okay, cancer which is more than 2 centimeter distal to the gastroesophageal junction बच्चे. I've told you it is treated as a esophageal or a gastric cancer. You have to remember it is treated as a gastric cancer beta. ठीक है, that is important. Next important if I talk about is the chemotherapy. We told you beta that chemotherapy is usually given when the lymph nodes of the patient will be positive. Okay, and याद रखना chemotherapy के लिए in a GIT cancer basically beta there are two sarkari drugs that I've told you beta. One is going to be cisplatin बच्चे, the second is going to be 5-fluorouracil beta, and the third one which is used only in esophageal cancer more commonly is known as gemcitabine. So these are the common drugs beta which are used for the chemotherapy in a patient of esophageal cancer. Next important if I talk about bachche is radiotherapy. We know beta radiotherapy will also be given after the surgery beta to prevent what? To prevent the recurrence bachche. To prevent the recurrence. Now let's talk about beta esophageal perforation. Now when I talk about esophageal perforation beta, याद रखना है that esophageal perforation beta is more commonly, okay, is it more commonly iatrogenic or is it spontaneous? That is important to be remembered. Now okay, iatrogenic मतलब due to our fault beta, and spontaneous मतलब अपने आप. ठीक है, so which kind of esophageal perforation do you think will be more common? Will it be iatrogenic or will it be spontaneous beta? Very good. The more common type of esophageal perforation beta is going to be iatrogenic beta. Yes, more commonly it is iatrogenic beta. And iatrogenic during which surgery beta? We know definitely iatrogenic during endoscopy, right? When you are performing a endoscopy beta, during that time, as I've told you beta, if you're not careful at the anatomical constructions of the esophagus beta, okay, that can definitely lead to a iatrogenic esophageal perforation. Okay, so that is important. So more commonly it is iatrogenic beta, the esophageal perforation. And if they ask you during which procedure, so we need to know during the endoscopy. If they ask you beta, which is the most common site, can anybody tell me which is the most common site? The upper 1/3, middle 1/3, lower 1/3. कौन सी साइड सबसे ज्यादा कॉमन होगी iatrogenic के लिए? Upper 1/3 beta. The logic and the reason being why we have upper 1/3 में क्या होता है? Cricopharyngeal sphincter, and I have told you yesterday itself beta that cricopharyngeal sphincter is considered as the narrowest portion of the whole GIT beta. Okay, so that's the reason upper one third which is there is going to be the most common site for the esophageal perforation, which is iatrogenic in nature. ठीक है, तो iatrogenic में it is upper one third, spontaneous में it will be lower one third. ठीक है, so that is important. Next important, if they ask you beta what will be the complaint, as the esophagus has perforated, the patient will have chest pain. Along with that beta, sometimes the patient may complain of abdominal pain also. Investigation of choice अगर करेंगे बेटा तो याद रखना है, investigation of choice is nothing else but again बेटा a CT with oral contrast has to be there. ठीक है, a CT with oral contrast has to be done beta, that has to be remembered. Now when I do a CT with oral contrast or a CECT you can write, that's fine. So CECT लिख लो, CT with oral contrast लिख लो. Please remember here, as I've told you beta, as there is a perforation, so what will happen, the contrast that we are going to give beta, it is going to leak out via the perforated part beta into the mediastinum. We should not use some contrast like barium over here, because barium is going to increase the inflammation further. That's the reason beta we should use some water soluble contrast, something like beta gastrographin can be used or iohexol can be used. Okay, even dinosol for that matter could be used. These are the contrast beta that can be used definitely for a perforation wala case. Okay, so that is important. Now if they ask you how do you manage the patient beta, so yaad rakhna, if there is a small perforation itself, beta, that means when the patient is having no sepsis at all. Okay, when there is a small perforation, the patient is having no sepsis beta, or the patient appears to be stable, then we should go for a conservative or surgical management. Obviously if there is small perforation, no chances of sepsis and stable patient beta, then obviously beta here we can go for a conservative management beta. Here we can definitely go for a conservative management. What is conservative management? Definitely beta, we are definitely going to just give analgesics to the patient, IV antibiotics to the patient beta. We can sorry, definitely give beta IV fluids to the patient. Okay, so that is what is done beta. We have to keep the patient on a conservative management, that has to be remembered. Now if it is a large perforation, then we have to go for a surgical management beta. Okay, so if there's a large perforation, there can be more chances of sepsis in the patient, that has to be remembered. Now important is, yaad rakh lo, if it is a large perforation, we have to repair it basically, right? And the repair can be done by various ways beta. Please remember, even if it is a large perforation beta, the chances of contamination will be lesser. Reason the chances of contamination will be less, because beta here this perforation has happened during endoscopy, and I hope all of you are quite aware that for the endoscopy beta your patient was well prepared, right? Your patient would be kept NPO or near peroral. That's the reason beta here the spillage is not going to be there, and that's the reason beta here you can definitely say that even if there is a large perforation, the contamination is not going to be gross like a spontaneous one. Okay, so what we have to do over here, either I can go for some endoscopic management beta. Okay, I can go for an endoscopic management over here, and that endoscopic management which is there beta, whether for a small perforation or a large perforation beta, we can go for endoscopic management. Like we can definitely apply clips beta over here. Okay, or apart from applying endoscopic clips beta, you can even go for an anastomosis over the T tubes beta. Okay, you can actually perform an open surgery, and that is nothing else but anastomosis over the T tube has to be done. The repair which is done beta, it is nothing else but an anastomosis over the T tube beta. Now when I talk about an anastomosis over the T tube, what is that? Definitely understand over here, this is the esophagus beta. Okay, this is the esophagus. You have to repair the esophagus, and while you are repairing the esophagus, you can insert a T tube inside the esophagus beta. You can definitely insert a T tube. Reason is, once you have repaired the esophagus beta, the suture should not come in contact with the food and everything beta. Okay, the food can pass definitely via the T tube. The suture should not come in contact with them. Okay, so that is important to be remembered. No issues with this, so that is important. Small perforation है तो mainly conservative management. If the patient's perforation does not heal, then we may go for endoscopic clips वगैरह. In large perforation beta, when there is sepsis in the patient, either I can try endoscopic clip, but usually large perforations में that may not be possible, so you have to do a thoracotomy, that is open the chest, and you have to go for a anastomosis over the T tube. Clear about that? Is important. Next is important condition beta, and that is nothing else but a spontaneous esophageal perforation. If I talk about that spontaneous esophageal perforation beta, that is nothing else but called as the Boerhaave syndrome beta. That is what is known as a Boerhaave syndrome. Now when I talk about Boerhaave syndrome, here what happens, a classical history beta. Understand, patient is a known alcoholic. Now the patient had a binge drinking episode beta. What is binge drinking? Drinking a lot of alcohol beta in a very short duration of time, or definitely binge eating episode beta. ओके सर दैट मीन्स ईटिंग अ लॉट डेफिनेटली, ठीक है, जब पेशेंट बहुत ज्यादा पी लेता है या बहुत ज्यादा खा लेता है इन अ वेरी शॉर्ट ड्यूरेशन डेफिनेटली बेटा, ठीक है. सो दैट इज व्हाट इज कॉल्ड एज बिंज ड्रिंकिंग और बिंज ईटिंग. After that, obviously, beta, what the patient is going to have? After that, the patient is going to have a very severe vomiting, beta, right? So after that, as the patient has vomiting or retching means nothing comes out, beta, okay, during the vomiters. So please remember, beta, either retching or vomiting episodes will be there, and whenever there is retching or vomiting, the pressure inside the esophagus increases too much, and if there is increased intraesophageal pressure, beta, that can actually cause a tear or a rupture in the esophagus, beta. So we know that during vomiting, beta, the pressure starts from the gastroesophageal junction or the lower part of the esophagus. That's the reason, beta, in the lower part of the esophagus, due to excessive pressure, beta, you are able to see a complete tear, beta. Yes, because if it is a partial tear, then that condition is known as a malarious tear, beta. तो अगर बस अंदर वाले लेयर्स में टीयर है, दैट इज म्यूकोजल एंड सबम्यूकोजल पार्शियल टीयर है, so then that condition is a malarious tear, beta, which will only present you with bleeding. But if there is a complete tear, beta, then this is what is called as a rupture of the esophagus or a spontaneous esophageal perforation, and that is what is known as a Boerhaave syndrome. Clear hai? But that is important. So Boerhaave syndrome is nothing else but a spontaneous, okay, it is a spontaneous esophageal perforation, beta, and the spontaneous esophageal perforation which is there, bache, it is due to the forceful vomiting against a closed glottis, okay. So against a closed glottis, if you are going to have a forceful vomiting, the pressure in the esophagus is going to be extremely high. Now, if they ask you what is the most common site, I've already told you, beta, for a case of Boerhaave syndrome or spontaneous perforation, the perforation which is there, it is more commonly seen, beta, in the lower 1/3 of the esophagus, right? It is more commonly seen in the lower 1/3 of esophagus. Where exactly? Near the gastroesophageal junction. Okay, near the gastroesophageal junction, beta. So more common site is going to be the lower 1/3. If they ask you where it is seen, we have discussed already, it is seen in chronic alcoholics, beta, but only after a binge drinking episode. Okay. Next important, it can also be seen in another condition, beta, which is a psychiatric eating disorder known as bulimia nervosa. What is seen in bulimia nervosa? These patients eat a lot of food, beta, in a short duration, and then they try to do purging, beta. What is purging? Basically, they try to bring out all that food by vomiting, and due to that, they can have a risk of Boerhaave syndrome. Or females who are pregnant, beta, that is a condition known as hyperemesis gravidarum, that is excessive or a severe morning sickness. In bulimia and hyperemesis, beta, in both these conditions, the Boerhaave syndrome is going to be rare. More commonly, it is going to be seen in alcoholics after binge drinking episode. Okay, that is important. So the case which is there, beta, in your examination will classically start as what, beta? The case will classically start as, we have an alcoholic patient, and that alcoholic patient recently had a or recently did a binge drinking, and after that binge drinking बोल सकते हैं, binge eating बोल सकते हैं, right? So that alcoholic patient did a binge drinking, and after which the patient started experiencing severe retching and vomiting episodes, beta. There was severe retching or vomiting episodes, okay. And now definitely the patient comes to your emergency, beta, with the complaints of chest pain, severe vomiting, subcutaneous emphysema, beta. Okay, so all of these features together, these three features together in a patient of Boerhaave syndrome, beta, it's classically called as which triad, beta? So yaad rakhna, it is classically known as the macular striaid, which is, this is classically known as the macular striaid. Yaad rakhna ye naam. Okay, no issues with this. The macular striaid, if I talk about, beta, in a case of bulimia, in a case of Boerhaave syndrome, beta, the macular striaid in patients of Boerhaave syndrome is classically remembered by the mnemonic, beta, CVS. Okay, the mnemonic to remember it is known as CVS, beta. Now CVS क्या होता है? C stands for chest pain, beta. Why there will be chest pain? See, if the esophagus was perforated, beta, now the patient was not ready, na? He was not undergoing endoscopy. That's the reason, beta. All the secretions, all the food, alcohol, everything will go into the mediastinum of the patient. And as that goes into the mediastinum, there will be a severe inflammation of the mediastinum, beta, known as mediastinitis. So this chest pain which is there, beta, it is basically due to mediastinitis. And this chest pain is so severe, beta, that it almost mimics a myocardial infarction. Yes, it looks like a MI जैसा pain होता है, beta, patient में. That is important to be remembered. Okay, that's the reason when the patient presents to us in the emergency, one of the first line investigations that we do is definitely ACG followed by a chest X-ray. Okay, that is important. Next important, V stands for what? V stands for there should be a history of vomiting or retching, beta. Without a history of vomiting or retching or binge drinking, you should not call it as Boerhaave. Okay. Next important, S stands for what? Subcutaneous emphysema. Because if the esophagus have perforated beta, obviously a gas or air also goes outside the esophagus, and all that gas goes two sides pe beta. One, it goes into the mediastinum, causing a pneumomediastinum. Second, it goes and collects below the skin beta. So when the gas goes and collects below the skin, that is what is called as a subcutaneous emphysema beta. How do you suspect a subcutaneous emphysema? So when the patient is going to have a subcutaneous emphysema, which is here, definitely when I palpate the chest, basically wherever there is subcutaneous emphysema, now when I palpate that side beta, I will be able to get a crackling sound beta, and that crackling sound is what is classically called as the crepitus. Okay, so instead of writing the subcutaneous emphysema beta, they can say definitely there was a crepitus on palpation. So yaad rakhna, crepitus on palpation is suggestive of subcutaneous emphysema itself. Okay, so macular striate can be remembered with the mnemonic, that is CVS, C for chest pain, V for vomiting, S for subcutaneous emphysema. Done with this, that is important. Next important beta, if I talk about, is pneumomediastinum. I told you now that when the esophagus will undergo perforation, the air will also go, or the gas will also go into the patient's mediastinal cavity. That is called as pneumomediastinum. Now pneumomediastinum ki wajah se beta, I will be able to go get two findings beta. First is on auscultation and second is on a chest x-ray. Now if I do a auscultation of this patient beta, on auscultation you will be able to get a very classical finding. And what is that? That when you auscultate the chest of the patient beta, you will get a sound as if somebody is wearing leather boots beta and walking on the snow. कोई leather boots पहन के snow पे चल रहा है तो कैसा crunching sound आता है. The similar crunching kind of a sound beta you will be able to hear on auscultation, and this crunching sound on auscultation is classically called as the Hammond crunch sign. तो याद रखना, auscultation पे Hammond crunch sign, or you can call it as leather boots on snow. You can write that in bracket also beta, leather boots on snow. ठीक है, तो Hammond crunch sign या leather boots on snow which is there beta, this is very very classical in a patient of pneumomediastinum, and that pneumomediastinum can happen after Borhave syndrome beta. ठीक है, so that is important. Metabolic alkalosis, alcohol क्या लिखा है, या दे कैन एक्सपीरियंस, मतलब क्रॉनिक वॉमिटिंग की वजह से बोल रहा हूँ, यस दे कैन एक्सपीरियंस डेफिनेटली मेटाबॉलिक अल्कलोसिस. यस ऑब्वियस है. तो pneumomediastinum beta on auscultation definitely Hammond crunch sign will be heard. Second important thing beta, here you are able to see a chest x-ray, and if I talk about a chest x-ray बच्चे, तो please remember definitely beta, chest x-ray पे there is a very classical finding. See, normally beta we are not able to see any black shadow below the heart. Here are you able to see this black line below the heart? Yes, and that black line is basically due to the collection of air in the mediastinum or below the heart beta, and this is classically called as what? It doesn't look like as if the diaphragm is continuous over here, right? This black line is actually connecting both the domes of diaphragm. That's the reason beta this is classically called as the continuous diaphragm sign. This is another sign for pneumomediastinum beta that you have to remember. ठीक है, तो pneumomediastinum कैसे पता चलता है? One, definitely on auscultation will get the Hammond crunch sign. Second beta, on the chest x-ray you are able to get a continuous diaphragm sign. These are the two important findings beta in the patient of Borhave syndrome, okay, due to pneumomediastinum. Next important, if they ask you beta that what is the investigation of choice, so investigation of choice is again CT with oral contrast, right, or a CECT, whatever you want to write beta. So CECT chest लिख लो या CT with oral contrast लिख लो, that's fine with me, no issues with it. ठीक है, चलो, so यहाँ पे CT with oral contrast लिख लो या CECT लिख लो बेटा, it's one and the same thing. ठीक है, CECT is nothing else but a contrast and on CT scan. Obviously CT with oral contrast is the same thing. ठीक है, CECT में a lot of times usually people get confused that we are giving the contrast via the blood vessels. ठीक है, तो इसीलिए I tend to write it as CT with oral contrast. तो CECT ही है वो. The only thing is rather than giving the contrast injectable format में we give it orally. ठीक है, so that definitely wherever the contrast leaks out beta, you are able to see the perforated part, you are able to assess how much is the perforation, okay, and what should be done for the treatment. Now once the patient comes to us beta, what should be the first line management? Anybody यहाँ पे दिख रहे हैं ना साइड में थोड़ा, ठीक है, what should be the first line treatment in the patient? Anybody can tell me in the chat box जल्दी से, what should be the first line treatment in a patient of Borhave syndromes in the emergency? So please remember beta, very good, shabash. So it is going to be the basic resuscitation beta, shabash, because it's more important beta to save the life of a patient first, and then we will go for any kind of surgery or any definitive management beta. The basic resuscitation has to be your primary or your first line management. That is, you have to take care of the patient's airway, breathing, and circulation. I've told you, any patient who is in sepsis or in trauma or after bleeding, okay, in all these patients, beta, you have to do a basic resuscitation first. Now, once you have done a basic resuscitation, let's talk about the definitive management. If I talk about the definitive management in my patient, beta, sorry, what should be done in that condition, beta? We have to do a exploratory thoracotomy now. Okay, so definitely thoracotomy is what we have to open the chest, we have to explore what is the problem, then we have to repair, and then we have to close the chest back again. That is what is called as an exploratory thoracotomy, beta. Along with that, here the mediastinum is inflamed, beta. Okay, and that's the reason we have to clean the mediastinum. So what we will do, we will let in 1 liter of normal saline, beta. We will wait for some time, and then we will aspirate back all the normal saline from the mediastinal cavity. Okay, and that is cleaning of the mediastinum. That is called as mediastinal lavage, जैसे पेरिटोनियम में किया था, similar manner में. ठीक है, तो treatment which is there, बेटा, it has to be an exploratory thoracotomy. It has to be an exploratory thoracotomy, beta, with a mediastinal lavage. Once you definitely go for exploratory thoracotomy with a mediastinal lavage, beta, then we have to decide whether we have to go for an immediate closure of the perforation or a delayed closure of the perforation, beta. ठीक है, whether we have to go for an immediate closure or a delayed closure of the perforation. So that is basically decided, beta, on the time of presentation. That means if my patient has presented to me early, if the patient has presented to me within the 12 hours of perforation, beta, obviously here the contamination or the contamination would have been less, beta, and there is a minimal chance of sepsis, right? So please remember, agar patient jaldi aa jata hai, there is minimal chance of sepsis over here, and the patient would be more likely stable. So in this condition, I can go for a immediate repair, beta, right? I can go for an immediate repair over here. You can immediately go for a repair, beta, and that repair which is done, it is again, beta, an anastomosis which we have to do, and that anastomosis can be done over the T-tube, beta. Clear about? So that this repair that we do, beta, it could be an anastomosis over the T-tube that has to be done, beta. Immediate repair I can do. But please remember, beta, if I talk about if the patient is presented to us late, beta, after 12 hours, okay, so definitely here the contamination would have been more, and if the contamination is more, definitely, beta, the chances of sepsis in the patient will be higher. The chances of sepsis in the patient are higher, and the patient may be unstable also. So if the patient is unstable or there is a high chance of sepsis, beta, I should not go for an immediate repair. Reason, if you go for an immediate repair, beta, those sutures are going to break due to infection. So you have to wait for a few days. You have to keep the patient on antibiotics, let the infection or the inflammation get resolved completely, and then you should go for a delayed repair, beta. ठीक है, तो याद रखना अभी क्या करना है बस. After doing the exploratory thoracotomy and a mediastinal lavage, beta, we just have to leave a drain over there. Okay, the Romovac section drain, right? So we can just leave a drain, and then we can go for a delayed repair later on. Clear है बात बच्चे? So that is important to be remembered. So याद रख लो, exploratory thoracotomy plus a mediastinal lavage is the basic management. After that, whether we have to do an immediate repair or a delayed repair, that depends on the time of presentation, beta. Okay, no issues with this, anybody? So remember all of these important ones, or important points you have to remember, beta. Bohr-Haave syndrome is actually a common question of your examination also. Okay, so now another sarkari question and favorite at most of your examiner, beta, and tumhara sabka bhi, and that is nothing else but a condition known as a motility disorder of esophagus, beta, called as achalasia cardia. Now let us talk about achalasia cardia, beta. Now when I talk about achalasia cardia, what is achalasia cardia? To understand first, beta, here what happens is the lower part of the esophagus which is there, beta, the lower part of the esophagus is not able to relax only. And if the lower part of the esophagus will not relax, beta, will the food be able to pass? No. So please remember, in achalasia cardia, the lower esophageal sphincter or the lower part of the esophagus, it remains in a contracted state. It remains in a state of spasm. It does not relax, and that's the reason food is not able to pass. So क्या हो जाएगा? All the food which is there, beta, it collects in the middle and the upper part of the esophagus, beta. Okay, so that is the problem in case of achalasia cardia. So as there is difficulty in swallowing of the food, that will lead to dysphagia in the patient. Okay, so that condition is achalasia cardia. Now there are various reasons for achalasia cardia. Let's talk about them. So achalasia cardia, as I told you, it is failure of relaxation of the lower esophageal sphincter. Now, the first type of achalasia cardia is called as a primary achalasia cardia. Primary achalasia cardia, which is there, beta, definitely, it is going to be of two types, beta. Okay? It is due to two reasons. So, first of all, beta, we know that if I talk about the esophageal wall, beta, it has four layers in it, right? So, we have the mucosa, we have the submucosa, we have the muscularis, and we have the adventitia. These are the four layers in the wall. Now, I hope all of you are quite aware, beta, that there are two nerve plexuses inside the GIT wall. What are the two nerve plexuses in the GIT wall? The first one is a submucosal nerve plexus, beta. And ये जो submucosal nerve plexus है, that is known as the Meissner's nerve plexus, right? That is important. Whereas second is the muscularis nerve plexus, beta. And this muscularis nerve plexus, which is there, beta, it is known as the myenteric nerve plexus. Myo matlab muscle, right? It is known as the myenteric nerve plexus, beta, also called as the Orbach's nerve plexus. ठीक है, इसी को Orbach's nerve plexus बोलते हैं, right? So please remember, beta, we have a submucosal nerve plexus known as the Meissner's one, where it is going to supply the glands, beta, and it is responsible for secretion. Whereas second one is the myenteric or the Orbach's nerve plexus, beta, which is going to supply the muscles, and it is actually responsible for the motility of the muscles or the peristalsis of the muscle, right? It will actually stimulate the muscles, beta, to perform peristalsis. अब क्या होता है बेटा, in this patient of achalasia cardia, there is actually loss of ganglionic cells from the myenteric or the Orbach's plexus. Now please tell me, if there is going to be loss of ganglionic cells or loss of neurons from the myenteric or the Orbach's plexus, beta, will the muscles of the esophagus get stimulated, beta? No. And as the muscles of the esophagus cannot get stimulated, therefore they are not able to relax, or they are not able to perform the proper peristalsis, beta. And that is what is one of the leading causes of primary achalasia cardia. Okay, so that is important one to be remembered. So याद रखना, primary achalasia cardia, which is there, beta, ठीक है, primary achalasia cardia, it is due to the loss of ganglionic cells, बच्चे. In which plexus? This has been a question, याद रखना है. In which plexus? The answer has to be either the myenteric, or it is also known as the Orbach's nerve plexus, beta. It is loss of ganglionic cells, beta, in the myenteric or the Orbach's nerve plexus. ठीक है, तो याद रखना, इनमें definitely if there is absence of ganglionic cell, that is what is called causing a primary achalasia cardia. Second, primary achalasia cardia can also happen due to another reason, beta. And what is another reason for primary achalasia cardia? It can be due to deficiency of the inhibitory neurotransmitters, beta. What is the function of these inhibitory neurotransmitters in the GIT? These inhibitory neurotransmitters, beta, they will actually help the muscles to relax. ठीक है, तो if there is deficiency of these inhibitory neurotransmitters of GIT, beta, the muscles will not be able to relax. And which are these two inhibitory neurotransmitters? याद रखना है. The first one, this was also been a question. The first one is NO, that is nitric oxide, and the second one is VIP, that is vasoactive intestinal peptide, beta. तो अगर ये दोनों नहीं होंगे, beta, the esophageal muscles in the lower part at least, they are not able to relax, and that is the reason, beta, the patient may develop a primary achalasia cardia. Okay, so that is important. Next important, let's talk about the secondary achalasia cardia. If I talk about the secondary achalasia cardia, beta, तो याद रख लो, it is basically secondary to some other condition or secondary to some other disease, beta. Okay, first condition is known as Chagas disease, beta, which we know is also called as American trypanosomiasis, caused by Trypanosoma cruzi. Okay, this condition which is there, beta, it is known to cause damage to the lower esophagus, and that can actually cause failure of relaxation, beta. And you might have seen in Chagas disease, there is a mega esophagus which develops. This is the reason, because lower part contracted hai, so all the food collects in the upper part, and that leads to extreme dilatation or distension known as the mega esophagus. Next important, scleroderma. I have told you, beta, initially scleroderma agar hota hai, so then the patient develops GERD. But later stages of scleroderma mein, when there is complete fibrosis of the lower esophageal sphincter, the lower esophageal sphincter gets closed, beta, and that is going to cause achalasia cardia, which is. Next important is a pseudo-achalasia cardia. Now, this pseudo-achalasia cardia क्या है? So please remember, beta, here there is no problem in the esophagus. Then what is the problem? There is basically a cancer or a malignancy, beta, which is actually pressing the lower part of the esophagus from outside. ठीक है? Esophagus में कोई दिक्कत नहीं है. There is compression from outside due to cancer. ठीक है? So therefore it is called as a pseudo-achalasia. तो याद रखना है बेटे. That pseudo-achalasia cardia, if they ask you, so it is nothing else but compression of the lower esophageal sphincter, beta, due to a malignancy. Okay, due to a mediastinal malignancy, the esophagus is getting compressed. Hopefully that's clear to all of you now. Now, if they ask you, beta, what is the criteria that is used for the diagnosis of achalasia cardia? याद रखना है, shall I? Okay. So please remember the criteria that is used for the diagnosis of achalasia cardia beta has to be a Chicago criteria. So Chicago criteria में there are three features beta. याद रख लो. The diagnostic criteria used for the achalasia cardia is going to be Chicago criteria. तीन features है beta. The first one definitely the definition itself. That means the lower esophageal sphincter fails to relax. Okay, there is failure of relaxation of the ileus. Second important beta. Now please tell me if the lower esophageal sphincter is contracted beta. ठीक है. So even if in the upper part there is peristalsis, even if in the upper parts of the esophagus beta there is peristalsis, will the food be able to pass? No. Okay, even if there is peristalsis in the upper part beta, still the food is not able to pass. Therefore this peristalsis is called as effective or ineffective. Ineffective peristalsis because the food is not able to move further. And third, obviously if the lower esophageal sphincter will be in a contracted state beta, the pressure in the ileus is going to be high beta. What was the normal ileus pressure I told you yesterday? 8 to 25 millimeters of mercury. But मैंने तभी बताया था that in achalasia cardia the pressure is going to exceed 25 millimeters of mercury beta. That is important to remember. ठीक है, तो याद रख लो बच्चे. Criteria which is there, it is failure of ileus relaxation basically, first point. Second important, ineffective peristalsis is going to be there. And third point beta, definitely the ileus pressure is going to be more. How much is the ileus pressure beta? याद रखना है. So ileus pressure for the criteria beta, exactly it is more than equal to, okay, I know definitely it doesn't make a difference more than 25 लिख लो या more than equal to लिख लो, but beta you know definitely the criteria, so it's better to remember it as more than equal to 26 millimeters of mercury. Okay, so do remember it is more than equal to criteria के according, you can also call it as more than 25. Okay, so more than equal to 26 millimeters of mercury beta is going to be the pressure. Okay, so these are the three features beta in the Chicago criteria. No issues with this? Done with this, anybody? Now next important, if I talk about beta, is what are the clinical features in the patient. Now if I talk about the clinical features, but do remember the earliest clinical feature beta, as definitely all the food is getting collected in the upper part of the esophagus beta. So whenever you lie down, what is going to happen? All that food is going to come back into the mouth beta, and that is classically called as regurgitation of food beta. So earliest feature in patients of achalasia cardia and Zenker's diverticulum is going to be the same beta. The patients will have regurgitation of food. That is the first feature. Next, as the food stays collected over here for a longer duration of time, it will definitely get infected and release a foul smell beta, causing a bad breath known as halitosis beta. And lastly, definitely the patient is having dysphagia, but yaad rakhna, dysphagia which is over here beta, that dysphagia will be more for solids or liquids. We have discussed already beta that याद रख लो कि dysphagia in patients of achalasia cardia will be more for liquids. Reason beta, see liquid जो होते हैं beta, they are lighter in weight, and as the liquids are lighter in weight beta, will they be able to put a lot of pressure on the contracted esophagus? No, that's the reason beta, they will not be able to pass. Okay, but on the other hand, if I talk about a solid beta, solid is definitely heavier in weight beta, and as solid is going to be heavier in weight beta, it is going to put enough pressure beta on the lower esophageal sphincter and it is able to pass beta. ठीक है, तो solids at least make their own way beta, solids अपने आप pass हो सकता है, ठीक है, but the liquids have difficulty in passage beta, and that is important to be remembered. So dysphagia in cases of achalasia cardia beta is going to be more for liquids as compared to solids, and this is what is the important thing beta which differentiates from esophageal cancer, because please remember esophageal cancer and achalasia cardia, both of them are going to have a continuous dysphagia. Yes, in achalasia cardia the dysphagia is not progressive in nature, but still it is continuous na, so there can be a confusion. So the another way to differentiate it is nothing else but beta, that the dysphagia is going to be more for liquids as compared to solids. In esophageal cancer it was more for solids. Now obviously beta, as the patient is having regurgitation of food, there is a very high chance that the patient can have definitely beta aspiration. All that food may go into the patient's airway beta, and that can lead to aspiration. And हमें पता है when the patient will have a recurrent aspiration beta, the patient is going to develop acute lung infections known as pneumonia, and due to pneumonia beta over a longer period of time, the patient may also develop lung abscess beta, right? These could be the problems which are due to the recurrent aspiration in a patient of achalasia cardia. Next important beta, if I talk about, is esophagitis, right? Because beta in the upper part of esophagus beta, as the food stays collected for a longer duration of time, that damages the esophageal mucosa बच्चे, and therefore the esophageal mucosa undergoes an inflammation that is called as esophagitis. Due to esophagitis beta, later on what is going to happen? We know inflammation heals with fibrosis beta, and as that inflammation is going to heal with fibrosis, Later conditions mein beta the patient may have stricture. But another problem can be what? Another problem beta, obviously, as the esophageal mucosa is damaged over here, it will start proliferation, and if there is too much of proliferation, that can lead to growth of a cancer over here, right? And we have discussed in achalasia cardia, which esophageal cancer is more common, squamous or adeno? We know beta, it is the squamous cell carcinoma beta, which is going to be common. The patient may develop a squamous cell carcinoma of the esophagus beta, right? The patient may develop a squamous cell carcinoma of the esophagus, or later on beta, in some conditions, definitely the patient is going to have strictures. No issues with this, anybody? Hopefully that's clear to all of you. Now, if they ask you, beta, what is the investigation of choice? So, yaad rakhna, beta, okay, investigation of choice is not a barium swallow. A lot of people are always confused कि barium swallow is the investigation of choice. No, it is very commonly given in your examinations, beta. This is the barium swallow का picture that is given below. ठीक है, barium swallow में what you are able to see. Now I hope you are able to appreciate the difference between a rat tail and a bird beak. क्या दिख रहा है यहाँ पे? Here you can see there is a sharp margin, beta, of the lower part of the esophagus, and there is a sudden narrowing, and that sudden narrowing I told you is called as the shouldering effect, right? So that is important. So yaad rakhna, this one over here is classically called as which appearance, beta? This is classically called as a bird beak appearance. ठीक है, तो bird beak appearance on a barium swallow is definitely suggestive of a achalasia cardia in a patient, beta. Or this bird beak appearance can also be called as, again, not a rat tail sign as well. ठीक है, मैंने बोला है कभी भी alternative terms नहीं है. ठीक है, the bird beak appearance can also be called as, beta, the pencil tip sign. The bird beak appearance is usually called as the pencil tip sign, beta, because it is sharp, right? याद रखना बेटा, either you can call it as the bird beak appearance, or you could call it as the pencil tip sign, beta. These are the features on the barium swallow in a patient of achalasia cardia, beta. That has to be remembered. If they ask you what is going to be the investigation of choice, बच्चे, तो याद रखना, as the lower part of the esophagus is in a contracted state, beta, the pressure in the lower esophagus is very, very high. And as the pressure in the lower esophagus is very, very high, beta, obviously we can measure that pressure, okay? And the to measure the pressure, beta, the investigation of choice has to be what? To measure the pressure, the investigation of choice has to be an esophageal manometry. Mano means pressure, metry means measurement. Esophageal manometry could be done, beta, to measure the pressure in the lower part of esophagus, beta. तो याद रखना है, manometry has to be remembered. ठीक है? And on esophageal manometry, beta, how much will be the pressure in a lower esophageal sphincter, beta? The pressure in the lower esophageal sphincter would be somewhere between 26 to 100 millimeters of mercury, beta. ठीक है? In a patient of achalasia cardia, the pressure which is there, beta, it ranges between 26 to 100 millimeters of mercury. That has to be remembered. No issues with this, anybody? याद रख लो. So 26 to 100 millimeters of mercury is the usual pressure on the manometry. Now a lot of times, I know अभी तो बाकी देखना है, but a lot of times बेटा people usually complain कि sir there is always a confusion between कौन सा investigation of choice है, what is the treatment and all of that. So for surgery बेटा, when you are going to revise surgery, I will ask you to do one thing बेटा, एक चीज कर लेना बस, that will make it easier. What? Make a table out of it बेटा, and in that table, on one side write the disease. Second column should definitely be beta the investigation of choice. Third column can be a special investigation which gives you a classical appearance. Like for example, I'll give you a hint. And last column has to be the treatment of choice, beta. Now example के तौर पे first is achalasia cardia. Then second column is investigation of choice where you will write manometry. Third column special na, so BS, that is barium swallow. Okay, and then you will write bird beak. Reason beta, bird beak is also seen on barium enema. So you should not get confused. इसीलिए BS लिखना है. So bird beak appearance, and lastly treatment, Heller's cardiomyotomy. That is how definitely beta it will be easier for you. In one glance beta all the GAT conditions which are there, सबका तुम्हें important वालों का याद हो जाएगा. ठीक है, without any efforts. Got it? That is important. Now if they ask you beta about the management in the patient. So if I talk about the management beta, the first line management is drugs. Yes, here lifestyle modifications are not the first line because beta the risk factors are not modifiable. That's the reason. So first line management is medical management beta, and the drugs should be given. Which drugs are given? We have to relax the smooth muscles of the esophagus. That's the reason beta we can give CCBs to the patient. And what are CCBs beta? They are nothing else but calcium channel blockers could be given to the patient beta. If calcium channel blockers is not an option, the second choice can be nitrates. Nitrates are not considered as the first choice because of the hypotension like side effects beta. So CCBs are the safer ones. They are considered as the first choice. But beta, most of the conditions mein the drugs do not work. Okay, we can try them definitely. Always we have to give it a try. but majority conditions में बेटा the medical management may not respond also. Next condition is injection of botulinum toxin in the lower esophageal sphincter. क्यों? Because beta, if you give an injection of botulinum toxin in the lower esophageal sphincter, what is going to happen? That lower esophageal sphincter which is there beta, it is going to relax basically, right? That is going to happen due to botulinum toxin injection. Okay, but problem kya hai beta? If once the effect of the botulinum toxin injection is gone, okay, again the esophagus goes into the contracted state beta. That means here there is a very high chance of recurrence beta. Okay, after giving a botulinum toxin injection, there is a very high chance of recurrence. That is the reason it is not commonly performed. Next important condition beta is we can go in this contracted lower esophagus beta with the help of an endoscope. And once we go over there beta, we have taken a balloon along with us. Now we will slowly beta start inflating the balloon. And as you will slowly start inflating the balloon beta, now what we have done? We have actually dilated the esophagus beta. So that is what is done. Okay, so it is known as an endoscopic balloon dilatation beta. Okay, it is known as an endoscopic balloon dilatation. But the problem with endoscopic balloon dilatation is what beta? As the esophagus is contracted and you are also inflating the balloon beta, there is a very high risk of rupture over here. Okay, so याद रखना है बच्चे, there is a very high risk of rupture if you go for a endoscopic balloon dilatation. That's another reason why it is not commonly preferred. Then nowadays beta, we have started using a surgery beta, which is a minimally invasive endoscopic surgery bachche. And what is that endoscopic surgery? That endoscopic surgery is what is called as POEMS beta. Now what is POEMS? Write down. POEMS is nothing else but per oral endoscopic myotomy surgery. Okay, so per oral endoscopic myotomy surgery, whenever you make incisions or whenever you give cuts on the muscles beta, that is what is called as myotomy. याद रखना है बात, ठीक है? तो myotomy surgery it is, but this is not done externally beta. We have to go inside the esophagus beta with the help of an endoscope, and then per orally we have to do the surgery beta, known as POEMS basically. Now when I go for a POEM surgery, understand how we do it. See over here beta, once we go with the endoscope into the lower part of the esophagus, first we have to create a tunnel beta. Yes, tunnel matlab we have to separate the mucosal and the submucosal layer beta from the muscular layer. मतलब submucosa और muscle layer के बीच में tunnel create करना है. You have to create a tunnel between the submucosa and the muscle beta, right? So you will separate the inner two layers beta, mucosa and submucosa, and now you'll go inside the tunnel basically. So I have created a tunnel beta, so you can definitely go inside these two layers known as the mucosa and submucosa beta. And once you have gone on inside the mucosa and submucosa, after that you have to remove the circular muscle layer beta. Yes, we know there are two muscle layers inside the esophagus now. One is the circular muscle layer, which is responsible for that contraction, and second is the longitudinal muscle layer. So what are we going to do? We are going to remove the circular muscle layer beta. Reason is definitely that circular muscle layer which is there, it is fibrotic in nature. So if that circular muscle layer has undergone fibrosis, we have to remove that circular muscle layer, or we can make multiple cuts on it beta if it is not undergone fibrosis. Okay, now due to that, what is going to happen? Obviously now the esophagus which was contracted until now beta, it is going to relax, because that muscle either has been removed or we have made multiple cuts on that muscle, so that the esophagus relaxes beta. Okay, and once definitely the surgery is done, you have to close the tunnel back beta with the help of clips basically, because if you do not close the tunnel back, aortic dissection jaisa ho jayega, right? That can be a problem. No issues with this, anybody? Chalo. But it is again not a surgery of choice always beta. Reason, chances of recurrence would have been seen beta in chances of recurrence have been seen beta even after a POEMS definitely. Okay, so therefore beta, till now the treatment of choice or the surgery of choice, if they ask you beta, it is actually external surgery. Here you can go via a laparoscopy beta. Yes, okay, because intra-abdominal esophagus contracted mainly. So definitely here we can go via a laparoscopy beta, and then what we do, we basically make cuts on the muscle layer of the esophagus beta, but from outside bache. Can you see? We have made multiple incisions or cuts on the lower esophageal sphincter beta, but from outside. Okay, and as we have made the cuts, what has happened? The lower esophageal sphincter of over here is going to relax, and that's the reason beta the condition gets treated. So here you can see definitely beta, what we have done, we have made cuts over the muscles, or we have split out the muscles beta, so that the lower part of the esophagus relaxes properly. Okay, so please remember this surgery which is there beta is classically called as the Heller's cardiomyotomy surgery beta. Heller's myotomy भी बोल सकते हो, or Heller's cardiomyotomy, because the surgery is done in the cardiac region. Cardia is gastroesophageal जंक्शन, ठीक है, तो उसमें होता है इसलिए Heller's cardiomyotomy surgery, which is there, बच्चे, it is considered as the surgery of choice in a treatment of achalasia cardia, ठीक है, so that is important to remember. So Heller's cardiomyotomy surgery is the surgery of choice or the treatment of choice. What can be a complication of the surgery, beta? Now here you have made multiple cuts or incisions on the lower esophageal sphincter muscles, beta. Obviously they are going to relax, but ऐसा ना हो that they are going to relax permanently. That means they are not able to contract again, beta. And if they will not be able to contract properly again, what is going to happen? Definitely, beta, as the lower esophageal sphincter is not able to contract, it will remain open, and due to that, the acid from the stomach, beta, it may go back into the patient's esophagus, leading to a complication like GERD, beta. Yes. So please remember, beta, if they ask you what can be a complication of Heller's cardiomyotomy surgery, अगर तुमने incisions बहुत deep लगा दिए, if you have made the incisions too deep, and due to that, beta, the LES is not able to contract again, beta, that can keep the LES open always, leading to GERD, beta, in the patient. So complication of this GERD surgery is definitely GERD. If you want to prevent GERD, beta, after Heller's cardiomyotomy surgery, what is indicated? Along with the Heller's cardiomyotomy, beta, you can definitely pick up the fundus and you can actually wrap the fundus, beta, around the lower part of esophagus. Now, whether you do a partial fundoplication, beta, known as the Dors fundoplication, or you do a complete fundoplication, बच्चे, known as the Nissen's fundoplication. Both can work, beta. ठीक है, no issues with this. तो याद रखना है बच्चे that after a Heller's cardiomyotomy surgery, beta, please remember, if you think that there is a chance of GERD, okay, if you have made the incisions too deep, then immediately, beta, in the same setting, please perform a prophylactic, okay, please perform a prophylactic, beta, fundoplication, ठीक है, so we have to go for a prophylactic fundoplication in the patient. Either a Dors or a Nissen's can be done. Clear to all of you now? That is important to be remembered. That was all about your achalasia cardia, beta. Next important if I talk about is a motility disorder of the esophagus itself, beta, and that motility disorder of esophagus is going to be called as distal esophageal spasm, बच्चे, or the diffuse esophageal spasm. Now when I say distal or diffuse esophageal spasm, beta, याद रखना ये बात that the patient is going to come to you, beta, with complaints like what are the complaints? The patient will have a complaint of chest pain, beta, and the patient will have dysphagia, right? The patient would have a complaint of chest pain or dysphagia. Reason, beta, in distal or diffuse esophageal spasm, beta, याद रखना, in achalasia cardia, what was the problem? Only the lower esophageal sphincter of the patient was contracted. But in a DES, that is diffuse esophageal spasm, beta, the whole esophagus, or rather the body of the esophagus, is contracted. And as here, beta, the contraction will be seen in a major part of the esophagus, beta. That's the reason. The pressure in the esophagus will be very, very high. And due to that, beta, the patient will also experience chest pain as well. And obviously, as the esophagus is contracted over here, the patient is going to have dysphagia. Clear about? That is important. So here you can write down distal or diffuse esophageal spasm. Here definitely what is contracted or what is in spasm, beta? It is the body of esophagus basically. Okay, it is mainly the body of the esophagus, beta, which is in spasm. Body of esophagus in spasm. Clear to all of you? If they ask you, beta, what is the investigation of choice? Okay, investigation of choice is same, beta, over here also. That means here also the pressure inside the esophagus is very, very high. So we will try to measure the pressure, and measuring pressure will be done by the esophageal manometry, beta. Okay, we can definitely go for esophageal manometry, beta. That has to be remembered. Now esophageal manometry, how much will be the pressure? The pressure in esophageal manometry will be somewhere more than 120 millimeters of mercury. Yes, any pressure more than 120 millimeters of mercury, beta, can be considered as a diagnosis of diffuse esophageal spasm. You will be like, sir, हमने कहीं तो पढ़ा था sorry, we have read somewhere 300, 400, beta. So please remember, the pressure in the diffuse esophageal spasm, beta, can reach up to 300 and 400, but any pressure more than 120 is diagnostic of DES, beta. You don't have to wait for the pressure to be 300. Okay? That is important. So here also the investigation of choice is a manometry. Now apart from that, beta, the other investigation that we can do basically is this. What is this? Again, we are able to see a barium swallow, beta. And when you do a barium swallow in a patient of diffuse esophageal spasm, you are able to see the whole body of the esophagus appears to be contracted over here. And when the body of the esophagus will appear contracted, beta, it will give us a very classical appearance. And what is this classical appearance called as, beta? It is known as the corkscrew appearance, or we can also call it as the rosary bead appearance, beta. Either we can call it as the corkscrew appearance or we can call it as the rosary bead appearance बच्चे. The corkscrew or the rosary bead appearance is very classical in patients of diffuse esophageal spasm. Okay, so that has to be remembered. Next important beta, if they ask you, see, please remember beta, if the pressure which is there, beta in the esophagus, okay, is going to be more than 180 by 200 millimeters of mercury. Okay, when the pressure is going to be more than equal to 180 by 200 millimeters of mercury beta, then I can call it as nutcracker esophagus also. When the pressure is going to exceed more than equal to 180 by 200 millimeters of mercury, then it can be nutcracker esophagus also beta. Okay, but याद रखना nutcracker esophagus and diffuse esophageal spasm में there are certain differences that you need to remember beta. ठीक है, they have not asked in your examinations until now. It is basically on the amplitude, okay, and the normal peristalsis in the esophagus. Based on these two parameters, we differentiate both these conditions. You don't have to remember. बस इतना याद रखना, दोनों एक कंडीशन नहीं होते हैं, both are different condition. Just remember the pressure, diffuse esophageal spasm which is there, here the pressure is going to exceed more than 120, and nutcracker esophagus में the pressure is going to exceed more than equal to 180 by 200 millimeters of mercury. Now if they ask you what is going to be the treatment beta, तो याद रखना the treatment, again the first line management would be medical management, that is drugs beta. The same drugs could be used beta. The first line which is there beta are going to be CCBs, that is your calcium channel blockers to be used beta, followed by the second best choice which is there beta are going to be your nitrates. Those are the same drugs to be used over here. Apart from that, if I say beta, if the drugs fail, if the medical management is going to fail beta, then what we have to do, we have to make cuts over the muscle itself beta. Okay, you can definitely go and make cuts over the muscle so that muscles are able to relax beta. And whenever we make cuts over the muscle, I've told you that surgery will be called as a myotomy surgery beta. So here we have to go for a myotomy surgery. Clear about that is all about your DES बच्चे or the diffuse esophageal spasm. Now let's talk about the another condition beta, and that condition that we need to talk about is a benign condition itself known as Skadsky ring beta. Now basically what is a Skadsky ring बच्चे? It is this one over here. Can you see? So here you are able to see beta that there is compression in the esophagus beta, and it is because of what? You can see it is basically due to this ring-like structure beta. Okay. So where is this ring formed? This ring is actually formed inside the esophageal wall itself. Yes, beta. So due to fibrosis, beta, okay, there is a esophageal fibrotic ring which is formed, and due to that fibrotic ring, definitely there is narrowing in some part of the esophagus. That is what is called as Skadsky ring, bache. So when I talk about a Skadsky ring, we know it is going to be a benign condition, beta. Okay, it is going to be a benign condition, and here definitely there is a mucosal and a submucosal fibrotic ring which is going to form. There is a mucosal and a submucosal fibrotic ring which is formed inside the esophageal wall beta. Now here definitely the patient is going to complain of intermittent dysphagia beta. Okay, the patient may have an intermittent dysphagia. Apart from that beta, what will be the investigation of choice? So investigation of choice is the one that I've shown you now. What was that? That is nothing else but a barium swallow beta. So when you do a barium swallow beta, that is enough to make a diagnosis of Skadsky ring bache. Okay. When you do a barium swallow, this is the classical appearance beta which is seen in a patient of a Skadsky ring beta. Yaad rakhna, because in the examination they have asked you about the spot diagnosis, just image and diagnosis pucha tha. So answer has to be Skadsky ring. Okay, on the barium swallow, that appearance which is there beta, it is called as the B type of appearance. That ring which is there beta, it is giving us a B type of appearance. So just remember, B type of appearance will be seen on the barium swallow. Treatment, if they ask you beta, if the patient is asymptomatic, okay, if the patient is going to be asymptomatic beta, I always say if the patient is asymptomatic, will the patient come to us? Obviously not beta. So in those conditions, if the patient is asymptomatic, we should just go for an observation beta. We should just go for an observation. That has to be remembered, bache. But please remember that sorry. So if the patient is asymptomatic, just go for an observation. But if the patient is symptomatic beta, then what we have to do? We have to go at that side beta where there is a Skadsky ring formed via an endoscopy, and we also have to take a balloon along with us. And with the help of this balloon beta, we will slowly inflate this balloon bache. And as we will inflate this balloon, definitely what is going to happen? The esophagus over there beta is going to get dilated. So this is classically called as an endoscopic balloon dilatation beta. So we have to go for an endoscopic balloon dilatation. That is going to be the surgery of choice beta in the management of a symptomatic case of cat's gearing. This has been another question beta, that what is the treatment. So answer has to be balloon dilatation would be the treatment in the patient. Clear about? Chalo. No issues with this, anybody? Now if I talk about beta, definitely that what is the condition that is given next. So the condition that you are able to see beta next in the picture is there is an endoscopic picture beta, and on that endoscopic picture you are able to see that inside the esophageal wall beta, or inside the esophageal mucosa, there are multiple rings beta which are going to be formed, right? And these multiple rings which are there beta, they are actually looking like as if there is a stack of coins beta, right? It is looking as if there is a stack of coins beta which is kept over one another, right? So this is classically called as the stacked up appearance. So on the endoscopy, the esophageal mucosa beta, due to these constriction rings which are formed inside it, it looks actually like a stacked up appearance. It is giving us a stacked up appearance beta. Apart from that, even you are able to see the barium swallow beta. Barium swallow also gives similar kind of appearance beta. It is also giving you a stacked up appearance itself. Okay, this condition which is there beta is classically called as the feline esophagus. Now you will be like, so what is feline esophagus? I hope all of you are quite about the feline family beta. Feline family is the cat family beta, cat, tiger, all of them. ठीक है, उनमें खासियत क्या होती है बेटा? What is a common feature among all of them? They have stripes on their body, right? So all of them have stripes on their body beta. In similar manner you are able to see over here beta. Here definitely similar to their stripes, basically we are able to see rings inside the esophagus beta. So this is classically called as the feline esophagus beta. This is classically called as the feline esophagus. How important is bache here in feline esophagus? What is going to happen? The esophageal mucosa which is there beta, the esophageal mucosa which is there, as I told you, it appears stacked up. What is the reason beta? I have told you beta, here definitely there was inflammation of the esophageal mucosa initially, and due to that inflammation beta, we know there can be fibrosis, and due to that fibrosis there can be formation of these constriction rings. So beta, because of that, because of these constriction rings in the esophageal wall, you are able to get this kind of a stacked up appearance. Okay, but that is important. What can be the most common cause? Now we know any condition that is going to cause inflammation, that is esophagitis beta, may cause feline esophagus, right? So please remember, we know which is a more common condition to cause esophagitis. Esophagitis is the most common complication of GERD beta, that is gastroesophageal reflux disease. The most common cause of a feline esophagus, if they ask you beta, then answer has to be GERD, that is gastroesophageal reflux disease beta. Clear about? But here beta, the second most common cause which we have to remember is going to be eosinophilic esophagitis. Yes, it is also inflammation of esophagus itself beta. Okay, but it is a special one because, okay, here when we do a biopsy and when we check the histopathological examination, over there beta, we will be able to see a lot of eosinophils beta inside the biopsy. That condition is known as an eosinophilic esophagitis. So here I am going to talk about beta eosinophilic esophagitis, because we have spoken about GERD everything beta. If GERD is the cause of this feline esophagus, you know what to do. Definitely you have to start definitely PPIs in the patient beta with prokinetic agents. If the patient does not respond, then we have to go for a surgery. Okay, so that is important. But eosinophilic esophagitis, which is there, some important points about it. The first thing that you have to remember about this condition, that it is actually going to be more commonly seen in children beta. Okay, it is more commonly seen in children, first thing beta. Second important, definitely this condition is usually associated beta, this condition which is there, it is usually associated with allergic conditions beta. That means, for example, the patient is having a family history of bronchial asthma beta, or they have allergic rhinitis. So in those patients, definitely those patients who are atopic basically, or the patients who are allergic, in those patients definitely we are able to see this eosinophilic esophagitis bache. And third important thing that I have told you already, that when you will take a upper GI endoscopy and biopsy beta, on that biopsy, when I do a histopathological examination, on that histopathological examination, you will be able to see more than 15 eosinophils beta per high power field of microscope. Okay, we will be able to see more than 15 eosinophils per high power field of microscope. That will be a feature. Okay, that's the reason it is called as eosinophilic esophagitis beta. No issues with this, anybody? So that is important to be remembered beta. And now if they ask you definitely what should be the ट्रीटमेंट इन द पेशेंट बच्चे, तो याद रखना है बात, ट्रीटमेंट की अगर मैं बात करूँ, इन्वेस्टिगेशन उसके पहले, आई होप ऑल ऑफ यू क्वाइट अवेयर, इन्वेस्टिगेशंस के लिए यू हैव डन अपर जी एंडोस्कोपी, एंड व्हेन आई हैव डन अपर जी एंडोस्कोपी बेटा, यू आर एबल टू सी दिस क्लासिकल अपीयरेंस. व्हाट इज दिस अपीयरेंस कॉल्ड एज? दिस इज बेसिकली कॉल्ड एज द स्टैक्ड अप अपीयरेंस बेटा. ओके, दिस इज क्लासिकली कॉल्ड एज द स्टैक्ड अप अपीयरेंस, और वी कैन ऑल्सो गेट बेटा This appearance can also be called as a crepe paper mucosa. Right here, the mucosa which is there, beta, it appears like a crepe paper, that rough paper that you might have seen, na? So it is also called as a crepe paper mucosa. So either you can call it as a stacked up appearance, bache, or you can definitely call it as the crepe paper mucosa. Okay? That will be seen. Even on a barium swallow, beta, if you do, the same kind of a stacked up appearance is going to be seen, beta, over here also. Okay? That is important. Also, upper GI endoscopy and biopsy will be done, and biopsy will show more than 15 eosinophils, beta, per high power field. Treatment अगर वो पूछेंगे बेटा, see GERD का तो treatment I've told you already, PPIs and followed by surgery if not responding. But if I talk about the eosinophilic esophagitis, okay, feline esophagus especially, beta, so in that condition what we have to do, we have to give initially steroids to the patient, beta. Okay, we have to initially give steroids to the patient to stop the inflammation, beta. But if steroids do not work, beta, then we have to give even stronger agents, beta. Then we have to give even stronger agents, and that is nothing else but immunomodulators, beta. Yes, we have to give even stronger agents, beta, something like immunomodulators, basically. Immunomodulators like some, for example, a TNF alpha inhibitor can be given, beta. That is an infliximab, okay? All of them. Okay? Golimumab, infliximab, and all of these drugs which are there, beta. Those kind of immunomodulators could be given in the patient who is not responding. Okay? So that is important to be remembered. So that is one point. Now, second important of, if I talk about beta, okay, and that is going to be very, very important basically, and that is going to be beta, nothing else but foreign body ingestion. Now let's talk about another topic, beta, and that is foreign body ingestion, a very important topic, beta, from ANT as well as from surgery, beta, that we have to talk about. Now let's talk about a foreign body ingestion, bache. So when I say foreign body ingestion, beta, the first thing that comes to my mind is that which age group is going to have more common chances of foreign body ingestion? Obviously, beta, it is going to be children only, right? So children where there are more chances of foreign body ingestion. So if they ask you what is going to be the most common foreign body ingested by a child, yaad rakhna hai bache, if they ask you the most common foreign body ingested by a child, usually, beta, it is nothing else but coins, right? The most common foreign body ingested by a child is going to be coins, beta. Apart from coins, the other foreign bodies could definitely be, beta. Apart from coins, the other foreign bodies could definitely be toys as well, beta, small toys which are there, or definitely, beta, they can even ingest peanuts. Now I'm not saying peanuts for the GIT, peanuts for the airway, right? If the peanuts go into the airway, that can be a foreign body, now then that is important. Clear about? Because here we are talking about foreign body ingestion in the throat, and by throat I mean either it can be airway or it can be the esophagus. ठीक है, तो दोनों के बारे में एक साथ बात कर रहे हैं अपन. Most common foreign body ingestion has to be the coins. If they ask you, beta, that what is the most common foreign body ingested in an adult, beta, so the adults may the most common foreign body has to be a fish bone, bache. It is usually the fish bone. And in elderly patient, beta, if they ask you the most common foreign body, so the most common foreign body in an elderly patient is going to be the loose teeth, beta, or the dentures. Okay, the loose teeth or the dentures which are there, beta, those are going to be the most common foreign body in elderly patients. If they ask you, beta, what will be the complaint of the patient, yaad rakhna, most of the patients are going to be usually asymptomatic, bache. Yes, majority of the patients who are there, beta, those are going to be usually asymptomatic. याद रखना है, majority of the patients are usually asymptomatic, beta. Okay, most of the children, they are brought to the emergency, beta, with a complaint of foreign body ingestion, but if you look at them, they are having no symptoms. But yes, there can be other people, beta, who are having symptoms like this. The first condition which is there, beta, the patient will come. Yes, beta, what is this? The patient is not able to speak, the patient is not able to breathe, beta, and this is a classical presentation of choking, bache. Second, if the foreign body is in the patient's airway, beta, the patient will have difficulty in breathing, that is dyspnea, or noisy breathing known as stridor. And if the foreign body is inside the esophagus of the patient will have dysphagia, beta. Clear hai baat? If they ask you when a patient of foreign body ingestion comes to us, what should be the first line investigation? याद रखना है बेटा. Okay. क्या हुआ? What you're asking, I'm not getting the reference point for it. So please remember, beta, if they ask you what is the investigation basically, the first line investigation which is there, beta, whenever a patient comes to you with a foreign body ingestion is nothing else but a X-ray, beta. Okay, it has to be the X-ray basically. And yaad rakhna, you have to tell the technician who is taking the x-ray beta to not only cover the neck beta but also cover the chest of the patient properly. Reason, we are not sure about the location of the foreign body beta. Okay, it can be at the level of the neck itself, or it might have gone down into the chest also beta. Okay, so x-ray neck plus chest has to be done. So x-ray has to be the first line investigation to be done in a foreign body case. याद रखना बेटा that when I have to do basically a x-ray beta, it has to be done in two views, which it has to be done in two views. One is definitely going to be the AP view beta. One is going to be the AP view. The second one, which is there beta, it is going to be the lateral view. The first one is the AP view beta. The second one, which is there, it is going to be the lateral view. GERD may be seen in the lower part of the esophagus. Eosinophilic esophagitis, it can be seen in any condition. No issues with this in any part. That is important. Next important beta, if I talk about definitely, is if the foreign body is inside the airway, definitely I will be able to see the chest x-ray and I should be able to tell that what is the location of the foreign body, whether it is inside the esophagus or it is inside the trachea. So logical hai beta. Now what you have to remember, understand. First of all beta, please tell me which diameter of trachea is more, whether it is the anteroposterior diameter or the transverse diameter. तो अगर वो पूछते हैं बेटा in trachea, the anteroposterior diameter is going to be more. And as the anteroposterior diameter of trachea is more, the foreign body goes like this inside the trachea. Right? What is seen on the AP view? On the AP view, beta, the foreign body is going to appear slit-like or circular? Slit-like. Okay. So here, beta, the foreign body on the AP view appears slit-like, and on the lateral view it will appear circular beta. Okay. So on the AP view, if the foreign body appears, as you are able to see beta over here, I can write on the sides basically. Side में दिख रहे थे. So if on the AP view beta, if the foreign body appears on the AP view beta, if the foreign body appears slit-like, and on the lateral view beta, if the foreign body appears circular or N-face, whatever you call it as, that means the location of the foreign body is the trachea. That means the foreign body is inside the trachea. Okay, logical hai? Next important, which diameter of esophagus is more? The transverse diameter of the esophagus is more. Therefore, when the foreign body goes inside the esophagus, it gets obstructed like this. Now, please tell me, on AP view, it will appear, on AP view, it is appearing circular beta, and on lateral view, it will appear slit-like. Okay, so that is important to be remembered beta. So, yaad rakhna, foreign body in the esophagus, if it is there, yaad rakhna, on the AP view, it is going to appear circular beta, and on the lateral view, it is going to appear slit-like. On the lateral view, it is going to appear slit-like. Clear hai baat? That has to be remembered, bache. No issues with this, anybody? Chalo. So yaad rakho ye baat. That has to be remembered, beta. Hopefully that's clear. So yaad rakho AP view pe, if the foreign body appears slit-like, and lateral view pe, if it appears circular. That means the location of the foreign body which is there beta, it is going to be the trachea. AP view pe, if the foreign body appears circular, and lateral view pe, if the foreign body appears slit-like, that means the location of the foreign body is going to be the esophagus. Another way beta to identify whether the foreign body is inside the trachea or the esophagus beta, and that is going to be what? Understand? Okay. And that way which is there beta, it is this one. Here, are you able to see beta? Here, are you able to see that in front of the foreign body beta, or in front of the coin, basically you are able to see a black shadow. That black shadow which is there beta basically is nothing else but the air column, bache. And black shadow which is there beta, it is going to be the air column. If you are able to see a air column in front of the foreign body, this air column in the neck is what? The air column is nothing else but the trachea beta. So here you are able to see that the foreign body is behind the trachea, and if the foreign body is definitely behind the trachea beta, that means the foreign body is inside the esophagus beta. Okay, so that is important, bache. The foreign body is inside the esophagus. No issues with this, anybody? That's important to be remembered. Clear hai baat? But please remember, ये जो दूसरा तरीका है बेटा, to see definitely whether that black column is visible in front of the foreign body or not beta, that can be definitely problematic at times. Reason, in your examinations you cannot zoom in the pictures beta, and zoom in nahi hota, so definitely it becomes difficult at times to see that trachea. So it's basically important that you have to remember this, okay, whether the foreign body appears slit-like or it is appearing circular. Okay, so that is important to be remembered. Chalo. Next important beta, Now if I talk about the management, तो management अगर करना है तो we know बेटा when the foreign body will be inside the airway, that means anywhere in the larynx, trachea or the bronchi बेटा, whenever the foreign body is inside the larynx, trachea or bronchi, any part of the airway बेटा, we cannot keep the foreign body inside the airway. So that is the reason we have to get it removed बच्चे, and therefore we have to go for an endoscopic removal बेटा. In any part of the airway if the foreign body is there, we have to go for an endoscopic removal. Now a lot of times बेटा I've got the query that sir ऑप्शन में एंडोस्कोपिक रिमूवल नहीं था, तो आई आस्क्ड व्हाट वाज द ऑप्शंस, दे विल से सर ट्रेकियोस्कोपी और लैरिंगोस्कोपी वाज देयर. तो भाई एंडोस्कोप वेर एवर इट गोज दैट इज गोइंग टू डिसाइड द नेम ऑफ दैट endoscopy basically. If the endoscope goes into the trachea, it is tracheoscopy, into the larynx it is laryngoscopy, in the bronchus it is bronchoscopy. Clear है बात? So that is important. So whatever is the one that isn't there in the option, you can mark that. Next important beta, if the foreign body is going to be inside the esophagus बच्चे, then you have to see whether the foreign body is above the C6 vertebra or below the C6 vertebra. Now you will be like, so why it is important? Reason beta, we have to see whether the foreign body is above the C6 or below the C6. What is present at the level of C6? We know at the level of C6 beta we have the CPS. What is CPS? Cricopharyngeal sphincter. And we have discussed the cricopharyngeal sphincter or the upper esophageal sphincter is the narrowest portion of the whole GIT beta. That's the reason we have to see whether the foreign body is above it or below it. If the foreign body is above the cricopharyngeal sphincter or above the C6 beta, that means the foreign body would be large, and that's the reason beta it was not able to cross the cricopharyngeal sphincter. Clear है बात? So therefore you have to go for an endoscopic removal. But if the foreign body is definitely below the cricopharyngeal sphincter beta, if the foreign body is below the C6 or below the CPS, that means the foreign body is very very small. Why I would say that? Reason beta, if the foreign body is below the CPS, that means it has already crossed the CPS beta. And if that foreign body was able to cross the CPS, the narrowest portion, obviously that means the foreign body is small in size. And if it was able to cross the narrowest portion of the GIT beta, will it be able to cross all the other parts of the GIT easily? Yes, it will be able to cross all the other parts of the GIT very easily beta, and therefore you will just go for an observation and serial x-rays. Whenever the foreign body is below CPS, go for observation and serial x-rays in the patient. Clear about? So when the foreign body is above the CPS, always remember we have to go for an endoscopic removal. Here you can call it as esophagoscopic removal. Okay? But when the foreign body is below the CPS or below the C6 beta, you just have to go for an observation and serial x-rays beta. Now when I go for observation and serial x-rays beta, serial x-rays are to be taken after every 24 to 48 hours beta. Serial x-rays are to be taken after every 24 to 48 hours beta. That has to be remembered. Clear about? Now when you are taking the serial x-rays beta, one more thing that you have to ask the mother beta, and you will ask the mother definitely to give meshy foods to the child beta. Meshy foods means something like banana or jellies or dalia basically. Okay, these kind of foods which are there definitely beta will be given to the child, even bhindi for that matter. Okay, these kind of meshy foods which are there definitely, sticky meshy foods should be given. Reason is beta that these foods which are there, they are going to actually ensure beta the smooth passage of the foreign body throughout the GIT, and they will excrete out the foreign body via the stools itself. तो मम्मी को बोलना है बस keep a watch definitely on the stools of the baby. जब बाहर आ जाएगी foreign body, that means the foreign body has gone. And any which ways beta we are doing the observation and serial x-rays over here. ठीक है? So observe serial x-rays क्यों? Because we have to see beta what is the location of the foreign body. Is the foreign body moving further or not? Is the foreign body moving distally or not beta? ठीक है? So that is important. Now in the x-ray beta, please tell me in this picture over here, with the foreign body is above the CPS or below the CPS beta. इस पिक्चर में बताओ whether the foreign body is above the CPS or below the CPS. क्या मार्क करोगे इस कंडीशन में? These are the type of questions which directly come to you. यही क्वेश्चन था प्रीवियस ईयर. बोलो जल्दी. What do you think? Yes, here the foreign body is usually below the CPS beta. The logic being, याद रखना Okay, normally in our clinical practice, beta, we count the number of the vertebrae. But in your examinations, beta, most of the times you get X-rays like this, where it is very, very difficult, beta, to count the number of the vertebrae. And that's the reason I always remember, beta, it's easiest way that you just see the clavicle. Okay, your reference point should be the clavicle, beta. If the foreign body is touching any part of the clavicle, if the foreign body is usually touching any part of the clavicle, beta, that means the foreign body has already crossed the CPS, because clavicle is over here. If the foreign body is touching the clavicle, beta, that means obviously it has crossed the C6. C6 यहाँ पे होता है. So obviously, beta, that has to be remembered, beta. It is the easiest way to definitely differentiate. Clear है बात? चलो. So that is important. If the patient says, beta, okay, if the patient is asymptomatic, sorry, when we are doing, definitely the foreign body is below the C6, we are doing observation and serial X-rays. Now, when we are doing observation and serial X-rays, beta, and if the patient is asymptomatic, or if the foreign body is distally moving, बच्चे, okay, or if the foreign body is distally moving, what we should do? We should continue observation. कोई दिक्कत ही नहीं है. The patient is also asymptomatic, and definitely, beta, the foreign body is also distally moving. Yesterday it was in the stomach, today it is in the intestine, so it will excrete out, beta. But please remember, if they say the patient turns symptomatic, that means my patient starts having abdominal pain, बच्चे, or the foreign body is not moving, the foreign body has got stuck at one point, beta. तो अगर फॉरेन बॉडी मूव ही नहीं कर रही है, तो इन दीज कंडीशंस डेफिनेटली, बेटा, व्हाट वी हैव टू गो फॉर, वी हैव टू गो फॉर एन एंडोस्कोपिक रिमूवल नाउ, इररिस्पेक्टिव ऑफ द लोकेशन. ठीक है, वेर एवर इट इज. इफ इट इज इन द स्टमक, यू कैन गो फॉर एन अपर जी एंडोस्कोपी. If it is definitely in the colon, you have to go for a colonoscopic removal, but you have to remove the foreign body then. Clear about? So this is important. Now last point, beta, is about the disc battery or the button battery. If they say, beta, that the child which is there, beta, has ingested usually a disc battery or a button battery, then it is going to be more dangerous or less dangerous? It is going to be extremely dangerous, beta. Reason? The disc batteries or button batteries कौन से होते हैं? those small circular batteries you might have seen in toys or in the watches, na? So those are the disc batteries, beta. So if the child has definitely ingested a disc or a button battery, बच्चे, do remember that definitely in disc battery or a button battery ingestion, there will be release of alkali. And as there is going to be a release of alkali, beta, the baby is going to have a liquefactive necrosis. Please remember, due to release of alkali, we know alkalis are known to cause liquefactive necrosis, beta. So there will be liquefactive necrosis in the esophageal wall. And if there will be liquefactive necrosis, we know the depth of penetration is going to be more, beta. And that's the reason definitely there will be a very, very high risk of perforation. So याद रखना, beta, please remember, anal suppository नहीं देते, beta. It's not usually recommended. It's better to go for a removal directly. ठीक है, because the foreign body has got stuck basically. तुम suppository भी दोगे तो उससे ज़्यादा कुछ होने नहीं वाला है, ठीक है, most of the times. So it's better that do not take a risk. Better go for a removal. So disc or button battery injection which is there, beta, it is we release the alkalis basically, and once we sorry, the disc battery or the button battery is going to release the alkali, beta, and once the alkalis are released, definitely that causes liquefactive necrosis. Liquefactive necrosis will cause a deeper penetration in the wall, and that will increase the risk of perforation. How to identify a disc battery and a coin? Definitely on the X-ray. याद रखना, if there is a disc battery on the X-ray, beta, it is going to give you, definitely, please remember, if there is a disc battery on the X-ray, beta, it is going to give you how many borders, beta? याद रखना है बच्चे, that whenever disc battery will be ingested, please remember, it is going to give you basically 2 borders, beta. There are going to be 2 borders, not so much. There will be very, very thin border, beta. याद रखना है, if the circular foreign body which is seen, beta, if it is showing you 2 borders instead of 1, then it has to be a disc battery, beta. Okay, अगर दो borders दिख रही है definitely, then it is called as a disc battery, and this double border which is there, beta, it is known as beveling. ठीक है, ये जो definitely double border है, beta, that is what is classically called as beveling, बच्चे. ठीक है, तो if you are able to see that beveling basically over here, okay, that is what is suggestive of a disc battery or a button battery. ठीक है, so that is important to be remembered. याद रखना, जब भी circular foreign body हो, पहले देखो कि whether there is beveling or not. ठीक है, treatment, if they ask you, beta, what is the treatment in the patient? तो याद रखना, treatment has to be immediate or an urgent endoscopic removal irrespective of the location of the foreign body. Why? Because we know, beta, that definitely the disc battery or the button battery, beta, is going to cause necrosis and perforation. That's the reason, beta, wherever is the location of the foreign body, does not matter. Even if it is in the colon, go for a removal immediately, beta. Otherwise, there will be a risk of perforation. That has to be remembered. Clear about? Next, previous year question was there, beta, जहाँ पे वो थोड़ा खेल गए थे, and that question was basically, the child has been brought to you, beta, after a foreign body ingestion. The child has been brought to you after a foreign body ingestion, beta, usually after 8 hours. ठीक है, the foreign body that has been ingested by the child is a disk battery or a button battery. ठीक है, and the child is completely asymptomatic. What is the next line of management? And to our surprise beta, the answer to that question would have been observation. Reason Q, because beta, if the child has ingested a disk battery or a button battery, okay, the child would have started experiencing symptoms beta within a span of 2 hours or 4 hours itself. Even after 8 hours, if the child is asymptomatic beta, that means the battery which is there, it is not releasing alkali beta. That means it is which kind of a battery? It is a dead battery. That's the reason beta this kind of a question could be there rarely. Okay, so itna घुमाया जाएगा, but yeah, though that has to be remembered. Clear? Next important beta, if I talk about, it is this one. What is this over here? Now important is beta, here you are able to see a barium swallow bache, and on that barium swallow we are able to see a classical picture where we are able to see there is compression of the esophagus from outside, and the compression of this esophagus from outside beta, it is basically due to artery over here. That artery is causing the esophagus, and due to that it is compressing the esophagus beta from outside, leading to dysphagia in the patient. Okay, and what is this condition? Let's see over here. Normally beta, we know from arc of aorta how many branches are going to arise. From the arc of aorta beta, normally there are 3 branches. The first one is the right brachiocephalic trunk beta, not common carotid. It is the right brachiocephalic trunk. Second is the left common carotid artery, and third is the left subclavian artery beta. These are the normal 3 branches. But here beta, how many branches you are able to see? Here we are able to see 4 branches beta. This is the 4th extra branch. Now this extra branch that you are able to see beta arising from the left side of the aorta. Though it is arising from the left side of the aorta beta, but can you see it is basically taking a turn beta, okay, and it is going on the right side bache, okay, and this is going to go beta below the clavicle. As this artery goes below the clavicle beta, we can call it as the subclavian artery, and it also beta can supply the right sided arm. So याद रखना beta, this is a right subclavian artery, but we know right subclavian artery तो इससे निकलेगी. So basically this one which is there is an extra right subclavian artery, or an aberrant or an abnormal right subclavian artery. So if there is an aberrant or an abnormal right subclavian artery, it may arise on the left side, go towards the right side, and therefore midway beta it can compress the esophagus of the patient, leading to dysphagia. And this condition is classically called as beta dysphagia lusoria, a fancy term that has to be remembered for your examination. And this condition beta is known as dysphagia lusoria beta. So if they say dysphagia lusoria, yaad rakhna ye baat, that dysphagia lusoria which is there, it is nothing else but it is compression of the esophagus beta. You can remember, it is compression of the esophagus. Okay, so what is dysphagia lusoria? Compression of the esophagus beta by, okay, compression of the esophagus by or due to, you can say, due to the right aberrant subclavian artery. It is due to the right aberrant subclavian artery. Aberrant is a abnormal. Okay, so due to this right aberrant subclavian artery beta, if there is compression of the esophagus, that is what is called as a dysphagia lusoria. Now important is, in patients of dysphagia lusoria beta, the patient will definitely complain of a intermittent dysphagia beta. Apart from that, you will be able to see the barium swallow which is there. It will give you a very classical picture. This has been a previous year image based question, so yaad rakh lena. Okay, here you are able to see that the esophagus is getting compressed midway, okay, from outside basically. बेटा कुछ नहीं है, एक्स्ट्रा सबक्लेवियन आर्टरी निकलती है, ठीक है. इंस्टेड ऑफ 3 branches from the arc of aorta, there is the 4th branch from arc of aorta which arises, and that 4th branch is called as the right subclavian artery. But this is not a normal, this is an abnormal right subclavian artery. So this right aberrant subclavian artery takes a turn basically and goes towards the right side. That's the reason midway may it can actually compress the esophagus. When there is compression of the esophagus by this right subclavian artery, or the right aberrant subclavian artery to be specific, it is going to cause dysphagia in the patient, and that condition is known as dysphagia lusoria. That's it. Okay. Next important, if they ask you beta, what is the investigation of choice? So investigation of choice, obviously here you have to see that aberrant subclavian artery, and that's the reason we have to go for a CT angiography beta. Okay. And definitely beta, treatment should be what? Treatment is, we have to block that vessel beta, we have to block that artery specifically, and for blocking that artery we have to go for an angioembolization. You will be like, sir, won't it cause any problem? No beta, that is an extra artery. मैंने अभी बोला था, that is an extra artery. Okay, so it does not cause any problem as such. Normally वो होती नहीं है, तो अगर उसको ब्लॉक कर दोगे क्या दिक्कत आएगी पेशेंट को? right? So that is important. No issues with this, anybody? Done. Next important is a topic beta that is more important for us to remember, and that is known as GI hemorrhage beta. GI hemorrhage is nothing else but gastrointestinal hemorrhage beta. That is any bleeding inside the gastrointestinal tract. Now let's talk about that. If I talk about the GI hemorrhage, bache, done with this. If I talk about the GI hemorrhage beta or the gastrointestinal hemorrhage, there can be two types of gastrointestinal bleeding beta. Either it can be a upper GI hemorrhage or it can be a lower GI hemorrhage. Now, whether it is a upper GI hemorrhage or a lower GI hemorrhage beta, what is the landmark to differentiate that? That was a previous year question. When do we say it is a upper or a lower GI hemorrhage beta? So, yaad rakhna hai, the landmark to differentiate that beta is the ligament that is known as ligament of Treitz. Yes. What do I mean by this? Any bleeding that is above the ligament of Treitz beta, any bleeding that is above the ligament of Treitz will be called as a upper GI hemorrhage beta, and any bleeding that is below the ligament of Treitz, any bleeding that is below the ligament of Treitz will be known as a lower GI hemorrhage. Clear है बात? So the landmark to differentiate upper GI and a lower GI hemorrhage has to be the ligament of Treitz. Do remember that अच्छे से, ठीक है? So ligament of Treitz is the landmark beta to be remembered. No issues with this. Now, if they ask you what is the most common cause of a upper GI hemorrhage, yaad rakhna, the most common cause of upper GI hemorrhage beta in all the age group definitely is going to be PUD beta. What is PUD? Peptic ulcer disease. Yes, beta. The most common cause of upper GI hemorrhage is going to be the peptic ulcer disease itself. Followed by, if they ask you what is the second most common cause, the second most common cause of upper GI hemorrhage, which is there beta, it is going to be gastritis. So the most common cause of upper GI hemorrhage is definitely peptic ulcer disease followed by gastritis. If they ask you beta that what is the most common cause, sorry, what will be the manifestation beta? Yaad rakhna, what is manifestation matlab? If the patient has a upper GI hemorrhage beta, if the patient has upper GI hemorrhage, how the patient will present to us beta? What will be the manifestation? So yaad rakho that either the patient can come to you with a blood in the vomitus, and if there is blood in vomitus beta, I hope all of you are quite aware, it is known as hematemesis beta. If there is blood in the vomitus, it is known as hematemesis, and the patient can also come to us beta with black tarry stools. Yes, there is an upper GI hemorrhage beta, but due to that, the blood which is there beta, it actually goes further with food beta. The blood which is there definitely, it actually travels further with food definitely, and it definitely gets mixes with food, that juices, that enzymes, everything beta. So the time till it is excreted out in the stools beta, now the color of the blood is going to change and it is going to become completely black. And these black tarry stools which are there in a patient of upper GI hemorrhage is classically known as melena beta. The black tarry stools in a patient of upper GI hemorrhage beta will be classically presenting to us with melena. ठीक है, तो याद रखना है बच्चे that in upper GI hemorrhage or upper GI bleeding, either the patient may have hematemesis or the patient may have melena beta. These can be the manifestations to be remembered. Clear है बात? Now, if I talk about the lower GI hemorrhage, I told you lower GI hemorrhage, that means any bleeding which occurs below the ligament of Treitz. The ligament of Treitz is usually at around the second part of duodenum. Any bleeding above that is upper GI, any bleeding below that is lower GI beta. Now, if I talk about what is the most common cause beta of the lower GI hemorrhage, तो अगर वो बोलते हैं most common cause of lower GI hemorrhage overall or the most common cause of lower GI hemorrhage in adults beta, so do remember the most common cause of lower GI hemorrhage has to be hemorrhoids beta, piles or bawasir. ठीक है, the most common cause of lower GI hemorrhage overall has to be piles itself or the hemorrhoids itself. If they ask you what is the most common cause of lower GI hemorrhage beta in children, तो याद रख लो the most common cause of lower GI hemorrhage in the children will be rectal polyps beta. The most common cause of lower GI hemorrhage in children are going to be rectal polyps, which is. Whereas if they ask you in elderly patient what it is, so elderly patients mein beta, please remember in the sigmoid colon na, there will be multiple outpouchings like this, and outpouchings will be called as diverticulum. So in elderly patients beta, there is a very high risk of diverticulosis, और उसकी वजह से क्या हो जाता है, these diverticulae may become inflamed leading to diverticulitis. So the most common cause of lower GI hemorrhage beta in elderly patients can be diverticulitis beta. In elderly patients it could be diverticulitis. ठीक है, so overall the most common cause is hemorrhoids. In adults it is hemorrhoids. In children definitely beta it is going to be rectal polyps, and in elderly it is going to be diverticulitis beta. That has to be remembered. ठीक है, if they ask you what will be the manifestation which is, so do remember that the manifestation is going to be the patient who is there beta may definitely have fresh blood in stools beta. Okay, upper GI hemorrhage mein what was the problem? There was a black tarry stools which was presenting to you, but lower GI hemorrhage mein definitely there will be fresh blood in stools beta, and that fresh blood, bright red blood in stools is what is called as hematochezia. This condition or this manifestation is known as hematochezia beta. Clear to all of you now? That has to be remembered. So this is the important things, the basic things about the gastrointestinal hemorrhage. Now let's talk about all the causes of the upper GI hemorrhage beta. Now when I talk about all the causes of the upper GI hemorrhage beta, the first thing that you have to remember that 70% causes of the upper GI hemorrhage beta, they are non-varicose. Non-varicose matlab apart from esophageal varices, all the other causes, ठीक है? And 30% causes are definitely varicose in nature. Varicose matlab the esophageal varices. What are varices? I told you yesterday itself. Varices bolo, varicosities bolo. It is what? Whenever the vein beta is going to undergo dilatation and it is going to become tortuous. Whenever the pressure inside the veins increases and they will undergo dilatation and they will become tortuous beta. That is what is called as varices basically. I've told you in the lower part of the esophagus beta, the lower esophageal veins known as the coronary veins or the left gastric veins beta, they are connected to the portal vein. That's the reason whenever the pressure in the portal vein will increase, the pressure inside these lower esophageal veins will also increase and they will become dilated and tortuous beta, leading to formation of esophageal varices. If the pressure inside them increases too much, those esophageal varices are going to rupture beta. That may cause a upper GI hemorrhage or upper GI bleeding. Okay, so those causes of those varicose causes are going to be around 30%, but rest 70% are non-varicose causes itself. ठीक है, चलो. So if I talk about upper GI hemorrhage बेटा याद रखना है बात. तो upper GI hemorrhage में definitely non-varicose causes are going to be more common, followed by the varicose causes beta. Let's talk about the non-varicose causes first. If I talk about the non-varicose causes, the most common cause has to be what? The most common cause has to be nothing else but beta peptic ulcer disease. So overall also the most common cause of upper GI hemorrhage is PUD. Non-varicose में also the most common cause is PUD only, obviously. ठीक है, peptic ulcer disease. And if they ask you which is the most common vessel or the most common artery to bleed in the peptic ulcer disease, we know peptic ulcers are those ulcers beta in the GIT which occurs due to increased acid secretion. ठीक है, these peptic ulcers are either seen in the stomach or in the duodenum of the patient beta. Either they are gastric ulcers or duodenal ulcers. We know more commonly there will be duodenal ulcers in the patient. And which ulcers bleed more commonly? Again, the duodenal ulcers are the one beta which bleed more commonly. And the vessel to bleed in duodenal ulcer beta is going to be the gastroduodenal artery, and that has to be remembered as a question. The most common vessel to bleed beta in a duodenal ulcer or the peptic ulcer disease overall has to be the gastroduodenal artery, which okay, so that is important. Now if they ask you beta what can be the second most non-varicose cause or what is the second most overall cause basically for upper GI hemorrhage, we know beta the second most common cause we have discussed already, it is known as gastritis beta, right? It is going to be called as gastritis. If they ask you beta that which is the vessel that is going to bleed in gastritis, see what is gastritis? Inflammation of the gastric mucosa. Due to that beta there can be actually erosion or damage to the gastric blood vessels which can lead to upper GI bleeding in the patient beta. याद रखने की बात. Okay, because we know that the gastric mucosa is highly sensitive beta. Therefore when it develops a gastritis, there can be immediate erosion of the gastric mucosa leading to formation of ulcers, and that can actually lead to erosion of the blood vessels also beta, leading to upper GI bleeding. अगर मैं बोलता हूँ gastritis में which is the most common artery to bleed beta, it has to be the left gastric artery. Yes, in gastritis or in the gastric ulcer beta, if they ask you, the most common artery to bleed has to be the left gastric artery itself. याद रखना which type of gastritis bleeds, obviously beta it is going to be an acute gastritis. Chronic gastritis में the patient will present to you in the OPD beta with mild to moderate symptoms, but in acute gastritis the patient will present to you with severe symptoms beta, and that too in the emergency, and one of the important symptoms is going to be upper GI hemorrhage beta in the condition. ठीक है, now please remember in a patient of gastritis beta or in a case of gastric ulcers, in a patient of gastritis beta there can be development of ulcers as I've told you. But we know gastric ulcers which are there, they also develop due to stress. Okay, whenever there is a decreased blood supply beta to the gastric mucosa, in those conditions definitely beta the stomach mucosa or the gastric mucosa will develop ulcers, and these gastric stress ulcers you have to remember as I've told you. Okay, so we have discussed about one of them definitely. The gastric stress ulcers which are seen in a patient of burns will be called as the gastric stress ulcers beta, which are usually seen in a patient of burns would be called as the Purling ulcers beta, right? So please remember in a patient of burns beta, you have to remember beta the gastric ulcers which are usually seen are known as the Curling ulcers beta. Whereas if they say in patients of head injury beta, in patients of head injury the gastric stress ulcers which are seen beta, those are known as the Cushing's ulcer. You can just remember beta ki Cushing's ulcers, sorry, Cushing's triad ka tha. Cushing's triad was seen in raised ICP, which usually occurs in a patient of head trauma, right? So that is how you can remember also. Okay. So Cushing's ulcers which are there, those are usually seen in patients suffering from a head trauma. Which clear है बात. तो burns ulcers which are there beta, those are usually seen in a patient of Curling ulcers. Sorry, burns में definitely there will be Curling ulcers, and head injury में there will be Cushing's ulcers. Now let's talk about the third most common cause beta for upper GI hemorrhage, and the third most common cause for the upper GI hemorrhage is going to be malarious tear. When I talk about a malarious tear in a patient beta, that has to be remembered. I've told you that malarious tear and Borehave syndrome, what is the basic difference? Both the conditions will basically occur beta after the same presentation. Easily you have to know the difference. Why? Because malarious tear will also have the same presentation, like a chronic alcoholic patient beta who recently had a binge drinking or a binge eating episode. Due to that, the patient has a lot of retching or a lot of vomiting, and that's the reason why the pressure inside the esophagus increases, mainly in the lower part of the esophagus beta near the gastroesophageal junction. And due to that, what happens, as the patient is constantly vomiting beta, due to that increased pressure, there is a partial tear in the esophageal wall beta. Can you see here the esophageal wall has not completely undergone a perforation or a rupture beta. Here there is just a partial tear beta. Only the submucosa, only the mucosa and the submucosa of the esophageal wall undergoes a tear. What was the difference in Borehave syndrome or the spontaneous esophageal perforation? In Borehave beta, there was a complete perforation of the esophageal wall beta. Clear है? That is the basic difference. So malarious tear which is there, it is nothing else but beta a longitudinal मतलब vertical, ठीक है, a longitudinal mucosal or a submucosal partial tear in the esophagus beta. That has to be remembered first thing. Okay. Now important is bच्चे here what is the most common site? As I have told you beta, this is also due to vomiting, and vomiting may definitely there is more pressure in the lower 1/3 of the esophagus. So here also beta it is definitely lower 1/3 of the esophagus which is going to be the most common site. But याद रखना है beta that it usually starts from which junction? Okay, it starts from the gastroesophageal junction and then it extends upwards beta. Yes, the tear which is there beta, it usually starts from the gastroesophageal junction and then it is going to extend upwards. No issues with this. Now as I told you beta, what will be the features over here? The patient will be a chronic alcoholic beta, and this chronic alcoholic patient will have a binge drinking episode. So in this chronic alcoholic patients, after a binge drinking episode beta, now the patient is having a forceful retching or forceful vomiting beta, and due to that forceful retching or vomiting beta, the patient undergoes a partial tear. So the presentation is going to be same beta, alcoholic patient, binge drinking and forceful retching or vomiting. After that, if they ask you what will be the presentation, we will talk about that. The patient will present to you basically with some amount of pain, and there can be a upper GI bleeding beta which will be there. Okay. They ask you what is the most common vessel ruptured. I have told you beta that the most common vessel that usually bleeds in a patient of malarious tear beta is going to be the same as gastric ulcer. That is nothing else but the left gastric artery. So the most common vessel that bleeds beta in a patient of malarious tear has to be a left gastric artery itself. याद रखना आर्टरी का नाम, ठीक है. And as the left gastric artery beta it starts bleeding, therefore the patient will have upper GI hemorrhage, like either the patient will have blood and vomitus known as hematemesis, or the patient will have black tarry stools beta known as melena. Okay, along with that the patient will have mild pain. How to differentiate from Borehave? Borehave mein beta definitely the patient has a very severe chest pain beta which almost look like MI in the patient. It is basically due to mediastinitis. यहाँ पे there is no mediastinitis as such. Next important over there beta, the patient apart from vomiting and retching also definitely has beta a subcutaneous emphysema, because the gas from the esophagus goes outside below the skin. Here there is no perforation only, so here there is no subcutaneous emphysema as such. Third, the patient will have pneumomediastinum and Borehave's beta, due to which on auscultation there was a Hammond-Krantz sign, or on a chest X-ray there was a continuous diaphragm sign. Here neither there will be any Hammond-Krantz sign nor there will be any continuous diaphragm sign on the X-ray. Only feature is some pain and mainly upper GI hemorrhage. That's it. ठीक है. So it is not difficult to diagnose a case of malarious and Borehave, but हर बार गड़बड़ी करते बच्चे. I'm not sure why. ठीक है. It is very clear demarcation that you need to remember. Investigation of choice beta, if I have to talk about, so please remember the investigation of choice is nothing else but an upper J endoscopy beta. The investigation of choice has to be an upper J endoscopy, which we'll do, and on that upper J endoscopy we'll be able to see this kind of a picture beta. What are you able to see? This is the upper J endoscopy in a patient of a malarious tear. Are you able to see a tear that is starting from this gastroesophageal junction beta, and that tear is extending upwards? This is a classical picture of a malarious tear. Okay, so that has to be remembered. So upper G endoscopy is going to be the investigation of choice beta. If they ask you what is the first line management, anybody? Yaad rakh lo. I've told you, any patient coming to you with any kind of bleeding, the first line management has to be what? Basic resuscitation. Reason beta, we know that this patient definitely may be hemodynamically unstable because of bleeding. That's the reason jab bhi wo bole beta any patient of bleeding, the first line management is always basic resuscitation. For your gynae and ops also beta, this follows up. Okay, basic resuscitation out there also. Any patient definitely who comes to you with with bleeding beta, first line treatment is always a basic resuscitation, that is A, B, C beta. Cardia से start होता है बेटा. Cardia का involvement downwards it is less common. Downwards it is very very rare that the cardia would get involved. Cardia is basically the GE junction basically. वहां से ऊपर होता है, नीचे नहीं जाता. Because you will vomit like this ना, not ulta. Majority cases, definitely if I talk about beta, please remember that majority cases which are there, they do not need a treatment only. Why? Because majority cases which are there beta, they will show a spontaneous resolution. Yes, अपने आप ठीक हो जाता है बेटा, अपने आप bleeding रुक जाती है. So majority cases में बेटा there is a spontaneous resolution which is seen. In majority cases बच्चे there is a spontaneous resolution which is seen definitely. Okay, so no treatment is usually required. Okay, in majority patients spontaneous resolution is seen. That means it is a self-limiting condition in majority cases beta. But yes, there will be some cases beta where the bleeding will continue. Okay, and if the bleeding continues beta, if the bleeding does not stop, then what we should go for, we can definitely go for an angioembolization beta to stop the bleeding. Okay, we can definitely go for an angioembolization to stop the bleeding. We will go inside the blood vessel with the help of a catheter. Okay, and we will inject embolizing substance beta. Beta, malarious tear में the patient after the binge drinking and vomiting episode will only have hematemesis or melena. That's it. In Boerhaave syndrome में the patient after a binge drinking, alcoholic patient after a binge drinking episode and vomiting, the patient will have multiple features like there will be chest pain, there will be Hammond-Krantz sign, there will be continuous diaphragm sign, there will be subcutaneous emphysema. So many features. ठीक है? That is important. No issues with this, anybody? Chalo. So that is important to be remembered. Next, fourth cause beta definitely of upper GI hemorrhage is nothing else but called as gastric antral vascular ectasia beta, called as GAVE. Okay, so let's talk about the next condition that is known as GAVE beta. What is GAVE? That is gastric antral vascular ectasia. Now, when I talk about ectasia beta, we have discussed what is ectasia literally means. Ectasia means dilatation beta, and vascular ectasia का मतलब होता है here definitely there is dilatation of the vessels बच्चे. Here definitely the patient is going to have dilatation of the vessels बच्चे. ठीक है, तो यहाँ पे क्या होता है बेटा, जो स्टमक की वेसल्स होती है ना, द गैस्ट्रिक वेसल्स विल अंडरगो एन डायलिटेशन, एंड इफ देयर इज टू मच ऑफ डायलिटेशन ऑफ दोस गैस्ट्रिक वेसल्स, these vessels are going to rupture beta and the patient may start bleeding beta, having a upper GI hemorrhage. ठीक है, so gastric antral vascular ectasia is nothing else but dilated submucosal vessels in the stomach beta. In the stomach, which is going to be the most common part beta, they have mentioned in the name itself, antral, right? That means I hope all of you are quite aware beta, there are 4 parts of a stomach. This is what is the fundus, this is the body, this is the antrum, and this is the pylorus beta. Clear? So obviously this part which is there beta, antrum, is going to be affected in this condition more commonly. So gastric antral vascular ectasia or GAVE, definitely it has dilated submucosal vessels. The most common part affected in the stomach is going to be the antrum. If they ask you it is more commonly seen in, to yaad rakhna, this condition is slightly more commonly seen beta in females. This condition which is there beta, it is slightly more common in females as compared to males beta. Okay, that has to be remembered. A reason why it is more common in female, ये रख लो better. Why it is more common in females beta? Because it is associated with connective tissue disorders. Connective tissue disorders like SLE, scleroderma. Okay, and as it is associated with connective tissue disorders, I hope all of you are quite aware from medicine that all your connective tissue disorders or your rheumatological conditions, they are more common in females beta. That's the reason definitely even GAVE is going to be more common in females itself. Okay, so that is important. If I talk about beta, if these submucosal vessels which have dilated beta, if they rupture and if they start bleeding, the patient will have upper GI hemorrhage and will manifest as either hematemesis or melena in the emergency beta. If they ask you what is the investigation of choice, if I have to see beta whether the submucosal vessels are dilated or not, the upper GI endoscopy, upper GI endoscopy has to be the investigation of choice. Again, when we will go for an upper GI endoscopy beta, we are able to see a very classical, very classical feature in a patient of stomach. Very good beta. Yes, here you are able to see that these submucosal vessels in a patient of stomach beta, they are dilated and they are giving appearance they are giving the appearance beta which is similar to which fruit. Basically it is similar to watermelon beta. So this is classically called as a watermelon stomach. याद रखना, in a patient of GAVE, definitely the patient is going to have a watermelon stomach बच्चे. The patient is actually going to have a watermelon stomach. Okay, so if you are able to see a watermelon stomach on upper GI endoscopy beta, that means this is a classical picture of GAVE beta, gastric antral vascular ectasia. Clear to all of you now? No issues with this? Chalo. If they ask you what is going to be the treatment beta, so yaad rakhna, the treatment in this condition is nothing else but APC beta. What is APC? Argon photocoagulation. Yes, with the help of a argon photocoagulation laser beta, we are actually doing a photocoagulation of these submucosal vessels beta. Okay, so argon photocoagulation has to be done definitely, which will coagulate these dilated vessels beta, and that's the reason it will stop them from bleeding. So APC or argon photocoagulation could be done. Next important condition beta which is known to cause upper GI hemorrhage beta is important, and that is known as Menetrius disease beta. Okay, that is known as Menetrius disease. So let's discuss the non-varicose causes at least. Varices I will discuss about after the break. Okay, but अभी continuity नहीं break करते. Only one main is there, Menetrius disease. Menetrius disease, if I talk about beta, what is Menetrius disease basically? For example beta, if this is your stomach over here, we know inside the stomach beta we have what? Gastric folds, and the gastric mucosal folds jo hote beta, these gastric mucosal folds which are there beta, those are known as gastric rugae. So in patients of Menetrius disease, what happens beta? There is hypertrophy, that is increase in the number of cells. So there is hypertrophy of these gastric folds, increase in the size of cells. There is definitely beta, there is hypertrophy of these gastric folds, and as there is hypertrophy of the gastric folds beta, can you see there are giant gastric rugae which are visible now, right? There will be giant gastric rugae beta which are usually visible in the patient's stomach. That condition is classically called as Menetrius disease. So Menetrius disease is nothing else but hypertrophy bache of the gastric mucosal folds, and due to hypertrophy of the gastric mucosal folds beta, you are able to see giant gastric rugae. Okay, you are able to see the giant gastric rugae. ठीक है, याद रखना, giant gastric rugae अगर दिखता है, that has to be a case of Menetrius disease. If they ask you beta, ये जो hypertrophy होती है, या obviously on biopsy you will also be able to see hyperplasia beta of the foveolar epithelium. Yes, foveolar epithelium beta is a special epithelium in the gastric mucosa which is going to secrete the mucus beta. ठीक है, तो definitely in this condition there is hypertrophy as well as hyperplasia. So beta, please remember, this is due to what? So this is basically due to release of a chemical mediator beta or a growth factor basically, and that is called as TGF alpha. So yaad rakhna, this can be a pathology question बच्चे कि what is the growth factor responsible for this? So it is the TGF alpha beta, tissue growth factor alpha, which is actually responsible for causing Menetrius disease beta, or the hypertrophy or the hyperplasia in patients of Menetrius disease. Now if they ask you what are going to be the clinical features, I've told you beta that in this patient there will be hyperplasia of the foveolar epithelium, and ये जो foveolar epithelium है that secretes mucus. So therefore beta, there will be more and more mucus secretion in this patient, and there will be excessive loss of mucus in the patient's stools beta, बहुत ज़्यादा mucus excrete out हो जाएगा. Now mucus has two things in it beta. First thing definitely which is present are the proteins. Second, definitely as it is alkaline beta, it is going to have a lot of bicarbonates. As a lot of proteins are getting excreted out with the help with the mucus beta, therefore the patient will have a protein losing. This condition will be called as a protein losing gastropathy or a protein losing enteropathy beta. And due to that, as a lot of proteins have been lost from your body beta, due to that the patient is going to have decreased oncotic pressure leading to edema. Second important, as a lot of bicarbonates have also been lost beta, therefore the patient will go into metabolic acidosis बच्चे. ठीक है, so protein losing gastropathy or protein losing enteropathy we can call it as, and due to that definitely the patient will have edema and metabolic acidosis beta. Okay, these will be the manifestations which is seen in the patient. Okay, no issues with this? Next important that they have definitely asked what will be the other symptoms in the patient. As I've told you beta, that other symptoms can be upper GI hemorrhage, that is hematemesis. That's the reason we are studying it over here. Apart from that beta, it is a very highly pre-malignant condition, right? So pre-malignant condition, that means it may further develop into a cancer. So Menetrier disease is a pre-malignant condition which has a very high risk of a gastric adenocarcinoma. It is a highly pre-malignant condition which has a very high risk of gastric adenocarcinoma beta. That has to be remembered. Another important point to be remembered, that it is pre-malignant in nature and therefore there is a high risk of gastric adenocarcinoma. Okay. If they ask you what is the investigation of choice, so as I've told you beta, investigation of choice, if you have to see those giant gastric rugae, you have to go for an upper GI endoscopy, and if you have to confirm that whether it is a menetrier or not, we have to see the hyperplasia and therefore we have to take a biopsy. So upper GI endoscopy and biopsy beta will be the investigation of choice in this patient. When I do a upper GI endoscopy beta, we are able to see a very classical picture. And what is this? So on the upper GI endoscopy in a patient of Menetrier's disease beta, you are able to see very classical feature. Can you see the giant gastric rugae? And the giant gastric rugae beta, they are actually giving a appearance like brain over here, right? Because of sulci and that gyri like appearance. And as there is a brain like appearance on the upper GI endoscopy in patients of Menetrier's disease, this is classically called as which appearance? This is classically known as the cerebriform appearance beta. This is classically known as the cerebriform appearance. Okay? So cerebriform appearance on the upper GI endoscopy beta is very classical of Menetrier's disease. Has to be remembered. Next important, if they ask you what is done, what is seen on the histopathology. I've told you beta, when you do a biopsy and when you do a histopathological examination, on that there is hyperplasia of which epithelium? Another question of pathology beta. There is hyperplasia of the foveolar epithelium. There is hyperplasia which is of the foveolar epithelium that will be visible. Okay, so that is important again to be remembered. Hyperplasia of the foveolar cells or the foveolar epithelium will be there beta. If they ask you what is the treatment in the patient, so medical management has to be the first line choice always. Okay, so here also beta, we try to manage the patient medically initially, and medical management may we have to give the patient a drug beta which is a TGF alpha inhibitor, and that drug which is a TGF alpha inhibitor beta is known as cetuximab. So cetuximab is considered as the first line management beta in patients of Menetrier's disease. Whereas if they ask you what is the surgical management in the patient, the surgical management of the patient, if the patient does not respond to the medical management, then we go for a surgical management, and the surgical management is gastrectomy beta, because you know that the patient is having a very high risk of cancer, so better go for a gastrectomy in the patient itself beta. No issues with this, anybody? That has to be remembered. Okay, pharmacy, there can be another question, that is cetuximab. Done. That is all about your Menetrier's disease. And the last condition beta, which is a non-variceal cause of a upper GI hemorrhage bache, is nothing else but this condition over here. Now you are doing definitely upper GI endoscopy for some other reason beta, and while doing that upper GI endoscopy, you actually encounter this lesion, small lesion beta over here. What is this? This is actually a dilated submucosal arteriole beta. Yes, it is actually a dilated submucosal arteriole. And what is going to happen? This submucosal arteriole beta, it may start bleeding at any point of time. And if this submucosal arteriole may start bleeding beta, then it will bleed like a jet almost. Arteriole hai na? So therefore it will almost bleed like a jet beta. So that is the reason beta, if you have encountered this is an incidental diagnosis. Okay? So if you have encountered this beta, immediately, any which ways you are doing an endoscopy now, just pass a cautery and immediately cauterize this side beta, so that this vessel which is there beta, it should not bleed. Clear about that is important. So that condition which is there is known as a Deleufoy's lesion, which is, so Deleufoy's lesion yaad rakhna, these are nothing else but some submucosal arterioles beta which may bleed. Okay, which may bleed, and if they bleed beta, as I've told you, they will have a jet like bleeding. Okay, they may definitely have a jet like bleeding, and which can actually cause a severe upper GI hemorrhage in the patient. So इसीलिए बेटा Deleufoy's lesion you have to go for immediately, and endoscopic cauterization could be done, right? Endoscopy तो वैसे भी कर ही रहे हो तुम, so you can just go for an endoscopic cauterization immediately. You have to coagulate beta that vessel immediately with the help of a cautery, so that it should not bleed further. Clear about that is all about the Deleufoy's lesion beta. This is the Deleufoy's lesion which has been a previous year question of your examination. ठीक है, तो याद रखना है बस. चलो, so that is all about it. All the non-variceal causes. There is a variceal cause after the small break. Then we'll talk about the variceal causes or esophageal varices beta in the patient. Then we'll begin with stomach. ठीक है, चलो. So hopefully all of you are back. Now let's start with the next topic. And that is going to be the esophageal varices, or we can talk about the varicose causes of the upper GI bleeding beta, right? Now I have told you that 30% cases of upper GI hemorrhage beta, they usually occur due to the variceal causes, and variceal causes means nothing else but the esophageal varices. Now in simple terms, first of all, what did I tell you? What are esophageal varices? So in the lower part of the esophagus, okay, in the lower part of the esophagus beta, when these esophageal vessels which are there, or when these esophageal veins which are there beta, these esophageal veins will undergo dilatation beta, and they will become tortuous. These dilated tortuous esophageal vessels, these dilated and tortuous esophageal vessels beta, they may rupture and they may cause a upper GI hemorrhage. This is what is classically called as esophageal varices. So as you are able to see, that is abnormal dilatation, beta, and tortuosity of the lower esophageal vessels, okay, which may rupture and leads to a upper GI hemorrhage beta, is classically called as esophageal varices. Now it is usually seen in which patients beta? It is usually seen in patients who are already suffering from beta. It is seen in patients who are already suffering from portal hypertension. Why? Because we know beta, the lower esophageal veins known as the coronary veins or the gastric veins beta, they are actually connected with the portal venous system. So whenever the pressure inside the portal vein is going to increase, that means the patient will have portal hypertension. Even the pressure inside these lower esophageal vessels is going to increase beta, and that will lead to formation of esophageal varices. So please remember, esophageal varices will always develop after a portal hypertension, in whichever patient there is portal hypertension. And we know that portal hypertension is actually due to what? The portal hypertension is itself is a complication of cirrhosis. We know beta that cirrhosis can also be called as CLD. What is CLD? Chronic liver disease beta. Okay. Cirrhosis is also known as CLD or chronic liver disease. Understand what happens in patients of CLD beta. So we know in patients of CLD or cirrhosis beta, there is complete fibrosis of the liver. If there is fibrosis of the liver beta, please tell me, will the portal vein be able to drain its blood properly? No. And as the portal vein is not able to drain its blood properly inside the liver, therefore there is pooling of blood inside the portal vein. That causes increased pressure inside the portal veins beta. So due to a cirrhosis or chronic liver disease in the patient beta, the patient is going to develop a complication of portal hypertension. And when a patient is going to have a portal hypertension beta, due to that, there will be excessive pressure in these lower esophageal veins, leading to formation of esophageal varices as well. If they ask you beta, what are going to be the causes basically for your cirrhosis? So as I can say, any cause for cirrhosis or any cause of portal hypertension beta will ultimately lead to what? Esophageal varices. So the causes which are there beta, it can be first is extrahepatic portal vein thrombosis. Obviously, if there is thrombosis or a blockage inside the portal vein, again, the pressure inside the portal vein is going to be very high, leading to portal hypertension. Next beta, splenic vein thrombosis. I hope all of you are quite aware that a portal vein is formed by the combination of a splenic vein and the superior mesenteric vein. Yes, superior mesenteric vein and splenic vein combine together to form the portal vein beta. So splenic vein thrombosis can also cause a portal hypertension. Next important beta, it is nothing else but tumors. If there is any kind of tumor beta which can increase the risk of portal hypertension, alpha 1 antitrypsin deficiency, Wilson's disease, hemochromatosis, all these conditions. ये सब conditions क्या है बेटा? All these conditions like alpha 1 antitrypsin deficiency, or for that matter Wilson's disease and all of these are ultimately going to cause cirrhosis beta. So whether it is an alcoholic cirrhosis or a non-alcoholic cirrhosis, due to all these conditions beta, it can actually cause portal hypertension, and that will further lead to esophageal varices in the patient. Or it can also be a non-cirrhotic portal fibrosis. Yes, there is no cirrhosis in the patient, but the problem is what? There is fibrosis inside the portal vein beta. Again, that leads to portal hypertension in the patient. And last condition is a hepatic vein thrombosis, bache. Now, what is hepatic vein thrombosis? Understand. If we know beta that the portal vein drains the blood into the liver, and from the liver beta the blood goes out via the via the hepatic vein. If I say beta, the hepatic vein is itself blocked due to thrombosis. If the hepatic vein is itself blocked due to thrombosis beta, the blood will not able to go outside the liver beta. And as the blood is not able to go outside the liver, there is pooling of blood inside the liver, and ultimately there is pooling of blood in the portal vein also, leading to portal hypertension in the patient. Clear? And this hepatic vein thrombosis beta, which usually develops okay, is classically called as which syndrome? You might have discussed in pediatrics of medicine. It is classically known as the Budd-Chiari syndrome. Beta याद रखना है बात. Hepatic vein thrombosis, which is there, beta, it is known as a Budd-Chiari syndrome. Okay, that can also be one of the important reasons, beta, for causing esophageal varices in the patient. Clear है बात? So that is important. Chalo. So please remember, any patient of portal hypertension or any patient who is having a cirrhosis or chronic liver disease, beta, can obviously develop a esophageal varices, and that may cause a upper GI bleeding. Okay, so that is important. So there was a previous year question, beta, where they said a chronic alcoholic patient presents to you, beta, in the emergency with upper GI bleeding, that is hematemesis. Okay, that's it. Now, if this kind of a condition comes to you, beta, obviously it will be a very close differential diagnosis for malarious tear. But it is easy to differentiate, beta. Okay, this was a previous year FMG question. Easy to differentiate. Kaise? Here, beta, they only said the patient is a chronic alcoholic and the patient is a known case of CLD. What is a CLD? Chronic liver disease, beta. Okay, and now the patient is having bleeding, beta. Okay, so this is a direct case of esophageal varices. Agar malarious hota, then what they would have said, if they wanted to ask you about malarious, beta, they would have said chronic alcoholic patient had a binge drinking episode, okay, and after that severe vomiting or retching. वो binge drinking and severe vomiting and retching, it will never be present in a patient of esophageal varices. In a case of esophageal varices, beta, even without binge drinking and vomiting, okay, the patient starts bleeding, beta. ठीक है, but malarious में बेटा the history of binge drinking and vomiting should always be present. Clear है बात? That is important. Next, if I talk about beta, what are the clinical features in the patient? So do remember that clinical features, as the patient is having cirrhosis, beta, so obviously the patient will have liver damage and that causes jaundice. Patient will also have ascites, beta. Ascites के दो reasons है. First is portal hypertension and second is cirrhosis, which causes decreased proteins and decreased oncotic pressure. ठीक है. And lastly, the patient will have splenomegaly, because if there is portal hypertension, beta, there is pooling of blood inside the splenic vein, and ultimately there is pooling of blood inside the spleen, beta, leading to enlargement of the spleen, bache. Clear? That is important. Next important, if I talk about, is how the presentation is going to be there. As I've told you, portal hypertension jab hota hai, please remember, we know if there is portal hypertension, that is high pressure inside the portal vein, all the sites, beta, okay, all the sites of portosystemic anastomosis or the portosystemic shunts, beta, they will also have high pressure. Now, what is this portosystemic anastomosis? Those sites, beta, where the portal circulation is connected with the systemic circulation. And we know in systemic circulation, beta, we have the inferior and the superior vena cava. So therefore, systemic circulation can also be called as the caval circulation also. Okay? So beta, those sites where the portal circulation and the systemic or the caval circulation are definitely sorry, anastomose, beta, those sites are basically called as the portocaval or a portosystemic anastomosis. So jab bhi pressure in the portal vein will increase, beta, all those sites which are the sites of connection between the portal and systemic circulation, that sites will also have high pressure. So portal hypertension ki wajah se bache, there is high pressure, beta, okay, in all the sites of portosystemic anastomosis. There's high pressure in all the sites of portosystemic anastomosis, bache, or portosystemic shunts. No issues with this, anybody? And that leads to formation of what? Let's talk about that. So that is going to lead to formation of, first, beta, in the lower esophagus. Okay, in the lower esophagus, we know, beta, when the pressure inside these lower esophageal veins will increase, beta, it will lead to formation of esophageal varices. In the lower esophagus, it will lead to formation of esophageal varices. And beta, we know the esophageal varices had formed at how much pressure? So yaad rakhna hai bache, that the esophageal varices which is there, it is going to form at a pressure more than 10 mm of Hg, beta. At a pressure of more than 10 millimeters of mercury, beta, the esophageal varices are going to form. Next important, it bleeds at how much pressure, bache? So please remember, it usually bleeds at a pressure of more than 12 millimeters of mercury. This has been your previous year question in the examination, beta. So do remember that अच्छे से, ठीक है? So the esophageal varices form at a pressure of more than 10 millimeter and actually bleeds at a pressure of more than 12 millimeters of mercury. That has to be remembered. Okay. Now important is, beta, please remember that in the periumbilical area also there is a connection between the portal and the systemic circulation. In the periumbilical area, beta, in these area, all these veins which are there now, they are also going to drain into the superior mesenteric vein, and superior mesenteric vein ultimately drains into the portal vein. Therefore, when the pressure in the portal vein will be high, the pressure in the superior mesenteric vein will be high, and that's the reason the pressure inside these periumbilical veins will be high. And when the pressure inside these periumbilical veins is high, can you see all these periumbilical veins, beta, they have undergone dilatation and extreme tortuosity, beta. Okay, they have undergone dilatation and extreme tortuosity, beta. This is classically looking like the hairs or head of Medusa, beta. This is classically called as what appearance? This is classically called as the caput medusae, bache. This classically, it has been an image based question of your exam, beta. It's classically known as the caput medusae, beta. Okay, याद रखना. Important is in the periumbilical region, beta, when there is increased pressure in the portosystemic anastomosis, it leads to formation of caput medusae, beta. That has to be remembered. And lastly, beta, if there is increased pressure in the rectal vessels, yes, in the rectum also, beta, there is basically the veins which are connected with the portal vein. So therefore, the pressure inside these rectal vessels are also going to increase. And when the pressure inside these rectal vessels will increase, they will undergo dilatation and become tortuous. These rectal vessels, when they will become dilated and tortuous, beta, will be called as rectal varices. And some of the rectal varices are known as hemorrhoids, beta. Some of the rectal varices which will be there, which will be known as hemorrhoids. Clear है? So a patient of definitely beta portal hypertension may have esophageal varices, may have caput medusae, or may have rectal varices known as hemorrhoids, beta. ठीक है? So these are the things that will happen if a patient is already suffering from a portal hypertension. चलो, done with this now. Important is beta, what should be the investigation of choice? If a patient comes to us in the emergency bache with the upper GI bleeding and you suspect it to be a case of beta esophageal varices. Kaise? For example, the patient will be a chronic alcoholic. Second, the patient may be a known case of CLD, that is chronic liver disease or cirrhosis. Or even if he is not a diagnosed case, you will be able to see jaundice, ascites, splenomegaly-like features, right? So obviously, along with that, if the patient is having upper GI bleeding, I suspect okay, the bleeding may be due to a ruptured esophageal varices, beta. Okay? So investigation of choice has to be what? Investigation of choice has to be a upper GI endoscopy. Okay? The investigation of choice has to be an upper GI endoscopy, beta. And when we go for an upper GI endoscopy, beta, you will be able to see this kind of a picture. This is the upper GI endoscopy, beta, which is done. And on that upper GI endoscopy, are you able to see all these dilated vessels, beta? These dilated vessels in the lower esophagus, beta, are what are called as esophageal varices, beta. Okay? So upper GI endoscopy is definitely the investigation of choice. If they ask you what is the first line management, as usual, beta, as I've always told you, that whenever a patient comes to you with a bleeding in the emergency, the first line management is to save the life of a patient, to keep your patient stable. And for that, you have to go for a basic resuscitation, beta. You have to take care of the patient's airway, breathing, circulation. In the circulation, you always have to give patient IV fluids, beta, right? You have to give IV fluids in the patient. So that has to be remembered. Now, important is if they ask you what is the drug of choice. So I hope all of you are quite aware, beta, for a bleeding esophageal varices, the drug of choice definitely, bache. No. Not every hemorrhoid is due to portal hypertension. No, bhai. Hemorrhoids definitely can be due to chronic constipation. That is a more common reason. Okay. So drug of choice, very good. It is a somatostatin analog, beta, and that somatostatin analog which is there, it is known as octreotide, beta. So drug of choice can be IV octreotide, beta, which will be considered. That has to be remembered. Okay. So IV octreotide is definitely considered as the drug of choice. But if they say, beta, that which is definitely going to be the best agent, okay? So overall best agent अगर पूछेंगे तो answer has to be IV terlipressin, beta. IV terlipressin has to be considered, beta, as the best agent. So you'll be like, sir, why it is not the drug of choice? Please remember, beta, it is not commonly available in majority of the countries, beta. Even in India, it is very selectively available, beta. That's the reason, as it is not commonly available, beta, that's the reason we do not say that IV terlipressin is the drug of choice. Yes, in USA वगैरह, beta, they commonly use terlipressin only, but we do not have terlipressin at most of the sites. Okay, so that's the reason. Now, important is, beta, you have tried IV octreotide in the patient, you have tried IV terlipressin which was available with you, both have been tried, but the medical management has been tried, beta. Still the bleeding from this esophageal varices does not stop. Yes, the bleeding in the patient continues, beta. If the bleeding in the patient is going to continue, then what we should do, then we can go for a endoscopic procedure beta. And what is that? Understand over here. You can go for an endoscopy beta, and during an endoscopy, what we are doing over here, we are ligating the we are ligating the esophageal varices beta. We are actually holding the esophageal varices, and at the base of the esophageal varices beta, we are actually applying this band. Can you see this band out here beta? This band which is there on the endoscope, you are going to apply this band beta at the base of the hemorrhoid. Why? Because once you apply the band at the base of the hemorrhoid, the blood supplied of the at the base of the varices beta, the blood supply to the variceal mass is going to decrease, and as the blood supply to the variceal mass decreases, the size of the varices is going to reduce beta. That is what we want basically. This procedure is what is called as an endoscopic banding. Banding is done beta. If banding fails beta, then what is another option? If banding is going to fail beta, then we have to go for this procedure. What is this? Here you can see banding has been tried first, because banding is a much safer procedure beta. That's the reason you can see the band has been applied already. So banding has been tried. Even after that beta, the bleeding continues. Then we have to inject a sclerosing substance in the base of the esophageal varices beta. Why? Because that sclerosing substance which is there beta, it is going to cause fibrosis, and as there will be fibrosis at the base of the esophageal varices, again the blood supply to this varices will cut off beta, and due to that the mass which is there, it is again going to shrink beta. And this is what is known as sclerotherapy. Yesterday itself I told you beta, in varicose veins also we use a foam sclerotherapy. And what was the sclerosing agent used? It was 3% sodium tetradecyl sulfate, right? That is important. If the bleeding continues beta in the patient, as I told you, if you have done the medical management, still the bleeding continues, then what is the first procedure to be done? Yaad rakhna, whether it is hemorrhoids or it is esophageal varices beta, the first procedure should always be banding beta, because it is much safer. Okay, if banding fails, then we can definitely go for a sclerotherapy in the patient beta. Okay, then we can go for a sclerotherapy. So banding followed by sclerotherapy should be an option after this beta. Once sclerotherapy has also been tried beta, but it has also failed. Okay, that even if the sclerotherapy also fails beta, then the only option left with us beta is a surgery. And in the surgery, what we do, understand bache, in the surgery here you are able to see what is the problem beta in this patient, that the pressure inside the portal vein which is there beta, it is very high. Okay, you have to reduce the pressure inside the portal vein. How you can do that? Understand now. Here beta, what we do basically, can you see this special shunt over here? We are actually placing a special stent beta, okay, or a shunt. Definitely this is a graft beta that we are actually placing. This is a shunting graft beta. This graft basically we are placing between the portal vein branch and the hepatic vein beta in the liver. Now what is going to happen due to this? As you place definitely a graft beta between the portal vein and the hepatic vein beta, the blood from the portal vein, okay, the extra blood from the portal vein which is there beta, it is able to drain into the hepatic vein. And as the extra blood from the portal vein goes into the hepatic vein, definitely beta, the pressure inside the portal vein is going to reduce definitely. And as the pressure inside the portal vein reduces, okay, obviously beta, the pressure at all the portosystemic sites which is there, okay, is going to reduce. So therefore the pressure at the esophageal varices which are there beta, over there also the pressure in the esophageal varices is going to reduce, okay, and the bleeding is going to stop. Clear hai baat? So if nothing helps beta, then we actually have to place a shunt basically between the portal vein and the hepatic venous branches beta, and this is what is classically called as beta the transjugular intrahepatic portosystemic shunt, because we have made a shunting between the portal and the systemic circulation beta. Clear hai baat? So this is what is called as TIPS beta. Okay, so if this fails definitely, then we can go for a surgery that is known as TIPS. And what is TIPS? Yaad rakhna, it is nothing else but a transjugular, okay, it is nothing else but transjugular intrahepatic portosystemic shunt. Clear hai baat? That is the surgery that is done as the last choice beta in bleeding esophageal varices. If the bleeding doesn't stop, then the last choice that we can go for is this. Now important is beta that TIPS which is there, it can be the final surgery, but the problem is beta, now till the surgery you are not going to immediately take up the patient for surgery. Now you have to prepare for surgery first, obviously. So till that time beta, how are we going to stop the bleeding basically? Okay, till the time the patient goes for a surgery beta, until the surgery is done, how to control the bleeding? So to stop the bleeding temporarily, beta, we have certain tubes. Okay, so there are certain tubes, beta, to temporarily stop the bleeding, bache. Okay, and these tubes which are there, they have balloons inside it. So these balloons which are there, beta, they will be inflated, and what they will cause, we know. For example, you have inserted the tube inside the esophagus, and now the balloon which was there, beta, it has been inflated. As the balloon will be inflated, beta, what is going to cause? It is actually going to put pressure on the esophageal wall, and we know the best method to control bleeding is what? Direct pressure. So here the balloon which is inflated, beta, it is going to put direct pressure on the esophageal wall, beta, and it can actually help us to control the bleeding, beta. There are three tubes definitely that we can use, beta, over here. The first tube that is more commonly used, and it was a previous year image based question of your examination, beta, and that is this one over here. Now this tube you are able to see, beta, it has basically how many ports? So please remember, beta, it has three ports over here. Okay, these are the two ports, beta, via which you are actually going to inflate the balloon. Yes, because how many balloons we have? Two balloons we have. One is the gastric balloon, which will be at the level of gastroesophageal junction or the cardia, and second is the esophageal balloon, beta, which will be inside the esophagus. So these two ports which are there, beta, they are generally used to inflate these balloons over here. Third port क्यों होता है बेटा? So this end of the tube which is there, beta, will be inside the stomach. So this third port which is there, बच्चे, it is for the aspiration of blood. Yes. Now even if definitely we are trying to control the bleed, beta, there will be a lot of blood bleeding which will happen, na? So all the blood which is collected inside the stomach, beta, we can aspirate that back with the help of this third port over here. Okay, so the third port is for aspiration, and this tube over here, beta, is classically called as the Sengstaken-Blakemore tube. This tube which is over here, beta, is classically known as the Sengstaken-Blakemore tube. Clear about that? Is important. Apart from that, beta, what is the second type, the second tube that we are having, bache? What is the second tube that we are having over here? The second tube which is there, beta, the second tube which is there, definitely it has how many ports? It has four ports over here, beta, and these four ports definitely which are there, beta. Okay, two of them are again for inflating the balloons, beta. One is the gastric balloon, second is the esophageal balloon that we have again. Okay, apart from that, beta, there are two ports basically. Why there are two ports? One port, beta, is for aspiration of blood from the stomach, and one port is for the aspiration of blood from the esophagus. Yes, so that is important, beta. Here there will be two ports for the aspiration purpose also. And this tube is which one, beta? This tube which is shown in the second picture is going to be called as the Minnesota tube, beta. Clear about this tube which is there in the second picture, beta, is known as the Minnesota tube. And the third tube which is there, beta, is here you are only having one balloon, beta, which will be at the level of gastroesophageal junction of the cardia. This gastric balloon will be there, beta. Okay, there is only one balloon in the tube, beta. This tube which is there is known as the Linton's tube, beta. Okay, this tube which is there is known as the Linton's tube. That has to be remembered. Clear? Hai? The most common one that we use, beta, in clinical practice is the Sengstaken-Blakemore tube, and it has been asked in your exams. But the other ones which is there, Minnesota is a better one, beta, because it has two or four ports basically. Okay, the Minnesota tube and Linton's tube is there. Now if they ask you, once the bleeding has been controlled, beta, in the patient of esophageal varices, and now you have to send the patient back home, obviously, beta, the patient should not bleed in the future. For that, we should give a drug for prophylaxis, beta, or for the prevention. So what is going to be the drug of choice, beta, for prophylaxis? What is going to be the drug of choice for the prevention or the prophylaxis of esophageal varices, so that the patient should not come to you with bleeding the next time? So drug of choice for prevention or prophylaxis has to be an oral tablet, beta, and that should be a non-selective beta blocker which will help in decreasing the pressure, known as propranolol. So oral propranolol which is there, beta, it has to be definitely the drug of choice for controlling the bleeding. So oral propranolol is the drug of choice for prevention, not for bleeding esophageal varices. Yaad rakhna ye baat, that in bleeding esophageal varices we do not give propranolol. Okay, it is just after the bleeding has stopped and when the patient will be sent back home. Those patients may definitely only propranolol is given. Clear hai? So that was all about the management, beta, in a patient of a esophageal varices. Now let's talk about, that was all about your upper GI bleeding and esophagus also. Now let's talk about the stomach, beta, the next part. If I talk about stomach, bache, the first condition that we are going to discuss in the stomach, beta, is nothing else but CHPS or IHPS, beta. Now what is the condition known as CHPS or IHPS? So CHPS means congenital hypertrophic pyloric stenosis, beta, or IHPS when you say, it is nothing else but, beta, idiopathic or infantile. Okay, we can use both the terms, idiopathic or infantile hypertrophic pyloric stenosis bache. Now first of all, what is this condition? So understand, we know beta in the stomach there are four parts bache. We definitely have the fundus, we have the body, we have the antrum, and then we have the pylorus beta. So what is going to be seen at the level of the pylorus beta? So in the pylorus beta, what happens over here is basically all these pyloric muscles which are there beta, they undergo hypertrophy. Can you see, as all these pyloric muscles have undergone hypertrophy definitely? What is the problem due to that? The gastric outlet of the patient which is there beta, it has become very narrow. And as the gastric outlet of the patients becomes very narrow beta, there is a gastric outlet obstruction which is there. Okay? So this is the problem beta. Clear hai baat? So congenital, that means which is present since birth. Okay, hypertrophic means there is hypertrophy of the pyloric musculature, and pyloric stenosis means due to this hypertrophy of the pyloric muscles beta, there is narrowing of the pyloric canal, and that is what is called as stenosis. Clear about? So that condition is known as congenital hypertrophic pyloric stenosis. Please remember beta, here as the pylorus is narrowed down beta, and definitely as there is a gastric outlet obstruction. So please remember, the most common cause of gastric outlet obstruction in a neonate, only in a neonate, is CHPS beta. Okay? So here what is going to be the problem now? Whenever you eat food beta, the food is obviously not able to travel further from the stomach into the duodenum. So the patient definitely has beta. All the food is going to go back, and therefore the patient is going to have vomiting beta. Yes, the patient will have a chronic vomiting over here. That has to be the presentation. Here beta, the food is coming back from the stomach. So it will be a bilious vomiting or a non-bilious vomiting bache. It is going to be a non-bilious vomiting. Reason beta, it does not contain bile inside it. Okay, because the food has come back from the stomach itself, and bile usually mixes with the food in the second part of duodenum, right? That is the reason this is going to be a non-bilious vomiting. And here remember that the patient does not present to you at birth immediately. Reason, here there is narrowing, not a complete blockage beta. That is the reason beta, initially for the first 2 to 3 weeks, the appetite of the baby is going to be very less beta, 10 ml, 20 ml of milk he drinks. Okay, that is able to slowly pass via beta the narrowed pylorus. But as the baby's age is going to increase, the hypertrophy is going to get more severe, and now the baby's appetite at the same time is also going to increase beta. And that is the reason now the baby will have the chronic vomiting. So the symptoms which are there in a patient of CHPS do not immediately start at birth. They usually appear after 2 to 3 weeks of life. Now when I said non-bilious vomiting and the symptoms appear after 2 to 3 weeks beta, these 2 points will help us differentiating it from another condition beta, and that condition is duodenal atresia. Now in duodenal atresia beta, what is the problem? That the duodenum which is there, two parts of the duodenum have not fused with each other. As the duodenum does not fuse with each other beta, that's the reason again there is a complete obstruction over there. But over there is a complete obstruction, not a narrowing. That's the reason beta, the patient will have chronic vomiting, but those symptoms will immediately start at birth itself beta. And second thing, over there the food is coming back from the duodenum, therefore the bile has mixed with the food, therefore the vomiting is going to have bile inside it beta, and therefore it will be a bilious vomiting. So when they say bilious vomiting and the symptoms immediately start at birth, then the diagnosis has to be a case of duodenal atresia. But when they say definitely beta non-bilious vomiting and the symptoms have usually started after 2 to 3 weeks of life, it is a case of CHPS. Okay, so that is important thing beta, to always differentiate between both the conditions. If they say CHPS is more common in, तो याद रखना CHPS is going to be more common in the first male child of the family. CHPS is going to be most commonly seen in the first male child of the family beta, very common. And if they ask you how much is the male to female ratio, तो याद रखना है बच्चे, the male to female ratio which is there, it is approximately 4:1. यहाँ पे you can remember 4:4:4 beta. Reason, male is to female ratio is 4:1. Second, the symptoms usually start after 2 to 3 weeks, matlab in the 4th week of life. Okay. Third, the ultrasound will show a pyloric thickening, and that pyloric thickness which is there, it is more than 4 millimeter, that is diagnostic. So 4:4:4. Okay, so please remember beta, the male to female ratio is 4:1, and the first male child of the family beta will have highest risk of developing CHPS. Next important beta, it is associated with intake of which drug? Very classical common question from your examination beta. We know that macrolide antibiotics are usually safe to be given during pregnancy, but one of them beta, known as erythromycin, if the mother takes erythromycin during pregnancy beta, the patient or the baby is going to have a very high chance of CHPS beta. Clear? So याद रखना, CHPS is commonly associated. CHPS is commonly associated with a with intake of what? With intake of erythromycin during pregnancy by the mother. If that mother has taken erythromycin beta during the pregnancy, okay, she will be at a very the baby will be at a very high risk of developing CHPS beta. That is important. Next important, if I talk about bache, is hypertrophied pylorus. Now, what are the reason? See, now what will be the problems beta? We know as the baby is going to have chronic vomiting over here, the baby will actually have a lot of metabolic and electrolyte disturbances beta. वो देखने हमें, because a lot of questions on electrolyte disturbances have been asked, but we do not have to rectify it. That is a very logical explanation beta why these electrolyte disturbances develop. Let's see them one by one. So chalo, as the patient is having beta a hypertrophied pylorus over here, as the baby is having a hypertrophied pylorus over here, that is going to cause a functional gastric outlet obstruction, right? Due to that, there is a functional gastric outlet obstruction in the neonate. And as there is a gastric outlet obstruction beta, due to that, the baby or the patient is having a chronic vomiting beta. As there is a chronic vomiting, there is the food coming back from the stomach. So in the vomiting beta, it is not only the food which is lost, it is even the acid of the stomach which is lost beta, right? So the patient is going to have extreme loss of HCl beta. And as there is going to be extreme loss of HCl beta, HCl जब loss होगा, दो चीजें loss हो रही है. First is H plus ions beta. We know H plus ions are acidic in nature, and if an acidic substance is lost from your body, you will land up into metabolic alkalosis beta. First thing. Second, Cl minus, that is chloride ions are lost beta. So as there is loss of chloride ions, the patient will have hypochloremia. So due to loss of HCl, the first two electrolyte disturbances which we will have, first is definitely hypochloremia beta with metabolic alkalosis. So the baby is going to develop hypochloremia with metabolic alkalosis beta. That will be the first feature. Okay. Next, now, as the body has gone into metabolic alkalosis, I hope all of you are quite aware from physiology beta that the body will always want to maintain a normal pH beta, a physiological pH or a homeostasis. That's the reason beta, the body will try to bring back the pH to normal. The pH has become alkaline, so it will try to bring back the pH to normal beta. As there is alkalosis in the body, so what the body has to do to bring back the pH to normal? It has to throw out the alkaline substances from the body beta. Why? Because if the alkaline substances will be thrown out from the body, the pH will come back to the normal beta. Okay, so that is what is that. And the alkaline substances that we have is nothing else but bicarbonate. So the body will start losing bicarbonates in the urine beta. Okay, so in the kidneys beta, in the nephrons, definitely in the tubules, we have some transporters beta which are known to reabsorb bicarbonate. So अब क्या होगा, all those transporters which are there beta, those will get inhibited, and if those transporters which reabsorb the bicarbonates are inhibited, obviously the reabsorption of bicarbonates is going to stop, and therefore all the bicarbonates will be lost in the urine. This is fine, but beta, the problem is what? These same transporters which were responsible for the reabsorption of bicarbonates beta were also responsible for the reabsorption of sodium. So अब, as these transporters have got inhibited, not only the bicarbonates are going to be lost beta, even sodium will be lost in the patient's urine. Okay, there will be natriuresis. And as a lot of sodium will be lost in the patient's urine beta, that's the reason the patient is going to develop the second electrolyte disturbance, and loss of sodium which is there beta is called as hypo. Less amount of sodium in the blood will be called as hyponatremia. Now we know beta that body can tolerate anything, but body can never tolerate beta hyponatremia or low sodium levels. So immediately beta, to restore the sodium levels back to normal, okay, वापस उसको normal करने के लिए, the body is going to activate a system beta, and that system is called as RAS, that is known as renin angiotensin aldosterone system beta. ठीक है. If I talk about this renin angiotensin aldosterone system, what is the final product in this system? It is the aldosterone. Aldosterone has two main functions beta. The first function is reabsorption of sodium and water in the body. It will keep sodium and water in the body beta, so therefore it will help in hyponatremia. Second, it will kick out at the same time beta, it is going to kick out the potassium ions and H plus ions in the urine. Okay. Now as the aldosterone has come into action beta, it causes retention of sodium and okay, loss of H plus ions and potassium at the same time. As it is going to cause beta retention of sodium and loss of H plus ions and potassium, what will be the problems? Let's see now. As there is retention of sodium beta, the patient now develops hypernatremia. Okay, yes. So when the patient comes to you in the compensated state beta of CHPS, the patient may have hypernatremia in the body. Okay, so that is important. Whereas beta, as there is loss of H plus and potassium ions, as there has been a loss of H plus and potassium ions, that's the reason now the patient would have developed what? The patient beta would have developed hypokalemia because there is loss of potassium, and we know H plus ions are also lost in urine beta. We know that H plus ions are acidic in nature, and if acidic ions are lost in urine, there will be aciduria in the patient. Problem kya hai beta? We were already having loss of acid now. Do you want more amount of acid loss from the body? No. So this is normal or this is paradoxical? ये तो उल्टा हो रहा है. This is paradoxical. That's the reason beta this is called as a paradoxical aciduria, right? So please remember hypokalemia with a paradoxical aciduria. Got the whole logic? Okay, so that is important beta. So if they ask you what is going to be the electrolyte disturbance in the patient beta, you remember that the whole electrolyte disturbance, if they ask you, answer is hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paradoxical aciduria. ठीक है, तो hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis with paradoxical aciduria is the final electrolyte disturbance that you need to remember. Clear है बात? That is important. चलो. So now what will be the this is the electrolyte disturbance बेटा याद रखना है. This has been asked in your exams. ठीक है, अगस्त में भी है और उसके बाद भी एक बार आया है. Clinical features, if they ask you beta, so as I told you, the child is going to be normal at birth beta. The child may not have any kind of symptoms at birth immediately, but as the child grows beta, the symptoms start developing, and the symptoms usually start developing after 2 to 3 weeks beta. The symptoms are going to appear beta. Beta repeat करने के लिए there is everything in line which we have written. The patient has loss of HCl in the vomiting. Due to that, there is patient is having hypochloremia, and that causes metabolic alkalosis क्योंकि acid loss हो रहा है. Due to that, the patient is having, now as there is metabolic alkalosis in the patient's body, therefore the body will try to bring back the pH to normal. Therefore, there is loss of bicarbonates which are alkaline. So body is trying to lose the bicarbonates, and but the bicarbonates के साथ साथ there is loss of sodium also. That's the reason the patient has hyponatremia. Hyponatremia होता है, so the body wants to bring the sodium levels back to normal. Therefore, it activates the RAS. RAS which is there, the final product in RAS is going to be aldosterone. ठीक है, aldosterone which is there is going to cause retention of sodium, which leads to hypernatremia. And at the same time, aldosterone also causes loss of H plus ions and potassium from the body, which causes hypokalemia and paradoxical aciduria. Clear है बात? चलो. Next important, if I talk about beta, as I told you, symptoms usually appear after 2 to 3 weeks, and the baby is going to have what symptom mainly? Projectile vomiting is going to be there in the baby. And this projectile vomiting which is there beta, it will be bilious or non-bilious? It is going to be non-bilious in nature. Okay, so that has to be remembered. So symptoms appear after 2 to 3 weeks, and the symptom is nothing else but a non-bilious vomiting. Now, if they ask you beta on palpation, what will be felt? See this hypertrophic pylorus which is there beta. When you palpate the epigastrium of the patient, na, this hypertrophic pylorus basically it feels like a olive-shaped lump beta. Okay, that hypertrophic pylorus which is there, uski wajah se you are able to actually feel a you are actually able to feel beta a olive-shaped lump in the epigastrium. If they say sausage-shaped lump beta, then the diagnosis is usually beta intussusception. But if they say olive-shaped lump beta, then the diagnosis is usually CHPS. This is a keyword for your question. Olive-shaped lump अगर बोलते हैं beta, that is going to be one of the important keywords for your question. याद रखना है, keywords याद रखने होते हैं. Next important, as the pylorus is hypertrophied over here beta, therefore when the baby is going to feed beta, when the baby is going to feed beta, and definitely when the milk is going to pass via this hypertrophied pylorus, the peristalsis will be very strong, and that strong peristalsis which is there, it will be visible externally also. So you'll ask the mother to feed the baby, and then you'll be able to see that you are able to see the peristalsis in the baby's epigastrium. So there can be visible peristalsis beta while feeding. Definitely it is not seen normally, right? So that is important. If they ask you now what is the investigation of choice, so usually remember beta, we try to do ultrasound only in the neonates beta. If there is no other option available, then only we go for a CECT. But in this condition of CHPS beta, easily an ultrasound will be able to give us a diagnosis. Okay, so investigation of choice which is there beta, we can definitely go for an ultrasound abdomen. And when we go for an ultrasound abdomen beta, we'll be able to see a thickened pylorus. The recent examination, NEET PG had a picture of ultrasound abdomen of this beta. So do remember that here you will definitely be able to see beta thickening of the pylorus, and that pyloric thickness will be how much? That pyloric thickness would be more than 4 millimeter beta. So if the pyloric thickness is even more than 4 beta, that is what is diagnostic of a CHPS. When the pyloric thickness on ultrasound abdomen is more than 4 that is diagnostic of CHPS. Next important, we can also go for a X-ray beta. Okay, investigation of choice is ultrasound, but apart from that, we can go for an X-ray abdomen. And when we can go for an X-ray abdomen beta, we are able to see a very classical sign beta. On the X-ray abdo, we are able to see this classical sign where only the gastric bubble is visible beta. And how many bubble is seen? Only single bubble beta. So this is classically called as a single bubble sign. So when that X-ray abdomen shows a single bubble sign, bache, that is very classical of CHPS or congenital hypertrophic pyloric stenosis in the patient. Clear about? Next important, if I talk about beta, this picture over here is of a barium meal now. Why I'm started calling it as meal? Because we are doing the barium study for the stomach beta. And as you will do a barium study for the stomach, that's the reason we are going to call it as barium meal beta. If I talk about the barium meal, bache, here you are able to see now the barium is actually passing via that narrow pyloric lumen beta. And as the barium is passing via that narrow pyloric lumen beta, this is actually giving us a very classical appearance. And what is this sign called as? This is classically called as the string sign beta. Okay, it looks like a string now. This is classically known as the string sign. First thing. Second important beta, here you are able to see definitely this after the barium goes out of the pylorus beta, then it spreads into the duodenum, right? Because duodenum is not narrow. That's the reason beta you are able to see this classical appearance, and that is nothing else but the classical mushroom sign beta. So you will be able to see the mushroom sign, umbrella sign, jo bhi bolna hai isko. So please remember beta, the classical signs that are visible on a barium meal in a patient of CHPS. One is going to be the mushroom sign beta, and the second is going to be the string sign bache. Okay, so that is important. And ये जो दिख रहा है ना, this looks like a shoulder basically, so it can be called as a shoulder sign also. This one over here can be called as a shoulder sign. Okay, so these are the important signs beta which are usually visible in the patient of CHPS. Now what should be the treatment in this patient? Let's talk about that. If I talk about the treatment beta in this patient, it is going to be, as the baby has come to us after a chronic vomiting beta, obviously the baby is going to have a severe dehydration. So therefore we have to correct the dehydration in the baby beta by giving IV fluids. But along with that beta, at the same time we have to keep in mind that we don't only have to correct the dehydration, we also have to correct the metabolic disturbances or the electrolyte disturbances which have happened in the baby beta. Okay, so we have to choose the fluid accordingly. So yaad rakhna hai baat. Now if I talk about beta, that which could be a better fluid beta. So if they ask you what is the best fluid beta to be used in a baby of CHPS beta, the best fluid to be used in a baby of CHPS beta, what it is going to be. So yaad rakhna sabse pehle, if the baby has come to you later beta, okay, if the baby has come to you very late, that time definitely beta, the baby is going to have what? The baby will definitely have beta higher risk of hypernatremia. So if the baby has come to us late beta, the body would have started compensation. इसकी वजह से the baby may be in hypernatremia. इसीलिए बेटा we should not load the patient with too much amount of sodium. So इसलिए what we do, we take the normal saline beta and then we definitely dilute the normal saline beta. Okay, we dilute the normal saline. How? We will take equal amount of normal saline and equal amount of distilled water beta. That is what is done basically for dilution, and then we reduce the concentration of normal saline to half beta. Normally we know normal saline has 0.9% NaCl beta. As we have diluted the normal saline over here, it will become 0.45% NaCl. Okay? So here definitely we will take NS by 2 beta, and that NS by 2 is nothing else but half normal saline we call it as, and that is going to be 0.45% NaCl which. Okay, first thing. Along with that, the most important thing beta, as the baby is having chronic vomiting beta, baby is not having proper nutrition. So therefore for the purpose of nutrition beta, we have to add 5% dextrose in the fluid beta. Along with that definitely beta, what we have to do, here the baby is definitely having beta, what problem? The baby is having hypokalemia as well as hypochloremia. We can correct that beta by giving a single injection basically, and that is an injection of what? KCl beta. So you have to add KCl to the fluid as well beta. KCl is what? Potassium chloride. It will correct hypokalemia also and hypochloremia also beta. So this can be considered as the best fluid beta in the examination. If this isn't the option beta, this should be considered as the best fluid. That is nothing else but half normal saline, 5% dextrose along with KCl together. But अगर ये option में नहीं है, please tell me what should be the second best choice. If this is not an option, what should be the second best choice? Two options I'll give you. One is normal saline, second is ringer lactate. One is normal saline, second is ringer lactate. What is the better fluid to be used? Please tell me that. Now, till that I'll tell you the definitive treatment. याद रखना, the definitive treatment for THPS is going to be beta. What we have to do? We just have to make multiple cuts or multiple incisions on the hypertrophic pylorus beta. Reason: if we make multiple cuts or incisions on the hypertrophic pylorus, the pyloric muscles are going to relax, and as these pyloric muscles are going to relax beta, the pyloric canal is going to widen up so that the food can easily pass by the pylorus beta. Okay, and making multiple cuts over the pyloric muscles will be called as pyloromyotomy, and this was done by a surgeon beta who is known as Ramsted's basically. So this is classically known as the Ramsted's pyloromyotomy beta. It is classically known as the Ramsted's pyloromyotomy. No issues with this. Or surgery of choice or the definitive treatment of choice which is there beta, it is going to be Ramsted's pyloromyotomy. Please remember, what is preferred as the second best fluid has to be only normal saline beta. Only normal saline will be preferred. Ringer lactate is not usually recommended in this patient beta. Why ringer lactate is not recommended in the patient? The reason being beta, yaad rakhna that rather I would say that ringer lactate is avoided in this patient. ठीक है, तो क्या avoid करते, कौन सा fluid करते avoid अपन? तो please remember, you have to avoid ringer lactate in the baby beta. Why you have to avoid ringer lactate? Reason: lactate which is there beta, it is going to get broken down in the body. And when lactate is going to get broken down in the body beta, it is going to release bicarbonates. And as bicarbonates will be released beta, the patient will land up into metabolic alkalosis. Already the baby is in metabolic alkalosis beta, so we do not have to worsen the metabolic alkalosis component in the baby. And that's the reason definitely what will be preferred as the second best choice. Answer is normal saline. And this has come in your earlier examination beta. Okay, so that is important. No issues with this. Next important beta, if I talk about that, if there was an eventful surgery beta, if there has been an eventful surgery matlab if there has been some problem during the surgery, some adverse events have happened during the surgery beta. ठीक है, तो इसका मतलब क्या है? For example beta, the cuts that we have made, they were too deep beta, and therefore we have actually damaged beta or injured the mucosa also. So if we have injured the mucosa, we had to repair the mucosa also beta, right? So if there was an eventful surgery, that means the mucosa was injured and repaired during the surgery beta, then you should not start the feeding immediately. Normally after a surgery beta, we can start the feeding usually after a span of 4 to 6 hours beta. Yes, after Ramsted's pyloromyotomy, you can start the feeding after 4 to 6 hours. But if it was eventful surgery, like when the mucosa was injured and repaired, then we have to wait for some time and we have to start the feeding after 24 to 48 hours beta. Then we have to start the feeding usually after a span of 24 to 48 hours. Clear about? That is important to be remembered. Next important, now let's discuss about the next topic, and that is going to be gastritis beta. I hope that you might have discussed it in pathology and medicine also. So let's talk about that further. Gastritis which is there beta, it is nothing else but inflammation of the stomach. Okay, gastritis is nothing else but inflammation of the stomach or the gastric mucosa beta. Okay. Now important is, as I've told you, depending on the presentation beta, gastritis can be of basically two types. Either it can be acute gastritis when the patient comes to you in the emergency with severe signs and symptoms beta, or it can be a chronic gastritis when the patient comes to you in the OPD with mild to moderate symptoms. Okay. First condition we have to talk about is nothing else but acute gastritis. Now what are the reasons why a patient will develop acute gastritis? See, acute gastritis can also be there when a patient is having chronic gastritis and there is a sudden worsening of the symptoms, right? So acute gastritis which is there beta, it is due to various reasons. The first and the most important reasons beta are drugs. And which drugs? Mainly NSAIDs. We know beta that NSAIDs which are there, those are known to cause erosive gastritis. So the history of NSAID intake will be very, very important beta in this patient. Or another condition beta, it could be due to a bacteria that is known to cause gastritis and peptic ulcer, known as H. pylori beta or Helicobacter pylori. That is also going to be one of the important reasons for causing a acute gastritis beta. And third, it can definitely be a binge drinking of alcohol beta. Yes, if you do a binge drinking of alcohol beta, the patient may have an increased risk of acute gastritis also. ठीक है, chronic alcoholism से नहीं, binge drinking of alcohol से. ठीक है. Clear है बात? That is important. Now, what will be the symptoms if a patient comes to you in the emergency with acute gastritis? The patient will have a severe epigastric pain, beta, right? A gastritis, GERD, peptic ulcer, in all the conditions, beta, patient will have a epigastric pain. So, in this condition, beta, the patient will have a severe epigastric pain, bache. Along with that, the patient will have dyspeptic symptoms. What are dyspeptic symptoms? The patient may have nausea and vomiting like features, beta. Okay, and as I've told you, acute gastritis means there can be damage or erosion of the blood vessels, beta. So the patient is actually going to have hematemesis, beta. The patient is going to have upper GI bleeding or hematemesis also. That is important. Now, if they ask you what should be the first line management, so the first line management which is there, so please remember, first line management which is there, beta, has to be basic resuscitation. Why? Because the patient has come to us in the emergency with bleeding, hematemesis chal raha hai. So the first line management has to be basic resuscitation, beta. That is nothing else but airway, breathing, circulation. Circulation के लिए you should give IV fluids to the patient, beta. So your patient will be stable. ठीक है? So basic resuscitation again first line. Now after that, beta, what should be the first line? What should be the definitive management? So definitive management should be surgical or conservative. I told you, beta, we will always try to do a conservative management in the patient if possible. So here, beta, we will try a conservative management initially. And what is that conservative management in a patient of acute gastritis? So yaad rakhna, beta, in the conservative management in this patient, bache. Okay, in the conservative management of this patient, we have to give IV, PPIs, beta. What are PPIs? Proton pump inhibitors. We know the drug of choice for GERD, gastritis or peptic ulcer disease has to be PPIs or proton pump inhibitors. So you should give, beta, intravenous PPIs, not oral ones. Okay, so definitely all your prazols which are there, definitely, beta, all those PPIs which are there, okay, those can be given intravenously. So IV PPIs is going to be considered as the conservative management of choice. But even after giving IV PPIs to the patient, beta, if the patient continues to bleed, that means the conservative management has failed. So if the conservative management fails, beta, then you have to take up the patient for an upper GI endoscopy, beta. And when I take up the patient for an upper GI endoscopy, what we will try to do? We will try to identify the blood vessel, beta, right? We will try to identify from which side it is bleeding and which is the bleeding vessel exactly. So now here you try to identify the bleeding site. There are two possibilities, that whether you are able to identify the bleeding site or you are not able to identify the bleeding site. First condition, let's see if the bleeding site is identified. If my bleeding site is identified in the stomach of the patient, beta, then what we have to do? We have to go for, beta, applying. We have any which ways done an endoscopy now, so we can definitely apply clips, beta, at the bleeding site. I told you na, to control the bleeding or to clamp the bleeding vessel, we can apply clips. So endoscopically, beta, I can definitely apply clips at the bleeding site. Second, I can use a diathermy or a cautery, beta, and with the help of diathermy or cautery, definitely you can coagulate the bleeding vessel, right? Third important, we can actually give an injection of adrenaline at the site, beta. Reason, definitely, if you will give injection of adrenaline at the site, definitely, beta, what is going to happen? We know adrenaline is a sympathetic drug. So definitely, beta, it is actually going to cause severe vasoconstriction at the site, beta, and it is actually going to stop the bleeding. Okay, so that is important. These are the things, beta, which should be done over here. First thing. Next important, beta, if they say that the bleeding site is not identified, agar wo bolte hai that the bleeding site of the patient is not identified, then what we have to go for? So if the bleeding site is not identified, you should go for an angiography in the patient first. Yes, we should inject a dye, beta, or we should inject a contrast inside the vessels, and then you have to take a X-ray. Now definitely when you will do this invasive angiography, beta, from whichever vessel, okay, whichever vessel is bleeding inside the stomach, you will be able to see, beta, the leakage of contrast from there, right? And once you have identified that bleeding site on angiography, now for the angiography you have any which ways inserted a catheter. Via that same catheter, beta, you can actually inject an embolizing substance, and you can perform an angioembolization, and you can try to control the bleed. Okay, so if the bleeding site is not identified, go for an angiography followed by an angioembolization and stop the bleeding. Okay, so that is important. Now, beta, if all of this has been tried but still it fails, beta, if everything has been tried but everything has failed, basically, if everything has failed, definitely the only option left is going to be surgery then, beta. Okay, but surgery is very, very rarely required, beta. Not even 1% cases, I would say, of acute gastritis may go for a surgery. Okay, so please remember, beta, the surgery which is there, it is very rarely required. And what is going to be the surgery? The surgery is nothing else but we have to do a gastrotomy, beta, and we have to do a surgical ligation of the vessel, beta. Okay, so please remember, we have to definitely do a gastrotomy and we have to ligate the bleeding vessel. Which do a gastrotomy and ligate the bleeding vessel. But that is the last option to be done. Beta. That is the last option to be done. Okay. Next important. Now let's talk about chronic gastritis. Chronic gastritis. That means when my patient who is there, beta, he comes basically to the OPD, beta. That is what is called as chronic gastritis. Done with this now. So when I say chronic gastritis, bache, please remember the patient is going to come to me in the OPD with complaints of what, beta? A very long standing epigastric pain. Yes, he will give you a history of almost months together, beta, like 3 months, 4 months, aisa. Okay, the patient will come to you, beta, with a long standing history of epigastric pain. Along with, beta, the patient may have dyspeptic symptoms like nausea, vomiting, and other dyspeptic symptoms like bloating will be there, beta, right? So nausea, vomiting, and other dyspeptic symptoms will be there in the patient. Investigation of choice, which is there, beta, here in any patient. We will talk about the causes of chronic gastritis, beta. There are multiple causes, but yes, investigation of choice, which is there, beta, for all the cases of chronic gastritis, has to be an upper GI endoscopy, beta. But with an upper GI endoscopy, beta, it is always better that we take up an upper GI endoscopy, beta. With an upper GI endoscopy, it is always better that if we take a biopsy, beta. Reason is we never know that if it is only a case of chronic gastritis or it has already progressed to the stage of cancer, beta. That's the reason to rule out the cancer. It is always better to take a biopsy if you are able to see any kind of changes. So plus minus, I'll write biopsy. Okay, the plus minus biopsy karte hain beta apan. So plus minus biopsy. That means if I am able to see any problematic changes, beta, I will immediately take a biopsy from that side. Okay, so upper GI endoscopy with or without biopsy, beta, is going to be the investigation of choice for chronic gastritis, bache. If they ask you what is the common drug of choice or the treatment of choice for all the cases of chronic gastritis, I have told you, beta, that this medical management of this drug has shown so wonderful results that it is not only considered as the drug of choice but even the treatment of choice nowadays, beta. And that is nothing else but your proton pump inhibitors, beta, right? So please remember your proton pump inhibitors, which are there, your PPIs, beta, they are definitely considered as a drug of choice and treatment of choice for patients of chronic gastritis, beta. Clear about? Then definitely we have to do some individual modifications, beta, according to the cause of chronic gastritis. That is what we have to see now next. Okay. So now next important is, let's talk about the first one, beta. Okay, I'm talking about the causes now. Okay, so type B में use करते हैं. So now first of all, beta, if I talk about first is type A basically. Now when I talk about type A, beta, it is nothing else but A for autoimmune gastritis. Okay, so if I talk about type A, beta, A stands for autoimmune gastritis, beta. Okay, if I talk about autoimmune gastritis, which autoimmune means what? Here your immune system forms antibodies and those antibodies are going to target your own body cells, beta. So this is the same thing which happens over here. Yeah, like now what happens over here? The antibodies which are formed, beta, these antibodies are actually going to target the parietal cells in the stomach. Yes, the antibodies are targeted against the parietal cells, beta, please remember. And I hope all of you are quite aware, the parietal cells which are present in the body of the stomach, beta, these are mainly responsible for secretion of two things, beta. One, they are responsible for the secretion of hydrochloric acid or the HCl. Second, they are responsible for the secretion of intrinsic factor of Castle, beta. Okay, so here the antibodies are going to target the parietal cells, beta, and due to damage of the parietal cells, beta, it leads to deficiency of what? It leads to deficiency of HCl, beta, that is hydrochloric acid, which is okay. It leads to deficiency of HCl, first one, that is hydrochloric acid, and decreased HCl is known as hypochlorhydria. Absence of HCl is known as achlorhydria, beta. And due to the achlorhydria, there will be malabsorption of which nutrient? Anybody? I hope all of you are quite aware, beta, that acidic medium is required for the absorption of iron. So as definitely there is HCl deficiency or achlorhydria, beta, the patient is definitely going to have deficiency of iron, beta. And if there is deficiency of iron, I hope all of you are quite aware, the patient is going to have iron deficiency anemia, beta, which will develop, right? The patient is going to have, beta, the iron deficiency anemia, which is going to develop. That is the first thing. Second important, beta, the patient will have deficiency of intrinsic factor of Castle. You might have studied in physiology that intrinsic factor of Castle is actually required for the absorption of vitamin B12, beta. Yes, intrinsic factor of Castle and vitamin B12 forms a complex, and then the vitamin B12 gets absorbed from the terminal ileum, beta. Okay? So here, if the intrinsic factor of castle is not going to be there, beta, so yaad rakhna, the patient is actually going to have beta malabsorption of vitamin B12. And if there is malabsorption of vitamin B12 or cobalamin beta, which type of anemia develops in the patient? Then the type of anemia that develops in the patient will be called as the megaloblastic anemia beta. Okay, the patient is going to have a megaloblastic anemia. Now we know that iron deficiency anemia beta, you might have studied, is basically a which kind of anemia beta? Iron deficiency anemia is a microcytic hypochromic anemia, right? And second, vitamin B12 deficiency anemia beta is a macrocytic normochromic anemia. So if both the features are seen on the peripheral blood smear of this patient beta, we are able to see both the features together. That is, we are able to see beta the microcytic hypochromic anemia also. Okay, we are able to see beta the microcytic hypochromic anemia also, and we are able to see a macrocytic anemia also beta. So if both the features are going to be seen beta together, then it actually is called as a dimorphic anemia picture. And this dimorphic anemia which is seen in the patient beta, this dimorphic anemia which is seen in the patient is classically called as the pernicious anemia. Okay, this dimorphic anemia which is seen in the picture beta is classically known as the pernicious anemia. Clear about that dimorphic anemia which is usually seen beta in the picture is known as the pernicious anemia. Hopefully that's clear to all of you now. Okay, so people directly say कि pernicious anemia होता है B12 deficiency से. It is basically a combination of both of them. Okay, no issues with this anybody? Next important, if I talk about beta, what is the treatment in the patient? So if I talk about the treatment beta, obviously we know autoimmune conditions are always treated by steroids. So here also beta, the treatment is going to be steroids basically to stop the antibody production or to suppress the immune system beta. Okay, so that is important. Next important, let's talk about type B gastritis beta. We know B stands for what? Bacterial basically. Okay, B stands for what? Bacterial beta. So type B or the bacterial gastritis which is there. We know which bacteria is responsible for causing gastritis. We know the bacteria that is responsible beta is going to be called as the Helicobacter pylori beta. The H. pylori or the Helicobacter pylori is the organism responsible for causing gastritis. It does not only cause gastritis beta, it causes other three problems also beta. And why it causes all these problems, let's try to understand that. Now please remember this Helicobacter pylori or bacteria beta, it has certain toxins. The name of those toxins have been asked in your examination. So please remember the toxins which are there in H. pylori are CAG-A, VAC-A, proteases, phospholipases, even an enzyme known as urease. Okay, all of these toxins are there beta. The patient has these toxins like CAG-A and VAC-A. These two were there in the previous year exam beta. ठीक है, जो previous year exam थे उसमें ये दोनों option थे. So CAG and VAC will be there, or there will be proteases, there will be phospholipases beta. These are definitely all the toxins which are present. Now what these toxins are going to cause? So understand. For example, beta, if I say this is the stomach of a patient, we know inside the stomach beta we have HCl. Now on one side I have told you beta that definitely the gastric mucosa is very very sensitive. On the second side we are saying that there will be HCl inside the stomach. So then how this gastric mucosa does not get damaged beta? It's because this gastric mucosa which is there beta. It's because this gastric mucosa is actually protected by a barrier beta. And this is called as the gastric acid mucus barrier beta. Yes, there is a mucus barrier basically which is formed above the gastric mucosa beta which protects it from the action of acid. Now what this H. pylori is going to do, that H. pylori beta is actually going to damage this gastric acid mucosal barrier. Okay, that H. pylori beta is usually the toxins of H. pylori is going to damage this gastric acid mucosal barrier, and as this barrier gets damaged, now the gastric mucosa comes in direct contact with the acid beta, and as the acid comes in direct contact with the mucosa beta, obviously the patient's gastric mucosa starts getting damaged. Initially there is inflammation of the gastric mucosa beta that will lead to gastritis, but later on beta there will be damage to the gastric mucosa, and damage of the gastric mucosa will lead to formation of ulcers over here beta, and that will lead to formation of gastric ulcers or peptic ulcers. Clear about? So that is important. So please remember these toxins which are released by H. pylori beta, they are actually going to cause disruption of the gastric acid mucus barrier beta, and as there is disruption of the gastric acid mucus barrier which as you can see, which part of the stomach I have highlighted, mainly antrum. So maximum damage by H. pylori is in the antrum. Okay, so there is a gastric acid mucus barrier disruption beta which happens, and due to that the patient will have four problems which can arise. First, there can be inflammation of the stomach, that I told you is gastritis, either a type B chronic gastritis or acute gastritis. Second, there can be ulceration in the gastric mucosa that will lead to peptic ulcer disease. Please remember, H. pylori does not only cause gastric ulcers, it can also lead to duodenal ulcers. Rather, it more commonly causes duodenal ulcers, beta. That is important. Third important, it can also increase the risk of cancer, beta, in the patient. And which cancer? Obviously, the stomach cancer. So the patient will have an increased risk of gastric adenocarcinoma, beta. Okay. And fourth, the patient can definitely have, beta, an increased risk of a malignancy arising from the mucosa associated lymphoid tissue of the stomach. And when the tumor or the malignancy arises from the malt tissue, beta, or the mucosa associated lymphoid tissue, that is known as a maltoma. Okay. So the four things which are there, beta. So previous year exam में they have asked which among the following is not caused by H. pylori. याद रखना, इसीलिए चारों याद होने चाहिए: gastritis, peptic ulcer disease, gastric adenocarcinoma, and maltoma. These are the four things, beta, which will be caused basically by Helicobacter pylori organism. Next important, if I talk about, beta, what is done for the purpose of diagnosis. तो याद रखना बच्चे, फॉर द पर्पस ऑफ डायग्नोसिस वी हैव टू डू व्हाट वी यूजुअली हैव टू डू, बेटा. नॉर्मल डायग्नोसिस के लिए वी कैन डू अ यूरिया ब्रेड टेस्ट, बेटा. रीजन, this H. pylori organism which is there, beta, it actually has a urease enzyme. So what it does, it actually breaks down the urea in your body, beta, and as the urea in the stomach is broken down, okay, it will be converted to ammonia. So we know that whenever the urea will be broken down, ammonia will be released, beta, and the patient will have ammonia inside his breath. So actually we are not detecting the urea, we are detecting the ammonia in the patient's breath, beta. That is called as the urea bread test. But please remember, beta, that urea bread test which is there, it is very, very non-specific, beta. That's the reason. What is a more specific and what is a better test, beta? So you have to remember one thing basically. The investigation of choice अगर पूछेंगे, बेटा, so you have to perform a rapid urease test, बच्चे. The rapid urease test is going to be the best test or the investigation of choice, and that should be done on the biopsy. Yes. So you have to do a upper GI endoscopy and biopsy. As I've told you, it is the investigation of choice for all types of gastritis. Once we have got that biopsy, beta, on that biopsy now we are actually going to add urea, beta. So we know in that biopsy, okay, we have the H. pylori. H. pylori has urease enzyme. As we will add urea over there, what is going to happen? Definitely the urea will be broken down immediately by that urease enzyme, and there will be a release of ammonia, beta. And we know ammonia has a very fishy odor basically, right? That will be seen. So investigation of choice for H. pylori organism, beta, has to be rapid urease test on the biopsy, beta, which has to be done. Clear about? If they ask you what is the stain that is used for H. pylori, I hope all of you are quite aware from micro and patho. So please remember, it is the Warden Starry Silver stain, beta. याद रखना, the Warden Starry Silver stain is generally used for the H. pylori organism. No issues with this. Next important, beta, if I talk about the eradication therapy, obviously, beta, it is a bacteria, so we have to eradicate that bacteria from your body, beta. And for the purpose of eradication, now what we should do, understand, for the purpose of eradication of this bacteria, beta, we either have to go for a triple therapy or we can go for a quadruple therapy, beta. Okay? Now what we use in a triple therapy, I hope all of you are quite studied this in pharma also. So triple therapy, beta, the mnemonic you can remember is CAP basically. C for clarithromycin, A for amoxicillin, and P for PPI, that is proton pump inhibitor. So basically triple therapy is nothing else but, beta, here we have to combine one proton pump inhibitor, beta, with two antibiotics. Okay? So one proton pump inhibitor with two antibiotics can be given. These antibiotics can be from various groups, beta. Either it can be from the penicillins more commonly, or you can also use tetracyclines as well. No issues with that. Okay? So that is important. So one PPI with two antibiotics is called as the triple therapy, beta. Whereas if they ask you what is done in quadruple therapy, तो याद रखना है quadruple therapy में, beta, we have to basically give triple therapy to the patient, that is one PPI plus two antibiotics, plus along with that we have to add a fourth agent, beta. And that fourth agent is basically called as a bismuth subsalicylate or a bismuth subcitrate, beta. Okay? So you definitely can use an agent known as bismuth subsalicylate or the bismuth subcitrate. Now what this bismuth is going to do, beta, the fourth agent, ये जो bismuth होता है, beta, basically this bismuth is actually going to form a protective covering over the gastric mucosa. And as this bismuth forms a protective covering over the gastric mucosa, beta, that is how it will prevent the gastric mucosa from the action of the acid, beta. That is what is used. Okay? So that is important. Clear? So that has to be remembered, beta. These are the triple and the quadruple therapies used for the eradication in the patient of H. pylori. Next is type C gastritis, बच्चे. If I talk about the type C gastritis now, तो याद रखना type C gastritis is C for chemical, beta. So type C gastritis is actually a chemical induced gastritis, and most of the chemical which is there beta, the major chemical which is there, those are nothing else but the drugs beta, and that drugs which are there, those are nothing else but classically NSAIDs. We know beta that NSAIDs which are there, they are actually known to cause erosive gastritis. So they can cause chronic gastritis also, or they can lead to a acute gastritis. For example beta, if you are going to cause beta, sorry, if you are definitely going to have sorry, if you are going to take NSAIDs beta for a case of migraine or fractures, definitely they can cause chronic gastritis. But if you have taken a lot of NSAIDs at one point of time, they can lead to acute gastritis beta. So type C which is there, it is a chemical induced gastritis, that has to be remembered beta. Okay, type C is nothing else but a chemical induced gastritis basically. Okay, along that is caused by drugs known as NSAIDs, or it can also occur due to alcohol beta. It can also occur due to alcohol, that has to be remembered. Okay, clarithromycin, amoxicillin, PPI, pharma में हो गया होगा ना. Now please remember beta, it is going to be causing, okay, I told you the chemical induced gastritis beta, it is going to be causing erosive gastritis beta, याद रखना. And due to erosive gastritis beta, the patient will have a very high risk of, see, erosive gastritis means what? The gastric mucosa which is there beta, it will keep on getting eroded, and due to that definitely the patient will have a very high risk of, okay, very high risk of ulcers and perforation beta. I hope all of you are quite aware that we have discussed about the perforation, hollow viscous perforation. Over there I told you beta that history of intake of NSAIDs is going to be very, very important, because NSAIDs causes erosive gastritis, then ulceration, and ultimately perforation beta. So hollow viscous perforation can be a complication beta, to be remembered. Next important beta, if they ask you, in a patient who is HIV positive beta, or a patient who is definitely having AIDS, in those patients beta, what is the important cause of gastritis? Yaad rakhna, in patients of AIDS beta, definitely. In patient of AIDS definitely beta, the cause of gastritis and diarrhea is usually the same, and that is an organism beta known as Cryptosporidium parvum. Okay, and that Cryptosporidium parvum which is there beta, it causes a condition known as cryptosporidiasis. It basically causes a condition beta known as cryptosporidiasis. So that Cryptosporidium parvum which is there beta, it is the organism which is known to cause diarrhea also and gastritis also in a patient of AIDS basically. ठीक है, इसकी oocyst size वगैरह 2 to 6 micron everything micro से. I hope all of you know, questions आते हैं इसमें से micro से. ठीक है, चलो. Next important, if I talk about beta, is the PUD. PUD is nothing else but peptic ulcer disease. Now if I talk about peptic ulcer disease beta, we know peptic ulcer disease can actually be a complication of gastritis itself, right? So the patient had a gastritis earlier, due to that there is formation of peptic ulcer disease. Okay, that can also be happening. Now we know beta that peptic ulcer is any ulcer which happens due to excessive HCl secretion. Please remember that peptic ulcer disease basically beta, याद रखना है, it can be of two types. Either it can be a gastric ulcer or it can be a duodenal ulcer beta. ठीक है, what is the more common site? We know beta the more common site for a peptic ulcer to develop has to be the duodenum. The more common site is the duodenum beta, followed by the stomach. The more common site has to be the duodenum, followed by stomach. Clear है बात? Now next important, what are the important risk factors beta that we need to know? Remember that the important risk factors which are there beta to be remembered are, the first one which is there beta, it is H. pylori, that is your Helicobacter pylori, a very important risk factor beta for causing PUD or the peptic ulcer disease. First thing. Second, again NSAIDs, because we know NSAIDs cause erosive gastritis which leads to formation of peptic ulcers beta. Later, all the S. Okay, so what is S? The first S is steroids beta basically. Okay, chronic intake of steroids can increase the risk of peptic ulcers in a patient beta, first thing. Second, smoking as usual beta is an important risk factor. Third, spirits. Now I've just made spirits basically to make it sure that you remember it. Okay, spirits is nothing else but alcohol beta. Okay, smoking and alcohol as usual. So next S is beta, spices. Okay, next S is spices basically. Extra spicy food causes excessive HCl secretion, that's the reason. Next is stress beta. I've told you that stress which is there, it leads to formation of stress induced gastric ulcers beta, the curlings in bones and Cushing's in head injury beta, right? So stress definitely can be an important risk factor. And beta, another condition is, or the risk factor is going to be a Zollinger-Ellison syndrome beta. I hope all of you are quite aware about Zollinger-Ellison syndrome. Zollinger-Ellison syndrome which is there, we have discussed that it is actually beta going to have a G cell tumor, and that G cell malignancy which is there beta is going to be called as a gastrinoma. Now when the patient is going to have a gastrinoma beta, obviously the patient will have hypersecretion of gastrin beta, and that hypersecretion of gastrin will lead to hypergastrinemia. I hope all of you are quite aware from physiology that this gastrin which is there beta is actually going to stimulate the parietal cells, and this parietal cells in response to that are going to secrete HCl or acid beta. ठीक है. So as there is hypergastrinemia beta, तो याद रखना क्या होता है, due to that the patient has a excessive HCl secretion, and as there is excessive HCl secretion beta, therefore in a patient of Zollinger-Ellison syndrome or a case of gastrinoma beta, the patient will have a giant beta, okay, giant or multiple peptic ulcer beta. ठीक है. तो प्लीज रिमेंबर इन अ पेशेंट ऑफ Zollinger-Ellison syndrome beta, there will be giant or multiple peptic ulcers beta due to excessive secretion of acid beta. ठीक है. So that is important to be remembered. Zollinger-Ellison में there is a giant or multiple peptic ulcers. Done with this. Next important beta, if they ask you what is the investigation of choice, so let's talk about beta the investigation of choice. So investigation of choice in a patient of peptic ulcer is nothing else but beta and upper GI endoscopy again plus biopsy. Okay, ulcers में biopsy is always a must beta to rule out the cancer. So upper GI endoscopy plus biopsy is definitely the investigation of choice in a patient of peptic ulcer disease. Okay. Now important is in a patient of peptic ulcer disease beta, we may also go, okay, we may also go for a barium meal, and when we do a barium meal in patients of peptic or gastric ulcers beta, we are able to see a very classical finding. I have told you the barium will never be taken at those sites beta where there is either a mass or there is definitely a ulcer beta, and due to that you are able to see this classical filling defects beta. So on the barium meal beta in a patient of peptic ulcer disease, we are able to see the classical filling defects. No issues with this. Next important beta, if I talk about the gastric ulcers which are there beta, the gastric ulcers are usually classified into 5 types. ठीक है. There are 5 types of gastric ulcers बच्चे, वो एक बार देख लेना. The 5 types of gastric ulcers that we need to know. The first one is, shall I? The first one which is there beta, here you are able to see a gastric ulcer which is usually seen on which curvature beta? So this is the greater curvature, this is the lesser curvature. So here we are able to see a gastric ulcer. Sorry. We are able to see a gastric ulcer beta along the lesser curvature of the stomach. Second important beta, it is seen in which part? Basically it is usually seen in the antrum beta. Okay, this ulcer which is there definitely बच्चे, it is usually seen in the antrum of the stomach definitely. ठीक है. So that is important beta. This is basically called as the type 1 gastric ulcer. ठीक है. So जो type 1 gastric ulcer होता है definitely beta, it is usually seen along the lesser curvature. The type 1 gastric ulcer is usually seen along the lesser curvature beta. Now the type 2 gastric ulcer which is there beta, you are able to see the type 2 gastric ulcer. Basically there is multiple ulcers beta in type 2. Type 2 में one definitely ulcer is in the pyloric region beta. The other one which is there beta, it is usually in the upper part of the stomach basically. Okay, it can be anywhere here. ठीक है. तो please remember beta, there are basically multiple gastric ulcers over here beta. So please remember in in type 2 gastric ulcer which is there, in type 2 gastric ulcer beta, there are 2 types of ulcers definitely over here beta. One definitely is going to be in the pyloric region or the pre-pyloric region beta, and second which is there beta, it can be in the proximal part basically, right? One is definitely in the proximal part and one is definitely in the pyloric part beta. ठीक है. This pyloric ulcer can also be a duodenal ulcer beta. It can also be in the duodenum as well. ठीक है. तो याद रखना है basically either it can be a pyloric ulcer or it can be a duodenal ulcer beta along with a ulcer in the proximal part. Next important beta is type 2. Type 3 now. Type 3 which is there beta, type 3 ulcer is basically in the pre-pyloric region. Type 3 ulcer which is there beta, it is in the pre-pyloric region basically. ठीक है. तो type 3 ulcer is in the pre-pyloric region beta. And type 4 ulcer which is there beta, this type 4 ulcer is usually seen in the body of the stomach. ऊपर है बहुत. ठीक है. So type 4 ulcer which is there beta, it is usually seen in the body of the stomach. So type 1 is along the lesser curvature anywhere. Type 2 which is there, it is usually a duodenal and a gastric ulcer. उसमें it is mainly duodenal or pyloric ulcer, and second is in the proximal part. Type 3 is a pre-pyloric ulcer and type 4 is a ulcer in the body. And last one which is there beta, it is type 5 basically. So type 5 बस इतना याद रख लेना बेटा. For example, if this is a if this is the patient stomach beta, तो याद रख लो, type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 का जो ulcer होता है, it will be seen over here. ठीक है. So type 5 मतलब डिफ्यूज अल्सर होता है बेटा, ठीक है। तो टाइप 5 का जो अल्सर होगा डेफिनेटली दैट टाइप 5 अल्सर इज एक्चुअली गोइंग टू बी अ डिफ्यूज अल्सर बेटा। एंड याद रखना द टाइप 5 का जो अल्सर होता है द डिफ्यूज गैस्ट्रिक अल्सर, इट इज बेसिकली एसोसिएटेड विद इनटेक ऑफ एनएसएड्स बेटा। याद रखना द टाइप 5 और द डिफ्यूज गैस्ट्रिक अल्सर is usually associated with the intake of NSAIDs. That has to be remembered. No issues with this, anybody? Chalo. Next important beta, if I talk about what is going to be the first line management beta when the patient comes to us. If they ask you what is going to be the first line management when this patient is going to come to us beta, obviously beta we know that in a case of peptic ulcer disease a lot of risk factors are there, and all those risk factors which are there, most of them are modifiable beta. So definitely beta the first line treatment in a case of peptic ulcer disease has to be lifestyle modifications which the most important treatment beta first line management has to be lifestyle modifications. याद रखना the first line management in patient of peptic ulcer disease is lifestyle modifications. Now what are all the lifestyle modifications? The same lifestyle modifications beta that we have advised in a patient of gastroesophageal reflux disease or GERD, exactly same modifications will be advised over here beta. And what are those modifications beta? First is you have to do a weight loss, and for that regular exercise. You have to quit smoking and alcohol beta. Next you have to avoid any kind of fried, fatty and spicy food bache. Okay, you have to definitely avoid any kind of chocolates beta, usually dark chocolate. The patient has to avoid tea and coffee because it has caffeine and tannins. The patient has to avoid citrusy fruits beta and carbonated drinks like thumbs up and cola. The patient has to take small and frequent meals, not large meals at a time. The patient has to take the last meal of the dinner at least 2 hours before going to sleep beta. Okay, so that is important to be remembered. If they ask you beta what is the drug of choice or the treatment of choice in the patient, तो याद रखना है the drug of choice or the treatment of choice in my patient is going to be nothing else but वही, that is nothing else but proton pump inhibitors beta. Yes, so please remember beta proton pump inhibitors are going to be considered as the drug of choice or the treatment of choice for a peptic ulcer disease case. Okay, so that has to be remembered. Along with that beta you could give antacids, but do not give antacids and PPS together. कोई logic नहीं है उसका, ठीक है। तो please remember beta that antacids which are there, they're usually given only during the acute flares. That means now the patient is having a lot of reflux, or the patient is having a lot of epigastric pain. Immediately for the relief beta you can give antacid. Okay, but for the long term management you have to give proton pump inhibitors itself. Okay, chalo, that's it. Next important is definitely beta the differences between a gastric ulcer and a duodenal ulcer. Let's talk about them now. We have to remember beta the differences between both of them now. See, if I talk about beta, the gastric ulcer and duodenal ulcer, out of them, which one is more common? We have already discussed beta that the duodenal ulcer which is there beta, it is going to be much more common. First point. Now, if they ask you beta that which is the most common site for these ulcers, तो याद रखना है the most common site for a gastric ulcer beta, it is where exactly the most common site for a gastric ulcer is along the lesser curvature beta. Yes. Please remember the most common site for a gastric ulcer is basically along the lesser curvature. Exactly where on the lesser curvature beta? Understand. For example beta, this is the lesser curvature na. So can you see this point over here? This point where there is an incisura angularis beta. At this incisura angularis basically that this is the most common site. In which part of the stomach? The antrum of the stomach beta. Clear hai baat? So yaad rakhna hai beta that the most common site for a gastric ulcer is along the lesser curvature beta, near along the lesser curvature near incisura angularis beta. Near the incisura angularis. And which part of the stomach is it? As I've told you, it is nothing else but the antrum of the stomach. We know beta duodenum mein, it is very easy. Duodenum mein the ulcer, there are 4 parts of the duodenum, D1 to D4. So please remember the most important site or the most common site beta for the duodenal ulcer is the first part of duodenum. Reason beta yaad rakhna, the duodenal ulcers are mainly due to excessive acid beta. We know that acid only comes in contact with the first part of the duodenum. After that beta, the duodenal secretions which are there, they mix with the food, and therefore the food becomes alkaline after this. Okay? So only the first part of duodenum is exposed to acid beta. That's the reason. Now if they ask you beta that in both the conditions, definitely what is going to be the leading complaint? We know beta in both the conditions, the main complaint of the patient is going to be epigastric pain beta. But the funda is beta, the epigastric pain which is there, it is going to be classical in both the conditions. Why? Because in patients of gastric ulcer beta, this epigastric pain which is there, it is usually seen beta immediately after meals. The epigastric pain which is there beta in a patient of gastric ulcer, definitely it is seen immediately after meals beta. Okay, within 30 minutes of meals beta, the patient is going to start, so the pain is going to start in the patient. Within the 30 minutes of meals beta, the patient is going to start. Whereas in case of duodenal ulcer beta, the pain which is there, it is usually seen 2 to 3 hours after meals. In duodenal ulcer beta, the pain which is there, it is usually seen 2 to 3 hours after meals beta. That has to be remembered. No issues with this. Important is beta, in patients of duodenal ulcer, as the pain usually starts 2 to 3 hours after meals beta, therefore we can even call the pain of duodenal ulcer as the hunger pain. The pain of duodenal ulcer which is there beta, it can also be referred to as the hunger pain. Next important, if they ask you the pain is relieved by what, so please remember beta, the pain of a gastric ulcer is going to be relieved by vomiting. The pain of a gastric ulcer is usually relieved by vomiting. The pain in the case of a duodenal ulcer beta, it is usually relieved by more food intake. Okay, the pain in duodenal ulcer beta, it is usually relieved by more food intake. If they ask you what will be the effect on weight, then obvious logic hai beta. If in gastric ulcer beta, the patient is going to do chronic vomiting itself, okay, therefore the patient is going to have weight loss. But in a duodenal ulcer beta, as the patient has relief with more food, the patient will keep on eating more and more food, and that's the reason there is weight gain. Next important beta is, in which socioeconomic class gastric and duodenal ulcers will be seen, poor or rich. याद रखना, gastric ulcers which are there beta, you can see the patient is having weight loss, मतलब पतला होगा patient बहुत, and definitely thin patients who are there beta, they are nothing else but poor. ठीक है, तो ऐसे you can remember. Second is definitely beta, duodenal ulcer is causing weight gain basically. मोटे patients कौन होते हैं? Definitely the rich people out there. Now, important is beta, this is not the logic, this is just to remember. The logic being, gastric ulcer which is there beta, it is mainly due to infections and immunocompromised status of the patient. That's the reason it is more common in the poor class beta. Whereas definitely the duodenal ulcers are mainly due to hypersecretion of acid, which usually happens beta after drinking carbonated beverages or usually after the junk food. Obviously that's the reason beta, they are more common in the rich class beta. Clear about? Next important if I talk about is the bleeding beta. So please remember, we know that bleeding is going to be the most common complication beta of a peptic ulcer disease. Yes, bleeding is going to be the most common complication of peptic ulcer disease. Now, bleeding will be more commonly seen in, so yaad rakhna beta, bleeding is more commonly seen in the bleeding is more commonly seen in the duodenal ulcer beta. And in the duodenal ulcer, when bleeding is seen, it is basically from which artery beta? The vessel that bleeds over here is going to be the gastroduodenal artery, which it is definitely the gastroduodenal artery which is going to bleed over here. That I've told you, it is also the most common artery to bleed in peptic ulcer disease. Next important beta, bleeding is going to be less commonly seen in gastric ulcers beta. And as bleeding is less common in gastric ulcers, okay. But in case if they ask you which is the most common vessel to bleed in gastric ulcer, the most common vessel to bleed in gastric ulcer, I've told you beta. Same in gastritis, same in malarious, known as the left gastric artery, because lesser curvature is supplied by the left gastric artery. Okay. Next important if I talk about beta, perforation. Perforation is definitely more common beta. Perforation is definitely going to be more common in gastric ulcer. Reason, we know that the gastric mucosa which is there beta, it is more sensitive. That is the reason beta, which ulcer will perforate first is going to be the gastric ulcer. Okay, the perforation is more common in the gastric ulcer. Next is surgery beta. We'll talk about basically, so yaad rakhna, the drug of choice or the treatment of choice. The first line management is lifestyle modification. Next, we have to go definitely beta. For what purpose? We have to go for the PPIs beta, which is a medical management. Then only we go for a surgery. Now, when we have to go for a surgery beta, please remember that what is done in the surgery is basically, in a case of a gastric ulcer beta, the surgery that we do here, whichever part of the stomach is having the ulcer, we have to cut out that part beta. That is called as gastrectomy, obviously a partial gastrectomy. And then whatever are the remaining parts beta, we have to join those parts. And joining is nothing else but anastomosis. So all the surgeries that we study in gastric ulcer now beta are basically based on this same thing beta, that is we have to do a gastrectomy with anastomosis beta. Okay, the logic behind all of these surgeries is going to be the same. If I talk about beta, the next one definitely, and that is the duodenal ulcer. In duodenal ulcer beta, the surgery that we do is basically called as a vagotomy. Now what we do in vagotomy beta, in vagotomy we basically cut the vagus nerve beta. Why? Because vagus nerve is the parasympathetic nerve of the GIT beta, and this vagus nerve is actually going to stimulate the parietal cells, and due to that stimulation the parietal cells are going to secrete the acid beta. That's the reason if you cut the vagus nerve itself beta, obviously the stimulation of parietal cells is going to stop and the secretion of acid is going to decrease. That is what you want in duodenal ulcers, right? So now let's talk about the surgeries for peptic ulcer disease, beta. The first ones, if I talk about beta, okay, the first is the surgery for peptic ulcer disease is for gastric ulcer. So let's talk about beta. The first will be the surgeries for your peptic ulcer disease. Mein first surgeries will be for gastric ulcer. Gastric ulcer surgeries, beta, I've already told you the main logic behind gastric ulcer surgery is we are going to do a partial gastrectomy. We are going to do a partial gastrectomy with an anastomosis. Now, what is that anastomosis going to be? Let's talk about that. What is that anastomosis going to be? Let's talk about that. Okay. Chalo. So the first condition which is there, beta. Done with this? The first one which is there, beta. Ab yahan dekho, beta, as I told you, the most common site for a gastric ulcer is going to be the antrum itself, beta. So what we have to do in this condition, as you can see, definitely we are going to cut the distal part of the stomach, beta. We have to cut the antrum of the stomach. Now, as you're going to cut the antrum of the stomach or the distal part of stomach, now what is left behind? Some part of stomach is left behind and the duodenum is left behind. So we should connect what, beta? We should definitely connect this part of the stomach to the duodenum. So when you will connect the stomach to the duodenum, beta, okay, this anastomosis which is there, this anastomosis that you have done, beta, is called as a gastroduodenal anastomosis, bache, right? So this surgery which is there, beta, it is called as Billroth 1. So what we have done in Billroth 1? In Billroth 1, beta, we have done a gastrectomy. Along with the gastrectomy, beta, we have done a, okay, we have done a gastrectomy with which anastomosis? A gastroduodenal anastomosis. And can I call gastroduodenal anastomosis as a gastroduodenostomy? Yes, beta. So it is nothing else but a gastroduodenostomy, beta. The first surgery that we are able to see, beta, is nothing else but a partial gastrectomy with a gastroduodenostomy. That is known as Billroth 1 surgery, bache. That is known as a Billroth 1 surgery. Next important, if I talk about, beta, is a surgery definitely. Yahan pe kya hota hai with the problem? Now the problem in the second surgery is try to understand basically what is the problem in the second surgery. Basically here we had to cut out the maximum part of the stomach. Now as you can see, beta, as we have cut out the maximum part of the stomach, definitely can I definitely join the duodenum directly to the stomach now? No, because there is difference in the diameter. Na? This stomach is very broad and this duodenum is very small. So I cannot go for an end-to-end anastomosis, beta. End-to-end anastomosis is not possible. So what we have to do? We have to go for an end to side anastomosis, bache. Okay. So what we have to do? We have to pull up the duodenum and we have to do a end to side anastomosis. But I hope all of you are quite aware that duodenum is fixed. Duodenum cannot move. ठीक है, तो मैं हमेशा बोलता बेटा abdomen में दो दोस्त होते तुम्हारे, that you have to remember. One friend of yours is one beta that who never comes outside. He never steps out of his room, beta. तुम कहीं भी बोलो, he is never going to come outside. That person in the abdomen is duodenum, beta. He never goes outside. Another person, another friend of yours, beta, he will assist you everywhere. He will come with you anywhere, beta, to take milk, to buy milk, to go for a walk. Okay, on even honeymoon, beta, that patient will be with you. So that definitely, that person or that friend of yours is going to be your jejunum, beta. वो जो jejunum होता है, that is very very free. वेला दोस्त है तुम्हारा. So wherever you need definitely, beta, someone to join, you can pull up your jejunum. ठीक है? So here we do the same thing, beta. As I cannot pull up the duodenum, beta, what we do basically, we pull up the jejunum of the patient, beta, and we are actually going to connect the jejunum over here. Clear? And this surgery which is there, beta, where we do not go for a gastroduodenal but rather a gastrojejunal anastomosis, is what is called as the Billroth 2 surgery, beta. Clear? Samjhe baat? So this surgery, as you are able to see, beta, what we have done, we have pulled up the jejunum, beta, and we have just connected the jejunum with the stomach. Okay? So duodenum को क्या कर दिया? This end of the duodenum we have closed. We have formed a stump out of it. ठीक है? So this is what is called as a Billroth 2 surgery, which is what we have done in the Billroth 2 surgery. You have to remember, Billroth 2 surgery में we actually have done, okay, Billroth 2 surgery में we have done a gastrectomy, beta, and along with gastrectomy, बच्चे, okay, along with a gastrectomy, definitely we have done a gastrojejunostomy, beta. We have done a gastrojejunostomy or a gastrojejunal anastomosis. Hopefully that's clear to all of you now. Okay. Now the problem is what, beta, with this gastrojejunal anastomosis? Basically, the problem with this gastrojejunal anastomosis, beta, is nothing else but this, that here the food which is there, beta, it has to come upwards. Okay. the food or the bile which is there, definitely beta. See here you can have a one problem beta. We know that the bile which is there or the pancreatic juice which is there beta, it comes into the second part of duodenum. Now problem is what beta, that this bile or the pancreatic juice which is going to come in the second part of the duodenum beta, how it is going to mix with food? For that beta it has to go anti-gravity. So most of the times beta that is not possible in this surgery. Most of the times beta the mixing of bile pancreatic juices does not happen properly with the food, and that's the reason definitely the patient may have malabsorption beta. That is a problem with a Bilrod 2 surgery beta, that the patient can definitely have higher chances of malabsorption over here. Okay, so due to that beta, what we have done, we have come up with a new surgery beta, and in this new surgery what we do now, understand, in this new surgery beta, we rather than pulling up the jejunum directly, what we do over here, we actually cut out the jejunum first beta. Yes, we will cut out the jejunum. Now I am going to pull the jejunum up, and then we are going to connect it beta. Clear about? So here you can see definitely we have cut the jejunum over here beta. We have pulled the jejunum above, and now once we have pulled the jejunum above beta, now we are definitely going for a gastro jejunal anastomosis beta, or a gastrojejunectomy. End to side we have done again. So end to side gastrojejunal anastomosis we have done. Okay, this end we are close, this end of the duodenum we are closing. And now important is beta, we know that definitely what we have to do, we actually want beta the bile and the pancreatic juices which are coming in the second part of duodenum, that to also mix with food, because if bile and pancreatic juices are not going to mix up with food beta, obviously the problem can be what? The problem can be definitely beta this mixture with the fats which are there or the carbohydrates which are there beta, they will not get absorbed, there will be malabsorption. That's the reason beta we have to connect the remaining part of the jejunum this remaining part of the jejunum to this jejunum which is coming from above. So in this surgery beta, can you see this extra limb is created basically? This extra limb is created. This extra limb which is there is called as a Roux-en-Y limb. Okay, this is definitely called as a Roux-en-Y limb beta. And yaad rakhna, in Roux-en-Y surgeries definitely there are how many anastomoses? There is not one beta but rather two anastomoses. Baki dono Bilrod surgeries mein there was only one anastomosis beta. In this surgery definitely there will be how many anastomoses or connections? There will be two anastomoses or connections, and that is known as the Roux-en-Y surgery. So Roux-en-Y surgery beta we are able to do over here. So this Roux-en-Y surgery is classically called as the Roux-en-Y gastrojejunectomy. So main surgery is what? Gastrojejunectomy only, na? Then we also do a jejunectomy over here. Okay. So please remember beta, this surgery which is there is known as a Roux-en-Y gastrojejunectomy. Okay, this surgery is known as a Roux-en-Y gastrojejunectomy. Here the problems of drainage beta are not going to happen basically. Clear about? Chalo. Next important, if I talk about beta, done with all of this, these are the three types of surgeries that we do for a gastric ulcer. Done with all of this. Chalo. Next important, if I talk about, is the surgery for the duodenal ulcer beta. Now if I talk about the surgery for a duodenal ulcer bache, this is important to be remembered. So the surgery for the duodenal ulcer is nothing else but vagotomy beta. There are various types of vagotomy we have to talk about now. As I told you, what is the logic behind vagotomy? As you will cut the vagus nerve beta, obviously the nerve supply to the parietal cells will be gone, and the secretion of acid which is there beta, it is going to decrease. Now the first type of vagotomy which is there, it is the truncal vagotomy. Ab do baatein yaad rakhni beta. First of all, this blue color nerve that is coming from above na, this is nothing else but your left vagus nerve beta. Yaad rakhna hai, the blue nerve which is there beta, it is the left vagus nerve. Now this branch of the left vagus which is there beta, this branch that of the left vagus which is there beta, this is basically called as the anterior nerve of Latarjet. Okay, this branch of the vagus which is coming beta and supplying the stomach is known as the anterior nerve of Latarjet beta. Whereas these branches which are coming beta, they are supplying the parietal cells. These branches of the left vagus which are coming now, they are basically supplying the parietal cells beta over here in the body of stomach. But can you see that this anterior nerve of Latarjet or the left vagus also gives some nerve supply to the pylorus beta? It also gives some nerve supply to the pylorus as well. That has to be remembered. Apart from that beta, the green one that I am drawing beta, basically this green one which is there is nothing else but your right vagus nerve. This green one which is there beta, the right vagus nerve basically is going to give some branches beta to the pylorus also, and it will also give beta some branch to the gallbladder as well. So jo right vagus hogi na, it gives one branch to the gallbladder which is responsible for the contractility of the gallbladder, and second it gives some branches which to the pylorus as well, beta. It gives some branches to the pylorus also. Now, important is to be remembered, beta. See, in truncal vagotomy, what we do? In truncal vagotomy, beta, we cut the main trunk of the vagus. Yes, here we cut the main trunk of the vagus. As you are going to cut the main trunk of the vagus, beta, what is the problem? Okay, the nerve supply to the right vagus as well as the left vagus, both is gone, beta. The nerve supply to the right as well as the left vagus is gone. Ab yaad rakhna, beta. As the nerve supply to the left vagus is gone, obviously the nerve supply to the anterior nerve of latarjet is also gone, and as the nerve supply to the anterior nerve of latarjet is gone, beta, even the nerve supply to all these parietal cells is gone. And if the nerve supply to all these parietal cells is gone, obviously the parietal cells will not be stimulated, and therefore, beta, there will be decreased secretion of HCl, or there will be decreased secretion of acid. That has to be remembered. So this is a good thing. Problem is what, beta? As you have cut the main trunk itself, okay, the nerve supply to the left vagus is completely lost. So even, beta, the branches which were supplying the pylorus, they are also not receiving nerve supply. Okay, both even the right vagus branches and the left vagus branches which were supplying the pylorus, beta, they are not receiving the nerve supply. As the pylorus is not receiving the nerve supply itself, beta, obviously will there be any peristalsis in the pylorus? No, all the peristalsis in the pylorus will stop. And please remember, beta, agar pylorus mein peristalsis nahi hoga, if there is no pyloric peristalsis, will the food go from stomach into the duodenum? No. Okay, so the food which is there, beta, it does not properly drain into the stomach, sorry, from the stomach into the duodenum. Reason, you can see it is anti-gravity. Okay, it cannot go directly. It needs a proper peristalsis, beta, over here. So as there is no peristalsis over here, beta, definitely due to this condition, what is going to happen? The gastric emptying will get affected, beta. There will be a impaired gastric emptying which will be there. Okay, the food will not go from stomach into the duodenum. So in this surgery, beta, this is a major problem, that the gastric emptying of the patient which is there, beta, it gets affected. Now, if you want to correct this, so you have to do one thing, beta, that in truncal vagotomy, always do one thing, that is straighten up the pylorus of the patient. Reason is, if you straighten up the pylorus, beta, now what is the reason? So here definitely we don't need the nerve supply itself. Why? Because due to gravity, beta, the food can directly go now from the stomach into the duodenum. So rather than that angle, beta, you have to just straighten up the pylorus over here, beta, along with the truncal vagotomy. So this is the important thing to be remembered, that whenever we will perform a truncal vagotomy, beta, we always have to go for a drainage operation, and that drainage operation is known as a pyloroplasty, where we try to straighten up the pylorus of the patient. Clear? Eh? That is one thing. Second important, beta, here the nerve supply not only to the pylorus is also lost, even the nerve supply to the gallbladder will be gone, beta. And if the nerve supply to the gallbladder is gone, the gallbladder is not able to contract, bache. And as the gallbladder is not able to contract, there is stasis of bile inside the gallbladder. Yes, the bile will stay collected in the gallbladder, beta, for a longer duration of time. And if there is going to be stasis of bile, beta, there will be increased risk of gallstone formation. Okay, so these are the problems. One is impaired gastric emptying, beta, for which we do a pyloroplasty, and second is definitely, beta, increased risk of gallstone formation in truncal vagotomy. Okay, then we thought we should come up definitely, beta, with a new kind of surgery, and we came up with a selective vagotomy. Now here you are able to see, beta, what we do in a selective vagotomy. In selective vagotomy, beta, we do not cut the main trunk of the vagus. Rather, we only cut, beta, the anterior nerve of latarjet. Yes, we only cut basically the anterior nerve of latarjet which is there. Na? We are only going to cut the nerve supply of the anterior nerve of latarjet. But problem kya hai, beta? As you cut the nerve supply of the left vagus branch, that is the anterior nerve of latarjet. Yes, here definitely, beta, the nerve supply to the parietal cells is lost, and that's the reason the HCl secretion in the patient is going to decrease. But the problem is, beta, even the nerve supply of the pylorus is decreasing over here. Yes, you will be saying, so yes, still there are some branches which are supplying the pylorus. Yes, so there are few branches, beta, which are still supplying the pylorus, and that's the reason, beta, the gastric emptying which is there, it is not completely lost. Yes, there will be gastric emptying, it may be decreased somewhat. Okay, there is an impaired gastric emptying which is there, but still the chances are quite lesser as compared to a truncal vagotomy. Wahan pe to definitely there was no gastric emptying happening. Okay, that is important. Now important is, beta, this one over here, and this is what is called as a highly selective vagotomy. Isme to bilkul hi problem nahi hoga. Reason, beta, we are not even cutting the anterior nerve of latarjet. So what are we doing? We are only cutting the branches of the anterior nerve of latarjet, beta, which are supplying the parietal cells. As we only cut those specific branches, beta, which are supplying the parietal cells over here. So obviously the parietal cells will not receive nerve supply, and therefore there will be decreased HCl secretion. First thing. The problem is what, beta? The problem over here, it is going to be that in this condition, yaad rakhna beta, here there will be a very high chance of recurrence. Reason beta, as the main nerve is still there beta, as this main nerves are still there, therefore from that main nerve beta, there is another nerve which grows beta, and this nerve is actually called as the criminal nerve of Grassi. This is actually responsible for the recurrence in the patient. There is another nerve beta known as criminal nerve of Grassi beta, which grows basically again and it starts supplying the parietal cells, and this is actually responsible for the recurrence. So now if they ask you, you are going to answer few questions beta. First question is going to be, which type of vagotomy will have highest chance of recurrence? कौन से में सबसे ज्यादा chance of recurrence होगा? Please tell me in the chat box जल्दी से. Which type of vagotomy will have highest chance of recurrence? Anybody? बोलो. So please remember beta, the highest chance of recurrence which is there, it is usually seen in very good, highly selective. Yes, the highest chance of recurrence will be seen in highly selective beta. Which chance of which type of surgery beta will have lowest chance of recurrence? Which type of surgery will have lowest chance of recurrence beta? Which surgery is going to have lowest chance of recurrence? Lowest, least recurrence rate है, सबसे कम recurrence rate. Truncal, very good. Truncal में तो you are cutting everything ना. So truncal में there will be least chance of recurrence. Okay. So truncal में there is least chance of recurrence, but the problem is basically those other things beta. Okay. That all the other problems which are associated. Very good. Shabash. So please remember beta, याद रखना. So duodenal ulcers में we know beta, the surgery that we do is known as a vagotomy. याद रखना, vagotomy in duodenal ulcers is only done if there is a case of recurrent ulcers beta. Yes. So please remember why. याद रखना, the treatment of choice for duodenal ulcers is PPI. Majority patients of duodenal ulcers beta only show improvement with PPI or proton pump inhibitors. Vagotomy is very rarely required, and it is only required in patients of recurrent duodenal ulcers, only in those cases. Okay, so that is important. Now if they ask you beta, the first one is a truncal vagotomy. I have told you, and truncal vagotomy bache, we have discussed basically that we always need beta what? Here definitely there will be least recurrence rate. In truncal vagotomy beta, there will be a least recurrence rate basically. But the problem is here we need an extra surgery for the gastric emptying purpose. And what is that drainage operation called? As I told you, here pyloroplasty is required. Pyloroplasty is required over here. We have to go for a pyloroplasty. Next important beta is highly selective vagotomy. If I talk about a highly selective vagotomy beta, so please remember, highly selective vagotomy mein, there will be a highest chance of recurrence. In highly selective vagotomy beta, there will be highest recurrence rates. Okay, though it is definitely having like good outcome basically, but the problem is the recurrence rate is very high. There are no complications as such, but the recurrence rate is very high. Okay, selective vagotomy can also be done, but selective vagotomy still will have some chances of impaired gastric emptying beta. Okay. No issues with this, anybody? Hopefully this is done. Now, if they ask you definitely beta, that what are the complications of these surgeries? That has been a very common question beta. Complications of peptic ulcer surgeries. Done with this? If they ask you beta, complications of peptic ulcer surgeries now. Let's talk about them. First one which is there beta, it is a duodenal stump blowout, right? In Billroth surgeries beta, you might have seen, okay, or even in Roux-en-Y surgery. In all these surgeries beta, in Billroth 2 or in Roux-en-Y, what we have done, we have sutured the proximal end of duodenum na, and that is called as a duodenal stump. So ये जो duodenal stump है बेटा वो फट सकता है. Okay, the duodenal stump sutures which are there beta, those can break basically, and that is called as a duodenal stump blowout. Now the previous year question in your exam was that this duodenal stump blowout will commonly happen on which post-operative day. So याद रखना, maximum chances of the duodenal stump blowout which is there beta, it will be seen on post-operative day 4. Maximum chances of duodenal stump blowout beta is usually seen on post-op day 4. Next important beta, the patient will have a gastric stasis. I've told you that in cases of truncal vagotomy or selective vagotomy beta, as the branches which are supplying the pylorus, those get cut beta. That's the reason definitely there is no supply to the pyloric muscles. So therefore there will be no peristalsis in the pyloric muscles, which will affect the gastric emptying, and therefore the food will stay collected in the stomach itself, leading to gastric stasis. Next beta, as the nerves are getting injured over here, the patient can either have a increased motility or decreased motility after the surgery beta. Okay, दोनों हो सकता है due to the other nerve injuries. ठीक है, so the patient may have a post vagotomy diarrhea. Either the patient may have a post vagotomy diarrhea, or the patient may have beta a post vagotomy atonia also beta. That is, the muscle tone will be lost as well. Okay, either there can be diarrhea or there can be atonia beta. Both the things can be seen. Apart from that beta, the patient will have increased risk of gallstones. As I've told you, in cases of truncal vagotomy beta, you are also cutting the nerve supply of the gallbladder. That's the reason the gallbladder is not able to contract. There is stasis of bile in the bladder, gallbladder, and that's the reason there will be increased risk of gallstones. Next, the patient is also going to have nutritional deficiencies beta. Now the question is, which is the most common nutritional deficiency after a peptic ulcer surgeries? Now, whether you definitely go for beta a gastrectomy surgery, or whether you definitely go for a vagotomy surgery, in all these conditions beta, the acid secretion from the stomach is going to decrease, and as the acid secretion decreases, we know which nutrient requires an acidic medium for absorption: iron. So the most common nutritional deficiency beta in the patient, the most common nutritional deficiency beta is going to be iron deficiency. This has been a very common question beta, याद रखना ये बात. Whereas beta, second vitamin which is going to have decreased deficiency beta is going to be vitamin B12. Reason, because if parietal cells are damaged beta, or parietal cells का nerve supply has been cut off, even intrinsic factor of Castle will not be secreted, and if intrinsic factor of Castle is not there beta, even vitamin B12 will not get absorbed. So there will be most commonly iron deficiency followed by vitamin B12 deficiency beta. That has to be remembered. Now another complication of peptic ulcer surgery beta, that is easy to remember, do not get confused, and that is understand. So please remember beta, see, for example, this is the stomach beta, okay, and this is definitely the jejunum we have connected. So we are talking here about the this is basically a Bill-Rod 2 surgery beta we are talking about. Okay, so this is the Bill-Rod 2 surgery we are talking about beta. Now normally मुझे ये बताओ definitely beta, in a patient, normally when in a normal person beta, whenever you eat the food beta, obviously the food stays inside the stomach for some time, and then slowly it is released into the intestine beta, right? So the intestine or the jejunum which is there beta, it is used to receive which kind of food beta? First, it is used to receive less amounts of food. Okay. Second, it is used to receive diluted food beta. Jejunum or the intestines will have never got beta the concentrated food ever in life, because before the food goes to the jejunum, it would have mixed with a lot of water and fluid, and that is the reason the food becomes diluted until it reaches the jejunum. Now what is going to be the problem over here? Understand. Here after the surgery beta, two advices you always give to the patient. First is that do not take large quantities of meal at the same time. ठीक है, एक बार में ज्यादा खाना मत खाओ. Do not take large quantities of food at one time. Second important, avoid any sugar rich foods beta. Yes, any sugary foods beta, something like thumbs up basically, right? So all these sugary foods which are there beta, those should be avoided basically. ठीक है, if you are going to take a sugar rich food, what is going to happen? Understand beta. If you are going to take a sugar rich food मतलब highly concentrated food beta, बराबर है. Now when you take this highly concentrated food beta, all that concentrated food immediately goes into the jejunum of the patient. Okay, so please remember, normally I told you beta, jejunum will never handle any kind of a highly concentrated food, but here you are giving a highly concentrated food into the jejunum directly. ठीक है, you are directly giving beta a highly concentrated food into the jejunum. So what the jejunum will do definitely now, the jejunum will try to dilute this food beta, and for diluting this food, it will bring in a lot of water now. Okay, to dilute this food beta, it is actually going to bring in a lot of water. So there will be excessive amounts of water beta which will come into the jejunum now to dilute this food. And where is the jejunum? It is connected to the stomach. That means it is in the epigastrium. So beta, as a lot of fluid, as a lot of water suddenly comes into the patient's jejunum beta, the patient immediately starts getting what? An epigastric fullness, pain, bloating, nausea, vomiting like symptoms beta. So as the patient takes large quantities of food, or as patient takes a sugar rich food beta, immediately within a span of 30 minutes itself beta, okay, within a span of 15 to 30 minutes, okay, so 15 से 30 मिनट के अंदर या 10 से 15 मिनट के बाद, okay, whatever you say, So usually after 10 to 15 minutes of food intake beta, the patient will immediately start getting the symptoms of epigastric fullness, bloating, nausea, vomiting, all these features beta. This condition is classically called as the early dumping syndrome. This is what is called as the early dumping syndrome. The food has been dumped directly into the intestine. Na? This is a classical picture of a early dumping syndrome. Clear about? Next important beta, now understand. Here what happens beta, as there was a sugar rich food has come into the intestine. So initially that sugar rich food was absorbed, and suddenly the blood glucose levels of the patient which was there beta, suddenly the blood glucose levels of the patient which were there beta, they have basically increased. Okay, suddenly the blood glucose levels of the patient beta, they have suddenly increased basically because we have taken a sugar rich food, barabar hai? And as the sugar rich food was taken and the blood glucose levels have spiked up beta, immediately the pancreas will start releasing what? Immediately beta, the pancreas will start releasing insulin. So immediately beta, the pancreas started releasing insulin. So insulin secretion also increased. Now what happens? The pancreas have released this insulin beta. The insulin is going to be high for some time. But problem is beta, now the blood glucose will not be high. Reason is initially the food which came into the intestine beta, that got absorbed and therefore the blood glucose levels of the patient increased. But now we know immediately after that what has come into the intestine, a lot of fluid, a lot of water has come into the intestine, and therefore all this water will take the food along with it beta. ये जो पानी जो intestine में आया था ना वो उस खाने को अपने साथ बाहर ले जाएगा. So as definitely beta, that water will take away the food along with it. Will there be a proper and a complete absorption of that sugar rich food? No, there will not be a complete absorption or a proper absorption of that sugar rich food. Due to that, what is going to happen? The blood glucose levels are not going to increase further beta. So up now, initially beta, when the blood glucose levels are high, insulin is actually having some work. Insulin is trying to bring back that blood glucose levels to normal. But after that beta, now the blood glucose levels are not increasing. So what will happen? Still the insulin is high, and as still the insulin is high beta, therefore now the patient is going to have rebound hypoglycemia, right? क्योंकि अब थोड़े टाइम बाद तो इंसुलिन के पास और कोई काम ही नहीं बचा है. Therefore the blood glucose levels will decrease further because initially the blood glucose was definitely high beta due to initial absorption of food, but after that the food has washed off from the intestine, and therefore beta, now the blood glucose levels are not rising further. But still as the insulin is high, therefore the patient is going to have a rebound hypoglycemia beta. This is what is called as the late dumping syndrome. This is classically called as the late dumping syndrome. Clear hai? Here what will happen beta? Usually after 45 minutes to 1 hour after food intake, usually after 45 minutes to 1 hour after food intake beta, my patient starts experiencing hypoglycemic symptoms like headache, dizziness, tachycardia, palpitations, sweating, all of them. Clear hai baat? Sure. So the complication of these surgeries beta could be a dumping syndrome also. If I talk about a dumping syndrome beta, yaad rakhna, early dumping syndrome which is there, it is nothing else but a rapid influx of fluid beta. It is nothing else but rapid influx of fluid in the bowel bache. Okay, it is rapid influx of fluid into the bowel due to which kind of food? Due to a hyperosmolar food beta. Okay, there is rapid influx of fluid or rapid influx of water into the intestine beta due to the hyperosmolar or the highly concentrated food, and that happens within 10 to 15 minutes of consumption, and the patient starts experiencing symptoms like epigastric fullness, bloating, nausea and vomiting beta. And here if the patient is going to take more food beta, what will happen? The patient's condition is going to worsen. So in a case of early dumping syndrome, if the patient takes more food, the patient's condition is surely going to worsen beta. This is a classical picture of a early dumping syndrome. So yaad rakhna, early dumping syndrome happens within 10 to 15 minutes or maximum 30 minutes after consumption of food beta, and the symptoms of the patient are going to be something like epigastric fullness, bloating, nausea and vomiting. Next important is the late dumping syndrome beta. If they say late dumping syndrome bache, here there is, now initially when you take a sugar rich food, there is a sudden rise in the blood sugar levels. Now initially there was a sudden rise in blood sugar levels. Due to that there was an increased and a sustained matlab for a longer duration of time, there was an increased and a sustained insulin release by the pancreas. Now but what happens after 45 minutes beta to 1 hour, basically after 45 minutes to 1 hour after the food intake or consumption, now definitely the insulin has started decreasing the blood glucose levels further, causing a rebound hypoglycemia beta. And due to that rebound hypoglycemia, the patient starts experiencing symptoms like headache, sweating. Okay, patient starts experiencing hypoglycemic symptoms like headache, sweating, dizziness, tachycardia. And if the patient goes for exercise now, Okay, if the patient usually goes for exercise, the patient's condition is going to worsen. So yaad rakhna, the late dumping syndrome which is there beta, it usually further worsens with exercise, because if he does exercise beta, there will be more severe hypoglycemia, and that's the reason the patient's condition is going to worsen over here. Clear about that is important beta. So late dumping syndrome usually happens after 45 minutes to 1 hour of consumption beta. First thing, the patient has all the problems due to rebound hypoglycemia. Okay, so these are the things. Now if they ask you beta, in a patient of early dumping or a late dumping syndrome, what should have been avoided? So what the patient should avoid beta, what is the advice that you should give after the surgery? As I told you beta, two things have to be avoided. First, the patient has to avoid sugar rich foods beta. The patient has to avoid any kind of sugar rich foods. And second, the patient has to avoid large meals beta. Right, the patient has to avoid sugar rich food. Second, the patient should avoid large meals. What the patient should take beta, what is advised? Patient should take small and frequent meals bache. Patient should usually take small frequent meals, right? That is important now, that should be taken by the patient. Next important beta, even after beta this, the symptoms of the patient persist. Even after this, the symptoms of the patient are going to persist. You can give octreotide to the patient. You can give octreotide to the patient. And even after that beta, if the symptoms of the patient persist, then we have to convert that Bilrod-2 surgery into, you have to convert to Ru-NY. But even if you convert to Ru-NY beta, this problem can be there. So at least tell him ki bhai, you have to follow these advices which are given to you. Okay? So if the symptoms persist even after this, so please remember octreotide will be given, and if octreotide also fails to work, then we have to convert it to Ru-NY surgery beta. And last point which is there, after that you can take a break, and that is nothing else but complications of peptic ulcer disease beta. If I talk about complications of peptic ulcer disease now, these were the complications of surgeries of peptic ulcer. Okay, the complications of peptic ulcer disease, if I talk about, is going to be the most common complication which is there beta. It is nothing else but, anybody, the most common complication I've told you, it is nothing else but bleeding beta. And please remember, bleeding more commonly happens from the posterior wall of the stomach or the duodenum beta. It more commonly happens from the posterior wall basically. And the most common vessel to bleed, I've discussed multiple times, the most common vessel to bleed beta is going to be the gastroduodenal artery. Next important beta is the perforation. Yaad rakhna, perforation I've already told you, it is more common with gastric ulcer, and perforation more commonly happens from the anterior wall. As the perforation happens from the anterior wall beta, that's the reason the patient is going to have an increased risk of peritonitis beta. Okay, if there is perforation of the peptic ulcer, I've told you the patient will have a peritonitis. Hollow viscous perforation, one of the reasons was what? Peptic ulcer disease. So peptic ulcers may perforate beta, causing peritonitis in the patient. Okay. So then we have to take up the patient for basic resuscitation if required. Then definitive surgery is exploratory laparotomy with peritoneal lavage. Okay, with or without repair of the perforation. If the patient has presented to us early, then we can go for immediate repair beta, and we have to do what? A Graham's or mental patch repair. If the patient has presented to us late, then we have to just leave a drain beta and we have to go for a delayed repair. Clear about that is important. Next important beta, if the patient is going to have stenosis of the peptic ulcer beta, due to stenosis is narrowing. So peptic ulcers are going to heal with fibrosis, and due to that there will be stenosis in the stomach beta. And due to that the patient will have a classical appearance of the stomach bache, that is classically called as the teapot stomach. There will be a classical appearance of stomach known as the teapot stomach. That is important. So all of these are the complications. I know the surgeries of peptic ulcers are somewhat complex. Their complications are difficult to remember, but at least try to remember beta the important things out of them. Okay, so it will be easier for you to appear in the exam. ठीक, याद रखना, early and late dumping syndrome से questions आते हैं. This is the most common question beta over here, this part. ठीक है, they usually ask the patient has undergone a surgery for peptic ulcer, what is the nutritional deficiency? So that has to be remembered. Usually apart from that, you have to remember which vagotomy has least and highest recurrence rate. After that, you have to just remember that Bilrod-1, Bilrod-2 and Ru-NY mein which anastomosis or which stomies were done basically. Okay? Then it will be easier to remember. No issues with this, anybody? Chalo. So let's take a lunch break, and after that we will talk about the gastric cancers and other types of stomach disorders further.